Good morning, everyone. On behalf of the organizing committee, I welcome you all to this August meeting of 10th Annual Conference of Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha, 2024. So, without any further delay, I request Dr. Sushant Mishra, who is also our scientific chairperson for this conference. He is already in the chair to chair this first session, and Professor Arun Chaudhary, our founder president, and Dr. Prithviraj Singh. All three are there in the chair to start the first session. Thank you.
Thank you very much. Good morning to all of you. And thanks to the organizing chairman and president of Aprasocon, taking the burden of hosting this conference on the 10th Annual Conference of Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha. In fact, the first conference was held in 2014, January 15th, in SV Medical College. Most of our alumni from that college. And since then, it is the 10th conference. So our backbone is the scientific programs. And today, we are little running late for the program. But anyway, with me, Dr. Prithviraj Singh and Professor Sushant Mishra is joining with me. And the first speaker will be Dr. Jayant Kumar Das, professor in plastic surgery at IMS and SOM Hospital, Bhubaneswar. So you have been allotted 15 minutes to talk about facial anatomy in relation to toxins. I also welcome the organizing team, Dr. Mulia and Dr. Nilamani, and delegates from SCB, Dr. Vishwajit Mishra and Rashmi from Berhampur, so, and Lakshmi from Apollo. So this shows our unity, in fact, that we congregate once in a year in the annual conference. So we have a lot of programs here. So whatever may be the situation, I think we have been, except this barring the COVID period, we have been sincerely doing these conferences and bi-monthly meetings. So I'm really, as a founder president, I'm really grateful and honored to be here at the first session. So now I talk about Dr. Jayant Das. It is your podium.
Very good morning to everyone. Thanks, Chairperson. Thanks, Sunil Bhai, Sushant, for giving me an opportunity to talk something this on botulinum toxin. As a plastic surgeon, we can do vascular anastomosis, but we are afraid of injecting botulinum toxin. So that is the precarious situation, and that is why the other specialties are there taking advantage of our fear of regarding the injecting botulinum toxin and the filler. So this is just a basic things to highlight. We should be very clear about the anatomy of the face so that we can inject at the right site to produce the maximum result, and which will be very satisfying for the patient. So first thing, it is not magic for the surgeon, not magic for the patient also, because we have to believe in science, we trust in science, we believe in logic. We have to inject things at right points to give good result. And we have to be very clear that it is not a permanent procedure. It is not an one-time procedure. So if you inject botulinum toxins, the result will start appearing within 1 week. Then it will last for 5 to 6 months only. So repeated sessions are required to have a sustained result. And we should proceed from basic things to advanced. So at present, the FDA approved use of botulinum toxin are only on the forehead and the frown line and the crow's feet. Other are off-level use, so we should be thorough in basic first, then we should proceed for advanced things. So just a brief physiological thing. It inhibits the release of acetylcholine at the neuromuscular junction. So muscle, there is a partial chemical denervation of the muscle. which will last for 5 to 6 months only. And again, you have to have a repeated session to produce the consistent result. So botulinum, we all call it as Botox, but it's the trade name or the pioneer brand of the allergen. So no financial disclosure here. So there are two types, botulinum toxin A and the botulinum toxin B. So there are three varieties of botulinum toxin A, onabotulinum, abobotulinum, then incobotulinum. So these are the different brands like Botox, Dysport and Xeomin. And botulinum toxin B, it is not available in India, and it is rimabotulinum toxin, myoblock, but it's, the injection is very painful, so it is not very popular also. So what are the indications of injecting botulinum toxin? The basic indications which are FDA approved are forehead lines, frown lines and crow's feet. And the advanced indications are like Bonnie's lines, gummy smile, perioral rhytids, then labiomental crease, dimpled chin, platysmal band, masseter hypertrophy for jaw reshaping, and nephritil like a band in the neck. So we should have a basic idea about the facial anatomy. So the muscles from the top, frontalis, it elevates the eyebrow, corrugator supercilii, it depresses the eyebrow medially, procerus also it depresses the eyebrow medially, orbicularis oris, the whole part is orbital closure, along with the lateral fibers, they depress the lateral brow side. Nasalis, it flares the nasalis nostrils. Then levator labii superior alecnazi, it elevates the upper lip. And orbicularis oris, the close the lip, and depressor angularis, it depresses the angle of the mouth. Mentalis, it elevates the lower lip, and the masseter, it elevates the mandible, and the platysma, it depresses all the facial muscles. So this, we should have an idea about the facial muscles. So I will tell one by one. The frontalis, I have told it is FDA approved, so we know. So it originates from the gallia paneurotica along the coronal suture and inserted in the dormis over the supraorbital ridge. And it interdigitates with the procerus and corrugator supercilii and the orbicularis oculi. So it lifts the eyebrow and the forehead skin, and it is responsible for forehead lines. So these are the points which are the sites for injection. And before injecting botulinum toxins, we should be very clear, and the treatment should be individualized. There is no blanket rule that will inject at the fixed point for all the patients. So you have to assess the pattern of the forehead lines like blind, single, stray line or apostrophe. So these are the various patterns of the forehead lines. And accordingly, you have to mark the points. Complications, if you have injected too low, then frontalis muscle will be paralyzed at the near the orbicularis oculi. There will be brow ptosis. Sometimes because of the unopposed lateral frontalis muscle action, there will be spoke brow. And if you have injected too much, there will be unnatural frozen appearance or mask-like face. Next is the corrugator supercilii and procerus. The corrugator supercilii is responsible for the vertical lines, frown lines, and the procerus is responsible for the horizontal lines. And again, the treatment you have to has to be individualized. You have to assess the pattern of the wrinkle at the frown line. Then you should inject the botulinum toxins. Same the complications, brow ptosis, if it has migrated into the frontalis, lower part of the frontalis, sometimes it migrates into the levator palpebrae superiorlis, causing lid ptosis, and if there is unopposed lateral frontalis activity, then spoke brow. Then the orbicularis oris, which is responsible for the crow's feet, and you have to inject it at 3 points. At 1 centimeter lateral to the lateral border of the orbit. And there are various patterns of the crow's feet like full fan, central or upper or lower. So you have to inject your botulinum toxin as per the patient. And the crow's feet, there are individual patient assessment must, because you have to inject at 3 points, 2 points or 1 point. It depends upon the pattern of the crow's feet. So complications, sometimes upper lid asymmetry, if it has migrated into the zygomaticus major or minor muscles, there will be elevation of the lip on one side. Sometimes cheek ptosis because of the high dose into the inferior medial portion, or dry eyes if high dose into the palpebral part of the orbicularis oculi blocking the lacrimal pump, lower eyelid ectropion if it has migrated into the palpebral part, or sometimes pseudo fat pad herniation if high dose into the medial part of the orbicularis oris muscle, which is responsible for fat pad support. Then nasalis muscle, which is responsible for Bonney's lines, there are two parts, one is transverse part and one is alar part. So you have to inject at 2 points for the transverse part and 3 points for the alar part of the nasalis muscle. So these are the various patterns of the Bonney's lines, and you should assess how the pattern, then you have to inject at different points. So complications, if you have accidentally injected into the levator labii superior alegnasi, then there will be elevation, asymmetry or ptosis of the upper lip, and you should be very careful while injecting the botulinum toxin for correction of the Bonney's line. So levator labii superior alegnasi, which is responsible for gummy smile. So there are two heads, one is medial head and the lateral head. And normally it elevates the upper lip and dilates the nostril. So if you will inject botulinum toxin into the levator labii superior alegnasi muscle, then gummy smile can be corrected. Again, it is temporary. There are different procedures by oral maxillofacial surgeon to correct it permanently. But being a plastic surgeon, we can correct it for a temporary period by injecting into the levator labii superior alegnasi muscle. Orbicularis oris, which is responsible for smoker's line, it helps in closing the mouth. So there are fine lines around the mouth. So botulinum toxin can be injected at different points to erase these lines. Another, there is a method, lip lift. Now it is very popular because of the Instagram. So there is a mild lift you can achieve by injecting at 2 points at the philtrum. So there will be partial paralysis of the orbicularis oris muscle and the upper lip will be elevated. Depressor anguli oris is responsible for the marionette lines and the depressed angle of mouth. So it will give a sad look to the patient, and we can inject botulinum toxin 1 centimeter lateral to the angle of mouth and 1 centimeter below it. So the depressor anguli oris paralyzed temporarily and the angle of mouth will be elevated, so it can erase the marionette lines or it can correct the depressed angle of the mouth. Mentalis is responsible for dimpled chin. We can inject at 2 points on 2 sides, so there will be temporary paralysis and there will be correction of the dimpled chin. So these are various patterns of dimpled chin, and you have to assess it individually and you have to mark it so that you can inject at 2 points or 4 points to erase this dimpled chin. So complications, if there is migration into the depressor anguli oris muscles during injecting mentalis muscles, so there will be depressed angle of mouth or asymmetrical smile. Masseter is an off-label use of Botox, but it is very popular to create a slim jawline. So we can inject at 3 points or 5 points at the masseter, at the lower border of the mandible, so that the masseter hypertrophy will be reduced and it will create a nice jawline and which has a very beautiful appearance. So platysma is responsible for different bands at the neck or sometimes necklace lines. We can inject botulinum toxin at low dose at different points, or if there is a clear-cut band, we can inject on the band also. So the neck band will be corrected, and it will correct also necklace lines also. So all the facial muscles of expression are supplied by all the branches of the facial nerve, except the muscle of mastication, which is supplied by the fifth nerve. So I will show one video how to mark the marking. So to reduce the forehead. Just a second. So these are the FDA approved.
Marking. So to reduce the forehead wrinkles, there are 5 points. But before marking the 5 points, you have to delineate the border. The first thing, ask the patient to clench. Clench ask the patient to clench. So this is the temporalis muscle, and this is the temporalis muscle, and you have to draw one line at the 1/3 junction of the forehead.
So
And
by
your
drawing this
Botox
line, you
injection
can
should be
avoid
at
the
5
migration of the
points.
botulinum toxin
Take a
to the
pull kale.
articular succulent muscle.
So this is the point 1, 2, 3, 4, 5. So this should be injected into the frontalis muscle, 4 units each. So it's approximately 20 units. Okay. Then your procerus muscle and the curvature supercilii. So again there are 5 points. Draw one line from the medial end of the eyebrow to the medial canthus, then medial end of the eyebrow to the medial canthus. So this is 1 point, and this is the curvature supercilii 2 points. So you have to inject 4 units each. So it is 20 units. So it will reduce the frown lines and the both horizontal and the vertical line. The third point is the crow's feet. So you have to inject at 3 points around 1 centimeter from the lateral border of the orbit, and 4 units in each point. Okay. So this is 4 into 3, 12, and this is 4 into 3, 12. So this is 12 plus 12, 24, 20, 20. So total 64 units of Botox will be injected to reduce the forehead lines, frown lines, both horizontal and vertical, and the crow's feet. Thank you.
So thank you. This is all about the basic anatomy related to toxin. Thank you.
He is getting a platform everywhere, in every meeting, even the national level. So I think all plastic surgeons now should be abreast with the recent developments, not only the applications of the aesthetic surgery. So any questions from the audience? Yeah, you can have the mic.
I have 2 questions. One is botulinum toxin. It's a toxin. When you are injecting, before that you are doing a skin test in all patients, or actually it's a toxin. It's a botulinum toxin, means sometimes it's
Sometimes
a
there will be
hypersensitivity
allergy.
reaction is there.
Right.
One patient may damage, will kill anybody's life also. Means it will damage the reputation of the doctors. So you do all the cases skin test or not doing it?
Yes, this was my last slide. I do skin sensitivity in all cases, number 1. I counsel the patient regarding the duration of the effect of the botulinum toxin and also the post-operative care. So patient should not do any heavy or strenuous activities after injection of the botulinum toxin, at least for 6 to 8 hours.
You do the skin test at the local site or in the...
Not on the hand or forearm, not on the local site.
Second question, compared to this, the botulinum toxin is relatively, means the 100 units is 18,000 to 20,000. Surgeon fees means almost equivalent to 25,000 rupees. What is your
25,000.
almost
On an average in Odisha, it is
if you will
20.
compare HIFU, HIFU means high
Right,
intensity
right,
ultrasound
right.
focus
Right.
ultrasound. The cost is relatively definitely minimal compared
Right.
to the buttocks.
Right.
So what is your take home to the message is the compared to the buttocks with the HIFU, which is your suggestion for the patient to do this one?
Right. So there are 3 things. One is number 1 botulinum toxin, second filler, third one is the HIFU. So both are different, all have different indications. So botulinum toxin is mainly used for dynamic wrinkles, which may not be corrected by HIFU. So all like where during the facial expression, so the wrinkle which is produced because of the muscle activity, that can be corrected with botulinum toxin only.
Thank you.
Thank you.
Any more question? Otherwise, I have a question. Then how frequent you have the second dose? Or for
So
the-
usually we advise to review the patient after 2 weeks for any touch-up procedure. Then the second review is after 6 months. The patient needs another session of botulinum toxin, we advise for
So you mean to say every
6 months to 7 months.
then he has to be
Right, sir.
repeated?
Right, sir.
Okay, hand over the mic to Dr.
I have also got some questions.
Sir.
So what precautions you take while injecting this botulinum toxin?
So first thing is that it should be freshly prepared normal saline. It should be from a new bottle. Okay. Second thing, the patient should not be in empty stomach. It has not been written, but there are certain side effects related. Third thing, we do all the skin sensitivity before injecting botulinum toxin. And after, before injecting, we apply numbing cream. So there are like Biveta or Prelox which are available. We apply numbing cream. Then after 10 minutes, we inject the botulinum toxin. And after the procedure, we advise the patient to avoid direct sun exposure and avoid strenuous activities, at least for 6 hours, almost for 24 hours. No need, no gymming, no heavy weight or lifting. Okay.
Thank you. One more, I want to know because I am not practicing, we are not doing, mostly we are in.
So that is why I have chosen this topic. So since we are not practicing, we are always, even I was afraid of this injecting botulinum toxins 4 years back. But again, we have to start it as early as possible so that other specialties, they are doing it randomly. So we have to be very active in injecting. So we can do it.
Okay. In case of fillers, no, we prefer to go more deeper than more deeper as
Yes.
deep as
So
possible.
botulinum toxin is our aim is to inject into the muscle. So while injecting in the forehead, it should be just below the skin. So because the forehead muscle is very superficial. Same is the crow's feet also. But while injecting into the corrugator supercilii, it should be injected deep into the muscle. And filler, it has a different site of injection. Most of the time, it is injected into the supraperiosteal part. Suppose from the like tear deformity. So it is injected to the supraperiosteal part, even to lift the nasolabial fold. So we inject at the zygomatic prominence, again supraperiosteal part.
Thank you, Professor Jain, for a
Thank you.
wonderful
Thank you.
presentation. Next, I call upon Dr. Lakshmikant Mishra, and his topic of presentation is nerve transfer in traumatic upper brachial plexus injury, his experience.
Respected chairpersons, dignitaries sitting on and off the table, and my respected juniors, today my topic is present on nerve transfer in traumatic upper brachial plexus injury, my experience in the field since last 10 years. Previously, I was not doing any brachial plexus repairs. When after the conference of Dr. Thates in 2015, I developed confidence to do these surgeries. So my experience since last 10 years. We know this anatomy of the brachial plexus. Its origin from C5 to T1 roots. Then it is divided into trunks, then division, then the cords. Mostly the lateral cord is the musculocutaneous nerves is there. Traumatic brachial plexus injuries are most commonly sustained in high motor vehicle accidents. See these two photographs. One is 1970 to 2000. Previously, the scooter, you used to drive these scooters. After 2000, you can see this high super bike started. The super bike started more after 2000 of this era. And when we start this super bike, just this is the video, you can see this video. Immediately when you start this video, means the super bike, it started 105, 106, 107, 108, up to 150. Immediately this, when the two-wheelers, those who are riding, they cannot control and sustain this high-grade type of injuries. Whereas previously when you use these two scooters, when you accelerate 60, more than 60 kilometers, it's maximally it go up to the 60 kilometers. 60 kilometers per hour. This was the difference. In present time you see, this is also added factor. When in the pillion driver will be a girlfriend, the speed will be definitely high compared to this one. In our times, 1980 to 2000, we used to this two-wheelers. When we accelerate up to more than 60, it doesn't cross more than 60. And the the incidence of the motor type means vehicle accidents like this brachial plexus injury, road traffic accidents are very minimal. And those who don't have two-wheelers, they used to travel by these rickshaws. This is the time. And the incidence, if you compare to previous one, means this after 2000 and before 2000, the incidence of the brachial plexus is definitely higher. If you go to the literature, the incidence is more after 2000. So on the basis of 18 years experience by Dr. Narakas, he developed a rule of the 770s. It's approximately 70% of the motor vehicle accidents. Out of motor vehicle accidents, 70% are the motorcycles or two-wheelers, bicycles. Of the cycle riders, 70% are multiple injuries, and out of the multiple injuries, supraclavicular injuries are more than 70%, and after of the supraclavicular injuries, 70% at least one root avulsed, and the avulsed root 70% are C5 or C6, C7, lower upper cords are there. 70% avulsed roots are chronic pain, they have chronic pains. So the incidents are common in closed injuries of the neck with a stretched hand, and mostly it is noticed in the male patients. You can see the patient, the two-wheelers with a helmet, but due to the outstretch of the hands and also the severe accident, C5, 6, 7 roots are affected. Many patients are 20 to 40 years of the age groups, and they were driving these two-wheelers. Apart from clinical examinations, other investigations are the MRI of the brachial plexus, nerve conduction studies. In my study, 8 patients are there, included upper brachial plexus, and they have presented to me 3 to 6 months of the injury. Both the shoulders and elbows are affected in the upper brachial plexus, so nerve transfer is preferred for the surgery. 8 patients were diagnosed as upper brachial plexus injury by clinical, MRI, and nerve conduction studies. For shoulder stabilization, patients were positioned prone, and preoperative markings for both spinal accessory nerves and the supraclavicular nerve, suprascapular nerve done. Incision placed, spinal accessory nerve and suprascapular nerve were identified. Both were stimulated by the nerve stimulator. Both nerves were coapted with tension-free and with 80 or 90 proline, and over that tissue glue was applied. After 1 month, I do in 2 stages the procedures. After 1 month, I do this another procedure for the elbow stabilization by overline procedures. Ulnar fascicles supplied to the FCU were coapted to the branches of the biceps or median nerve fascicles supplying to the FCR, FDS of the index finger to the bicep branch of the brachialis. Both are the musculocutaneous branches. This is the schematic diagram. The ulnar fascicles are the ulnar fascicles of this FCU is rotated and coapted with the musculocutaneous branch supplying to the biceps nerve. What is neurotization? Transfer working but less important motor nerve to the non-functioning motor important to the denervated muscles. You can see this is the ulnar nerve. So suppose this is a good nerve. From this, the nerve is the less dominating nerve is anastomos coapted with the branch to the muscle supplying to this denervated muscle to this one. This is neurotization. The upper brachial plexus injury, roots are C5, 6, 7, roots upper trunk, middle trunk, the cords are the lateral cords. The muscle supplied by the upper trunk is the nerve to subclavius, suprascapular nerve, supraspinatus, infraspinatus, lateral cord, musculocutaneous nerve, coracobrachialis, brachialis, biceps. Posterior cord, axillary nerve, deltoid. So my presentation, this is the video of one patient. This young boy, around age of around 25 years, he had this motor vehicle accident, and you can notice the left side is not able to flex properly and not able to abduct the arms, shoulder level, shoulder joints. Whereas the right side he is totally able to do, but they are not able to flex this elbow joint. So on the first stage, I did the surgery. did the first surgery in the posterior approach. Posterior approach is means ideally nowadays followed than the anterior approach, where the coaptation will be better as the denervated nerve is very nearer to the muscles. That's why posterior approaches nowadays people are following. And you did this nerve stimulation applied over this region, this affected part, and this is also spinal accessory nerve. So both the nerves. Then it is anastomosed with 8-0 rolling. This is for the overland procedures. Median nerve isolated and also musculocutaneous nerve supplying to the biceps identified. Median nerves, the fascicles is stimulated, supplying to this flexor carpi radialis is stimulated, and this flexor carpi radialis nerve is coapted with this median nerve, means musculocutaneous or biceps nerve. This is the final photograph after 1.5 years. He has sent the photograph with WhatsApp, through my WhatsApps. He is able to do the functions very nicely. He is a driver. Now he is driver in professions. He is able to do the functions. He can now driving the 4-wheelers very nicely. The disadvantage I have seen nowadays, there is a big scar we can notice here. Otherwise, the functional aspect, if you will see, is absolutely normal. This is a posterior scar is over the scapular regions. Another patient, the same 22 years male, he had the same, this one. Hand function is normal, elbow not able to flex, abduction totally absent. Presented to me around 4 months after the injury. He had history of previously, due to the injury of the scapular regions, he had developed this hypertrophic scar. So I told previous to the surgery there is chance of hypertrophy after the incision sites. We did the same procedures, both for the shoulder spinal accessory nerve to suprascapular nerve and the overland procedures for the sides. After 1.5 years, this is the finding. He is a LIC agent. Now he is happy. He is able to drive nicely. Now, this recent advances in the brachial plexus. I have seen in 2023 in the PEAT prize, Dr. Raja Tiwari from AIMS New Delhi, he has presented a robotic assisted nerve transfer for brachial plexus injury. It was a nice presentation. I have seen it is advantage is this scar is very minimal. We have in Apollo, there is a robotic instruments in Apollo. I have planning also to do in the futures to prevent a long scar, and the morbidity will be definitely less compared to this open surgery. So my conclusion is brachial plexus injury are common in young and male patients. Most are due to the road traffic accidents and from the two-wheelers. Better results of the nerve transfer noticed within 3 to 6 months of the injury. Upper brachial plexus injury results are comparatively better outcome than the lower and one brachial plexus injury. Thank you very much.
Thank you. I will say Lakshmi Bhai only.
Thank you.
for your wonderful presentation and also very good result. So now it is open for questions.
We have B-Bron, and there are two modes are there. One directly, there is a directly needle will be attached with one, and another is there. The tip is blunted, can apply also. Both the instruments are in Apollo. Okay. We have both the instruments are there. Specifically, I think the better one will be those, the anesthetists are using this nerve stimulator. That is definitely helpful. When you are touching directly over this nerve, without pressing over this nerve, just touching over the fascicles of this nerve, immediately it will stimulate. These are the impulse. Usually we start with a low dose, then gradually that will be increase. Suppose you will start from the 0.2 milliampere, then it can increase. Suppose it is not stimulated, then we can increase also 0.4, then 0.6, then maximum 1.5 to 2, 1.5 to 2 milliampere per.
Dr. Jiptes, you had a thesis on this. Can you have a question to him for the interest of everybody? Please, Mulya.
No, I do both the cases. Usually, previously, before this conference in 2015 by Dr. Thate, and before that, we used this nerve anastomosis with 80 or 90 prolin. But when he told that tissue glues are definitely useful, and tissue glues, this advantage of the tissue glue is the antibody formations and the phagocytosis of these suture materials sometimes causes damage to these nerves. And ultimately there is means the nerve coaptations and the nerve neurotization will be definitely delayed, and the fibrosis will be more compared to the sutures than the nerves, means the glue. Thank you, sir.
Did you have to do the Somsax transfer as well to get this kind of
Actually,
result?
sir, that is important. But I don't know. In that case, I got without doing any procedure for the triceps to the axillary nerve. But I got a good result. So I don't know. Means actually,
So which means, let two things come to my mind.
Sir.
If it is a complete avulsion of C5, C6, C7 roots, just by doing neurotization of supraspinatus, infraspinatus teres minor, you will not get an abduction beyond 90 degrees of shoulder. So you have to combine a Somsax transfer.
Yes, sir.
Which brings us to say that if you had good results, just by transfer of spinal axis to suprascapular, probably the other nerves were there, they were recovering. Sometimes it can happen. Only yesterday I saw a patient who was seen by most of the surgeons here who do brachial plexus surgery and was also booked for operation. He had even deposited fees, but then for some reason he did not get operated. So just about 4 months from the date of injury, and he has almost recovered everything, except that they are weak. So therefore, we have changed our time of surgery to well beyond 3 months of time for you to understand, because so many times even the nerve conduction studies and EMGs were done. A nerve conduction study showed complete loss of conduction, and the EMG showed fibrillatory potential, there is no reinnervation. But in spite of that, in close avulsions that we usually see, it's a good thing to wait. So you might even get some spontaneous activities in supraspinatus infrateres minor, and all that you have to do is go on doing lateral stimulation. So but otherwise, if it is a complete loss of 5, 6 and part of 7, to get this kind of abduction just by sand to suprascapular nerve is not possible.
I have gone through, sir, literature yesterday. I have seen, sir, up to 15 to 20 degree,
It's by the supraspinatus and supraspinatus muscles. That is, and before, after 20 to 90 degree by deltoid, and more than 90 by the serratus anterior and trapezius. Okay. But if you will do all the three, if it is preganglionic and all the roots are affected, then 3 nerves to be repair, like up to supraspinatus means spinal accessory to suprascapular for 20 degree, then branch of the triceps, a branch of the medial to the axillary up to deltoid. But here, sir, actually I thought the result was excellent after getting only doing this procedure. It may be a partial, whatever you have told postganglionic may be. Sir. I was planning to do the procedure, but by that time this result was so excellent, then I abandoned that procedure.
From the day one, you do all the 3 transfers. Nowadays, unless you have some compulsion, all these 3 should be done in once.
Thank you, sir.
Well, Lakshmi, your results are very good, but only my point is, now the trends with the persons who are doing in Ganga and Dr. Bhatia in Pune and all those people, their say is,
Triple transfer.
the why you not do what Dr. Jaina has really spoken about, what in one stage you cannot do it. And if it is possible, you can do it in the anterior.
Sir, main problem with this I have seen, sir, during the movement of the patients, we are suturing with 8090 sutures. Sometimes may dehiscence of the
That
this
is the
nerve.
point.
That's why I do these 2 surgeries, 1 month gap. First for the shoulder, then another for the elbow in the 2nd month stage. But for the betterment of the patient,
But I think
suppose there is a dehiscence,
you see,
we will lose the whole
posterior
procedure.
approach is meant for the patients who come off late, after 8 months or 9 months. Because of the ghost tube, you want to cut-short the regeneration of the nerve. Though we have a paper with Dr. Singh, 20 cases you presented in PGI Chandigarh.
Sir.
In that annual conference of 20 cases of posterior approach. But all those cases were in the late, not
Late
in the
means
early.
more than?
More than 9 to 10 months. Patient has come off late. But your case, they have come off very early. So once you find out the MRI findings, they are pre-ganglionic, and there are chances of less recovery. In that case, you can go earlier.
But
there
as
is
per
no
the
fixed time.
protocol, sir, we should wait for 3 months. After 3 months,
You
we
see, it is not a fixed
plan-
time. It all depends your evaluation of the clinical and also the MRI findings. Because you need to have at least 6 weeks to have the edema and everything subsides. Then only you can take a call on the decision making for taking up the case. It all depends on the merit of the case. I am not telling every case has to be done in one way. No protocol for every case. So I think that's the thing you have to keep in mind free to take a call on the particular merit of that case. And rightly, if you do an anterior approach, you can have all these 3 possible without that problem of posterior, then again you make it anterior.
Initially, sir, I did many
Anyway,
cases
this
of the
is-
anterior approach.
this is a
But when we go through the Dr. Bhandari's literatures, we have seen this neurotization and the result is compared. Huh? One of all are not, the vital structures, we are avoiding the vital structures. Second thing, the nerve, the affected nerve is very close to this, when we are anastomosing this good nerve to this affected nerve. So the neurotization and the result will be earlier when we compare to the anterior approach. Another few fibers make.
No, that you don't have to take away. You don't
I
take all
think
the
this is a
branches
very big topic and there will be a lot of discussion.
Yeah, actually, there are pros and cons of all techniques. Anterior, posterior, we have discussed earlier.
So I think that is a different topic in a different situation. We can
Thank you,
discuss a lot. I hope we are running late. Take
A
over.
small little thing that has happened recently is most patients who come under BSKY, if you operate all the 3 nerves, you get the same money. and if you operate one after the other, you get three so that is one reason. But otherwise, you should try to combine all the three in one.
Thank you, Lakshmi sir, for the nice presentation. Now, I would like to call upon Dr. Sunil Kumar Raut for his presentation. His topic is vascularized bone graft for avascular necrosis of bone.
Respected chairpersons and dear colleagues, very good morning to one and all. I'll be talking on vascularized bone graft for avascular necrosis of bone, which is not very commonly, I believe, managed by our specialty in most of the centers. See, most of us, we do microvascular surgery. It is just a little extension into another area into which we can encroach and expand our territory. So, we got an opportunity. Slide move nahi kar raha hai. Achha. Slide move. It's not. Next. So, sorry for the technical problem. Avascular necrosis of bone is not uncommon, I would say, in clinical practice of orthopedic surgeons. They usually come across this problem, but very rarely the cases are being referred to us. Many times, even it skips from the eyes of orthopedicians also, not properly diagnosed. And obviously, radiology, good quality X-ray, digital X-ray, and CT scan with 3D reconstruction are very useful to diagnose these cases apart from the clinical presentation. So, avascular necrosis of bone may result from several associated clinical causes, important of which at least we came across the cases which mainly resulted, one case from sickle cell disease and rest others are from high dose of steroid during COVID. Particularly in femoral head, and we came across the cases of scaphoid fracture non-union also because of the avascular necrosis. And they most often present with pain wherever it is affecting. Obviously, the best surgical treatment available is core decompression and vascularized bone graft for the head of femur, and for scaphoid, same way, debridement of the necrotic bone and replacing with a vascularized bone graft. We summarized the series of cases treated by our team means in AIMS basically, with core decompression and vascularized bone graft. All cases were diagnosed by CT scan with 3D recon, and cases managed both by free as well as pedicled vascularized bone graft. Post-operative pain relief was assessed using visual analog scale, considering pre-operative pain at a level of 10. So all cases were subjected to nuclear scan after a minimum period of 3 months. In order to assess the viability of the graft, it was basically for academic interest, nuclear scan, no other indication. We, from our interest, wanted to know the viability of the bone graft because most of them are buried. So our first case was a 12-year male, a young boy, history of, he was a patient of sickle cell disease from Western Odisha, and he presented with painful hip joint, right side was severe painful. Radiology showed irregular articular surface of the head of the femur, right femur, with features of non-viable bone of that region. Diagnosed as avascular necrosis of the head of the femur by our orthopedic colleagues and planned for vascularized bone graft. So this is the conglomeration of all the pictures, clinical pictures, starting from the radiology, the X-ray, digital X-ray, which shows clearly the irregularity on the right side hip joint. If you can see, the articular surface is of the head of the femur is highly irregular and doesn't look like normal. So we planned for free fibula vascularized bone graft. So they did the decompression by rimming from the greater trochanter side, and we used whatever length of the bone was required. It was about 8 to 9 centimeter length, 7-8 centimeter length is usually required, and the anastomosis was done to the pedicle of LT flap, that's the lateral circumflex femoral. And the other pictures are showing during surgery, it was the C-arm pictures. One picture shows the rimmer inside, and the other picture bone graft in situ fixed with one K-wire. Second case was 29 years male, post-COVID, severe pain in both the hips. Radiology displayed avascular necrosis of heads of both the femurs. At that time, OT was limited. We were not running OT regularly because of the post-COVID the crunch situation, manpower and everything. So he was he required to wait for a long time. So he wanted for the substitute, and he was treated somewhere else by an orthopedic surgeon with non-vascularized fibula. And then after about 6 months, he came to us again to do the other side of the femur with vascularized fibula. This is the case. So bone was, as I was saying, here we have mentioned that bone graft requirement was 8.5 centimeter. So the upper middle picture shows after rimming of the bone, the where guide instrument is inside that rimmed cavity, and nuclear scan we did post-op, and center below is the post-op X-ray showing the bone in situ, bone graft in situ fixed with a K-wire. The other side also shows bone graft, which was a non-vascularized fibula. Third case was 27 years female, again post-COVID with severe bilateral involvement. Left side was more severe than the right, so we went one at a time. Radiology again revealed avascular necrosis, planned for vascularized free fibula on the left side first. So same way, our orthopedics colleagues did the rimming, and we harvested the fibula. Here it was 9 centimeter requirement, and the anastomosis was same with the lateral circumflex femoral artery. Fourth case was again a young male with history of trauma to right hand, complained of pain in the wrist, neglected or undiagnosed by clinicians for a long time, and after about 6 months, radiological diagnosis was made of non-union of fracture scaphoid with features of avascular necrosis, planned for vascularized bone graft. Here the X-ray of the hand shows the fracture with non-union of scaphoid, which is a translucent line showing like it's a separate bone, but that was the fracture line. And in this case, we used vascularized medial femoral condyle as a vascularized bone graft for the scaphoid. All these cases were done in a team with our orthopedic surgeons, and they did the debridement and the aligning of the residual scaphoid, and we harvested the medial femoral condyle based on descending genicular branch of femoral artery, and it was replaced with the space, empty space made after debridement, and there the anastomosis was done, artery was anastomosed with end to side with radial artery and vein with cephalic vein. And the right photograph, middle photograph is the about 2 months post-op. we used a small skin paddle for monitoring in this case. That was with a perforating branch from that descending genicular artery. The C-arm picture shows the Howard screw, which is being often used for fixation of the scaphoid fracture. Our fifth case was a 47 years male with a history of trauma to right hand, diagnosed as right scaphoid, treated with screw fixation initially, Howard screw. Then he used to have continued pain in the wrist, and after that again it was detected that he was non-union related to avascular necrosis of scaphoid. Then we planned for vascularized bone graft. In this case we used pedicled distal radius. It was close to the just about 1 centimeter beyond the articular surface of the distal articular surface of the radius in the wrist joint, and usually about maximum 1.5 centimeter bone graft used to be required for the scaphoid. And this bone graft is the vascularity is based on a recurrent branch from the radial artery which runs through the septum, separating the extensor tendon compartments 3 and 4. So its dissection was very tidy and tedious dissection. So it was again used for the replacement of the scaphoid and fixed with a K-wire in this case. So total we performed this procedure in 5 cases, out of which for head of the femur in 3 cases and scaphoid in 2 cases. And vascularized bone grafts used in all the cases. Free fibula used in for all head of the femur cases. And for the scaphoid in 1 case, we used medial femoral condyle and other pedicle distal radius. Late post-op isotope scan we did in all the cases, and all cases revealed viable bone graft with good tracer uptake in all. Pain score in 3 cases of avian head of the femur, it came down to 3 from 10. Preoperative pain score was 10. So as per the patient's opinion, it came to the level 3. And in scaphoid cases, in 1 case it was 2, in 1 case it was 3. So it is mean is 2.5. So I would like to conclude with the points that vascularized bone graft is no doubt a better choice to relieve pain and delay hip arthroplasty in younger individuals. Here I would like to mention that the purpose of putting vascularized bone graft is basically for all those severe cases, they need a hip arthroplasty, hip joint replacement. But like the patient was in 12 years age, 12 to 13 years age, even in 20, 25 years age, if we do hip replacement now, all joint replacements functions well for about 20, 25 years. So maybe he will require, at the age of 50, he will require another replacement, most likely. So that is the literature, and our orthopedics colleagues say that if we put a vascularized bone graft, then the joint pain is relieved and the person can walk comfortably. So the joint replacement, if at all is required, that will be delayed at least for about 20 years. So that is the benefit of putting a vascularized bone graft, particularly in head of the femur cases. And in scaphoid cases, obviously, it's a fracture non-union, so we have to replace with the vascularized bone. And the other thing I would like to stress also, because we were not aware that steroid is such a notorious cause for this avascular necrosis. We came across at least 2 cases post-COVID. Those are also young patients. They had serious illness during pandemic, and they were on very high dose of steroids, so which is supposed to be the cause for this pathology. And free fibula is definitely the graft of choice for femur. Although various donor sites are available for avascular necrosis of scaphoid, vascularized medial femoral condyle is the better choice as per the literature. And practically also, even if I do only 1 case and another case distal radius, pedicle distal radius, I found rather femoral condyle free is more convenient and gives a better result. So these cases, no doubt, as I mentioned earlier, it adds to the clinical spectrum of microsurgery practice. So our specialty is supposedly to be known that we push into the other specialties territories in most of the cases. That's how this specialty has been established. So we can expand little further if we can push our orthopedics colleagues to send the patients with avascular necrosis of anywhere. So we can help them. Thank you all.
Thank you, Sunil sir, for this nice presentation. Now, any questions from the audience?
Sir, Dr. Rathore. Thank you.
What is your experience of, as you have shown that you have used free vascularized fibula for AVN neck of femur?
So, no, all the three cases, we have a short series only. We have 3 cases of avascular necrosis of head of femur. In all cases, we did vascularized fibula only, free fibula.
What is your long-term follow-up till now?
All the patients are at least, by now, they are more than 2 years, all completed 2 years. So they are all doing well as per the pain relief part.
And so, what was the stage of AVN? Was there any cortical breach then you, or as an protective just to?
No, in all these cases, there was the articular surface deformity already. So it is already, the articular surface was damaged. And pathologically, I mean, radiologically also there was it is the advanced stage, basically, advanced stage of the changes. So radiologically also and clinically also it was, pain severity wise also it was unbearable.
One more thing, were they unilateral AVN or a bilateral AVN?
In 2 cases, we had bilateral AVN. And I showed one case was done elsewhere with a non-vascularized fibula. Okay. And the other side, we did vascularized. We got a chance to compare the outcome in terms of vascularized and non-vascularized. It was a minor difference in pain score, honestly. It was not that significant. He said if it is 5, like pre-op pain was 10, so it was 5 on non-vascular side, vascularized it is 3. So still it is better. So it is 3, pain scale wise. And the other girl, actually, that 27-year-old female, we did. See, I don't have much idea about the regenerative medicine nowadays ortho colleagues are using for, we had a plan that next sitting we will do the other side. But the patient was following up with us also. They said that her husband said that orthopedics, the consultant is saying they will advise some regenerative medicine, some injections that helps. He said it's okay because patients are basically referred by them. So they are the boss to decide the treatment.
Yeah, that's true. But this is the primary disease of.
Yeah, the 2 cases were bilateral. Both were steroid induced. During COVID, steroid induced. So ideally, both cases should have done bilateral free fibula, maybe in 2 sittings.
Thank you.
So, thank you so much.
Thank you very much. We welcome Dr. Vikram from Kolkata. Thank you very much attending our conference. So, Sunil, I have a question. How do you monitor clinically while putting the graft?
For the non-vascular
do you
bone,
put a pedal for it?
For the hidden bone, na? You see, sir, basically there is no way other than there are ways like we can leave the pedicle exposed, or we can put a skin graft, even leaving a small gap, putting a skin graft there, we can see the pulsation of the vessels also. But we didn't do that. In one case only, that femoral condyle, we took the skin paddle. That was, I could find a perforating vessel branch to that skin paddle near femoral condyle.
Because later on you have done a bone scan.
Yeah, that is why. That is the reason we.
That is a different issue, but free grafts also being used.
Ideally, sir, we should do with the implanted Doppler probe.
And what if you take off on the children? Because avascular necrosis is very common in children. So do you have contemplation of doing in those cases?
Actually, I have not searched the literature honestly that thoroughly, but I believe wherever possible, vascularized bone graft is definitely better.
How many weeks or how many months after the patient works with this?
About 4 to 6 weeks is usually rest advised by our orthopedics colleagues. Okay.
So thank you very much. It is a new area
after 6
for
weeks we allow
plastic surgeon to get involved with orthoplastic surgeons.
Thank you so much.
Thank you, sir. Thank you very much.
Okay. Thank you, sir.
Now I would like to call upon Subrat sir, Dr. Subrat Jana, for his presentation on aesthetics in plastic surgery.
So we welcome Professor Kain from New Delhi, Safdarjung Hospital and VMMC.
Respected chairpersons, delegates, invitees, guests, and younger colleagues and students. Well, this paper is in fact meant for the people who have just entered into plastic surgery or are very, very young and have just entered into a career of plastic surgery. So the topic is about aesthetics in plastic surgery. So for a layman, plastic surgery is cosmetic surgery. The moment you talk to someone from outside your medical fraternity and introduce yourself as that you are a plastic surgeon, they say, oh, you do breasts, you do nose, you do cheeks. Then you have to explain, no, plastic surgery has a wide spectrum of surgical procedures, and we operate through all that spectrum. So there is reconstructive surgery. We also work with orthopedic surgeons, as Dr. Sunil just explained. We work with gynecologists. We create the genitals. We work with the android alopecia. We also work with the cosmetic dermatologists in providing them certain important help. So we work on a huge spectrum. But technically we divide plastic surgery into reconstructive and cosmetic surgery. So I am talking about the aesthetics in plastic surgery, and this aesthetic part is common to both reconstructive surgery and cosmetic surgery. This is my topic today, that aesthetics is as much a part of cosmetic surgery as reconstructive surgery. So this is what I have told you, that if you introduce yourself as an aesthetic surgeon, like our association is plastic, reconstructive, and aesthetic surgery. There could have been cosmetic surgery added to it also. But this aesthetic thing should not have been there, because aesthetic is plastic surgery. Every plastic surgery done is an aesthetic surgery. That is what I am trying to explain. So a line of demarcation is difficult between plastic surgery and aesthetic surgery. Because I consider that every reconstructive surgery or every cosmetic surgery is a plastic surgery with an aesthetic part into it. That is my take. So this is the definition of reconstructive surgery by American Society of Plastic Surgeons. In the website, it is written that reconstructive surgery is performed to treat body parts affected aesthetically or functionally by congenital trauma, this, that. So, let's take a case of a post-burn scar face, which has no functional impairment, but it has a huge aesthetic impairment. So, if that is so, a plastic surgery is not only done to improve the function, but also the aesthetics. Whether it is a free flap, or a rhinoplasty, or a breast reconstruction, or a hand surgery for that matter. I'll try to explain that through this paper. Any surgical procedure done anywhere in the body, concealed or exposed, let me add, functionally intact or functionally impaired, has aesthetic implications which cannot be ignored. You agree? I'll show you. This is a reduction mammoplasty. Is it an aesthetic surgery, a cosmetic surgery, or a reconstructive surgery? In the web pages of American Society of Aesthetic Plastic Surgeons, this surgery occurs in all the three. It is a reconstructive surgery, it is a cosmetic surgery, it is also an aesthetic surgery. To prove that point, I will take the example of this patient. This patient has a postborn deformity of the right breast, absence of nipple and areola. The left breast looks disproportionately large. So when he came, and a colleague of mine was trying to suggest that we will recreate the submammary fold on the right, put a full thickness skin graft. She said that, no, I don't want anything to be done on the right breast. I want the left breast to match the right breast. That is in the mind of the patient. You might do your own scientific calculations, but she has her own. She said you can add a nipple and areola if you can. So what we did is we did a reduction mammoplasty on the left-hand side, and the excess areola tissue that was available, we reconstructed a nipple and areola on the right-hand side, on the injured or the scarred breast. So this is what is a no man's land, or is every plastic surgeon's land. This is a girl with a scarred left breast with loss of nipple areola complex. Once reconstruction of nipple and areola complex, it is a concealed area, no functional disability, but it is the aesthetic need of a person, and strongly so. And as long as you are not able to deliver what she requires, a matching nipple and areola on the affected side, she is not happy with you. She doesn't give you a credit for doing this big surgery. So this is the surgeon that we are. This is the surgeon that people expect us to perform. Lip and palate, very commonly done. So this is a case that is referred to as a secondary deformity of cleft lip and palate. You can see the picture on the top in the middle. The moment she lifts her chin up, you find that the lip is absolutely unacceptable, unfavorable results. Opens the mouth, look at the teeth. So what was required to be done was take out all the supernumerary teeth, align them with a brace, do a lip revision, and here she is on the bottom left, a plastic surgery done on her face to the satisfaction of the patient. It's a hand. A thumb has been reconstructed with a groin flap. Looks quite okay. But how you can improve the aesthetics of this person is put a nail graft. The second toe nail taken as a composite graft improves the aesthetics of the patient much to match the realization, the need of this patient. When you take a groin flap, you have to see that the flap is thin as a finger, as thin as the place it is going to be, not something that is only a groin flap and doesn't match the finger. So therefore, aesthetics, gentlemen, is the most important element in our surgery, and we need to practice it from the word go, from day one of our practice. Loss of toe, once reconstruction, a radial free flap used for reconstruction. The picture on the lower right shows the reconstructed great toe. Goes on, and this is the final result, the same patient. So, this gentleman doesn't stay here, he stays abroad, he's coming back for his nail transfer. That is what they want, and that is what we are poised to provide. Irrespective of our qualification as an aesthetic surgeon, or a cosmetic surgeon, or a reconstructive surgeon, we are plastic surgeons. And that is what people expect a plastic surgeon to do. Whether indicated for aesthetic or functional consideration, a plastic surgeon must respect this human aspect of the specialty called aesthetics. Swachh, clean, good to see, good to feel. A free flap put on a foot. A free flap I have seen oftentimes is a huge blob of tissue sitting on the recipient area. Has not been considered well enough for the aesthetic requirements of the patient. You need to thin it if you have not taken a thin flap to start with, and make him look not only good with a footwear, but also without a footwear. An LD flap taken to cover a huge defect and grafted. Still, this foot should be something that can not only accept a normal footwear, but also, at least with a stocking, should look like a normal foot. The donor areas, therefore, assume a lot of significance in our surgery. I would suggest, or I have accepted it myself, that no LD flap is taken with a skin paddle. We can monitor we can put the graft later on, we can leave a space open for this muscle to assess its vascularity, but I will not take a skin paddle because it puts unnecessary stress on the closure line and results in a very, very unacceptable hypertrophic scar. I would like you to remember that when you are considering a flap or graft or whatever, you must consider the aesthetics. Whenever I have taken a thick split graft, I have always taken a very, very thin skin graft to cover the skin graft donor site, always without fail. My colleague is sitting here. You take a graft which is thick, you need a thick graft for the defect, take a thin graft and put it so that you ultimately have a very good reagent, a good donor site. So this is an accidental loss of the tip. You can see the scar, the stitched one, and the final result of reconstruction, done through a forehead flap. So the nose defect and the badly sutured cheek, then in the intermediate stages of the forehead flap being attached, then top rightmost is after the division, bottom left immediately after suture removal, and then as the patient proceeds. So the procedure is not just a forehead flap, but returning to the aesthetics of the patient. Yes, I might cross a minute or two. Is it okay? 1 or 2 minutes. So this is a patient which has come for abdominoplasty, because I have to explain this to my junior colleagues about what I need to speak to them. So this is what it is. And we have, there's a huge amount of skin that was excised, and then the proline mesh put, and, that's sorted. What I would like, and everybody does it, nothing new in it. All that I want you to do is put a navel. Put a navel. And where? Exactly where it needs to be. She is a Muslim lady. She is not going to even uncover anywhere. It's not going in a two-piece to the beach or wherever. But even if it is a concealed, you will understand and agree with me that navel is a very important part of a woman's belly. So this is the result of that person whom you have seen. Okay? And as I said, the final suture line of an abdominoplasty is very, very important. You might have done a great job in taking out and correcting all the weakness of the muscles, taking out this trial-ridden skin, apron, but if you have given a bad suture line, she doesn't like it, or she is not happy. And a navel. Not only that, the navel they select should be horizontal or vertical. So the picture on your right lobe is a vertical umbilicus, and this is actually hidden. Can I take this out? How do I take this out? There is a horizontal thing that was done to this patient who came back and asked for a vertical navel. Okay, so it is exactly where the time signal is there. So that is the horizontal navel which has become a vertical navel on the requirement of the patient. Okay. Okay. So this is the concluding slide. I hope I am able to convince you that whatever surgery you do, wherever you do it, whatever is the type of surgery, whether it is cosmetic or welcome, sir, Raju. So we treat the body and the mind like unlike any other surgeon. Why? Because we take them as they are. We take them as they are, but we leave them as they wish, as they wish. We take them as they are, do whatever we plan to do, propose to do, and do it well, but we have to leave them as they wish. Thank you.
Tip talk by Dr. Jaina, as he always does it. So aesthetic, he has told the form and function, both are very important for plastic surgeons. Right from Sushruta time, this has been the play of a plastic surgeon always, to have the form, that is the aesthetic part, and the function as well, important. So this is a very eye-opening to all the young surgeons, residents. So never a plastic surgeon takes away his mind and hands from the aesthetic part of any surgery concerned. So any questions from the audience side?
Is there any question? I don't. You have a question? You question my
Lakshmi
intentions?
always have a good question.
Sir, can you combine lipoabdominoplasty with Prolin mesh?
Yes.
No, this is the case of abdominoplasty with, it's not a lipoabdominoplasty. You do
Let me tell you, these nomenclatures sometimes create confusion in me. Either you are doing a liposuction or an abdominoplasty or together. If at this time abdominoplasty's requirement or part of it is liposuction. So they are all lipoabdominoplasties in all cases. So yeah, all the cases. You can always put, as long as you can maintain the sterility. Of course you can. So therefore it can
combining
be
both the Prolin mesh with the
repair weaknesses. Even this this patient also had a huge big scar of cholecystectomy. So still we did everything. All of you can do it. Only thing is, I think you have to keep in mind that the line that I'm going to leave on the patient should carry my signature, plastic surgery.
But it is avoiding, sir, this hysterectomy means TLH. Hysteroscope with, along with the abdominoplasty is usually avoided.
Yeah, I think the basic reason there is, because I have been called to do that often times, I don't want to combine two major surgeries. Okay. But otherwise, infection is not a big issue. Because CS or whatever is hysterectomy or CS are not contaminated surgeries. It's as long as it is an abdominal procedure, it's not contaminated. The question is that two major surgeries, the patient should not be given the risk of two major surgeries.
Are you ready? So we are lagging behind about 30 minutes. So if you all cooperate, I will go ahead for the next speaker. Thank you, Dr. Jaina, for your nice speech. I call upon Dr. Rashmi Ranjan Mahanti from MKCG Medical College, Berhampur, and he is working as an assistant professor. And he will be talking about flow through anterolateral thigh flap for upper limb salvage.
All of you, I am going to present flow through anterolateral thigh flap for upper limb salvage. Severe injury to upper limb with soft tissue and neurovascular injury provides a unique challenge to the plastic surgeon. Though these patients are quite often come to us, but due to lack of in-time management and definitive management, often these patients land up in losing their limb. So, unless technically impossible, every effort should be made to salvage the upper limb, because the limb will provide the tactile sensation and the confidence which the prosthesis won't provide to the patient. So I am going to present a case, a 25-year male from Ganjam presented to us with cross injury to the left forearm due to grinding machine. This is a deglobing injury with injury cut are very deep. On examination, it was found that the hand is cold and pale, pinprick bleeding was absent. There is loss of pulsation of the radial artery, and there is no sensation in the hand. Due to flexor tendon injury, the patient won't able to flex his fingers, and also there is loss of dorsal skin. And X-ray, you can see that there is no bony injury in this case. So emergency operation was started under brachial block and under tourniquet. Thorough toileting and debridement of the necrotic tissue was done. And what was identified was there is segmental loss of radial artery and ulnar artery with injury to median and ulnar nerve, and there is also injury to the flexor muscles. So, great saphenous vein graft was harvested around 30 centimeter, and the repair of the radial artery was done with 15 centimeter long vein graft, and ulnar artery with this is the radial artery, and then ulnar artery with 10 centimeter long vein graft. And another vein graft was used to repair the vena comitatus of the ulnar artery, and then sural nerve cable graft was used to repair the median nerve, and ulnar nerve was primarily coapted. Then muscle was repaired, and then the deglobed skin flap was used to cover the forearm. And no grafting was done in the initial stage because this is a deglobed injury, so there might be further necrosis. So grafting was planned for the second stage. And the post-op, this is the post-op day 3 picture, and this is what I am going to say, that due to narrow pedicle and deglobed skin, this skin viability was in doubt. And the muscles were red in the third post-op day. From the 5th day onwards, what was found that the muscle started necrosis, and the distal part of the skin flap again started necrosis. Then on the 12th post-op day, patient again started complaining that throbbing pain in the left hand, and on examination it was found that the hand was cold and pale, there is no pinprick bleeding, and radial pulsation was absent. So on examination, the muscles were also found necrosed, and the radial and ulnar artery were thrombosed. So again we came to the initial stage. So next management challenge was we have to repair again the artery and vein, then flexor muscles, and we have to provide a soft tissue coverage. Then what are the options? Again, we can do as I did before. We have to repair the radial artery and ulnar artery with long vein graft, and then provide a cover in the form of a abdominal flap or a groin flap. Or we can use one artery to vein graft to repair one artery, then another artery can be used to cover it with a free flap, or we can go through a flow through free flap. So what are the demerits of first two procedures? We have to use a long vein graft to repair the artery to salvage the distal part. And study shows that when you use a longer vein graft, due to turbulent flow within the vein, reverse flow, it can lead to turbulent flow and stasis and later on thrombosis of the vessel. which when we use flow-through flap, it will provide a vascular conduit through the flap, which can help to salvage the critically ischemic limb. So what is a flow-through flap? It is a flap where both the proximal and distal end of the vascular pedicule of the free flap are anastomosed to provide the blood supply to the distal part. Sutter in 1983 first described the flow-through flap, where he used radial forearm flap to anastomose the external carotid artery with the facial artery. And Latter and Foucher used the same radial forearm flap for extremity reconstruction. Different flaps have been used to salvage the limb as a flow-through flap, but in this case, we planned anterolateral thigh as a flow-through flap because it will provide a bridge vascular gap of around 20 centimeter, and it can provide a soft tissue coverage of 35 to 25 centimeter. Vastus lateralis muscle can be taken along with the flap as a chimeric flap. Two teams can be approached simultaneously, and patient need not have to change the position. And later on, any secondary procedure can be done. It can be done because the flap can be elevated from the underlying tissue easily. So we planned a musculocutaneous anterolateral thigh flap. This is the distal end of the pedicule where the clamp was secured for further anastomosis. We take 30 centimeter into 15 centimeter long skin paddle. The intra picture, and this is the proximal anastomosis and distal anastomosis, and the muscle was used to repair the flexor muscles. And another 20 centimeter long skin vein graft was used to repair the radial artery. This is what we did, and the vastus lateralis muscle is used as a functional muscle to repair the flexor muscles, and the proximally the ulnar artery and basilic vein was used to repair the artery, and distally ulnar artery and one of its vena comitatis were anastomosed. And the immediate post-op picture of the patient where flap was looking healthy. And this is the dorsal part of the skin which was deglobed was skin grafted. And this is the 7th post-op day. And after the suture removed on the 14th post-op day. Patient was advised physiotherapy during all this period. And this is the 6th post-op picture of the patient. And the CT angiogram shows that the vascularity of the hand is normal. These are some of the videos. You can see the patient can able to have some functions of his hand.
Previous photo ରଖିଛନ୍ତି sir?
ସେ ଦେଖଉଥିଲେ ଏବେ।
He can able to flex his elbow. And with his hand, he can able to hold the objects, and which help him in doing daily activities. This is a non-dominant hand. And he has very good muscle strength. He can able to lift heavy objects with his hand. And he is a male patient who are very fond of riding bikes. And while we ride bike, our left hand normally helps in using the clutch while changing the gear. So he is very happy that he can ride bikes even after this type of serious injuries. So what are the indication of using flow through flap? We can use it in post-traumatic limb or after post-cancer excision or in case of ischemic limbs. There are various classification of flow through flaps. One type is single type 1 where single axial artery is there, just like radial forearm flap, or in case of anterolateral thigh flap. Or there may be type 2 where two separate arteries which anastomose with each other by minor anastomosis, just like rectus abdominis where superior epigastric and inferior epigastric were anastomosed within the flap. Our third type are our single axial vein, just like distal forearm vein. In this scenario, we have to reverse the flap. So concluding my talk, flow through flap allow a single stage composite reconstruction of both soft tissue and vascular defects. Anterolateral thigh flow through flap is extremely versatile and useful flap that must be considered whenever there is a need to salvage an ischemic limb with large soft tissue loss. It has advantage of large cutaneous area, acceptable donor side morbidity, adjustable thickness, and ability to combine adjacent and fasciolata with providing a large arterial gap to cover and soft tissue defect. Thank you.
Thank you very much. I think applause for him. Dr. Mahanti has presented a very nice paper, and I invite questions from the audience. Dr. Bikram, please.
First of all, I'll congratulate you. It's a really nice case which you have salvaged his left forearm. My question is that why didn't you plan the same thing on the first day, since you know it was a high velocity trauma with crush and eversion of the muscles in the vessels? And moreover, you only said it was a degloved skin.
First, because it was a patient came to us in the emergency, so we have not very much sure that the skin paddle will damage. I think that because the muscles were also there, which can able to cover the vascular pedicle, matlab vessels. So I think that if the skin paddle will not survive, then we can grab the skin other than using such large procedure. We can keep that for the second stage.
Any more questions? Or Rashmi, I have a question. In fact, you have given the you have completely justified plastic surgery giving a good function, because you have given a muscle with that, you get a good function also.
Sir.
And the form part aesthetic which you have been talking in the morning. So can you do something better refinement for getting that flap has to be little
and in this
refined
case,
so that you get a better aesthetic sense?
In this case, the patient require a muscle to use has to fill the gap, and then it can be used as a free muscle transfer.
Yeah.
So we cannot thin the ALT flap at the first stage, but in the secondary procedure we can use we can thin the skin flap of the ALT to give it a better aesthetic.
So what about the sensation at the hand? I find the index finger has an ulcer. Is it due to lack of sensation?
We repair both the ulnar and the median nerve, and it is a 6th month post-op month. Patient has some sensation of the ulnar area because the ulnar nerve was co-opted primarily. Median nerve has some sensation in the median nerve region, but the index finger tip patient did not have sensation. So due to that, the patient has some ulcer in that index finger.
So do you monitor to give him back the sensation, because that is very important in the hand?
Patient is on electrical stimulation, and the nerve growth will take some more time, I think.
So anyway, you are taking care of it. No, fantastic. Huh? I am asking for the sensation, not the stimulation.
Okay, sir.
So, thank you very much for everybody. We have a patience hearing for all the speakers. Everybody has spoken very nice. I think we conclude this first session. And I think Dr. Deepak, I think you are placed in some other program, PG programs, has been decided by the scientific chairperson sitting over you. Thank you very much. Now we go for a tea break now. HOD from SCB. So they have joined with us, and most of the people are still coming. I think we will be more gathering later on. Thank you very much.
Subrat Jana, Dr. Ranjit Sahu, and Dr. Lakshmikant Mishra to chair the session, please. Ranjit Sahu. Ashinan. Dr. Chinmay Chiranjeevi.
The second session of the 10th
Patients that present
Aprasocon
with
annual
difficult
conference.
to treat or infected wounds,
The first session
especially
was
those
only a
exhibiting thick
speaker's
wound exudate,
session. You
slough,
understand
or
what it is?
infectious materials,
The
are
audience and the
particularly
speakers were the
challenging
same.
to treat. More so if they cannot
So in the
tolerate
next session,
or
I
are
hope
not
some more
candidates for immediate surgical debridement.
white heads and black heads
Now
will join,
there's VAC
so that
Veriflow
it
Cleanse
looks
Choice
like a
dressing for use with
homogeneous
Veriflow
one.
therapy
I'll
that can
request
provide
my
immediate
colleague
cleansing
Dr.
of wounds
Lakshmi
with
Mishra
thick
to
exudate.
please carry on with the session.
As these cases illustrate, you now have a simple adjunctive therapy for managing complex wounds.
Now we are running
when
late.
surgical
Without any
treatment is
delay,
delayed, not
I would like to
possible,
request
or not appropriate for the patient.
Dr. Prithviraj
Now
Singh,
you
the
can
Professor
immediately initiate
Prithviraj Singh
active
from
wound
Berhampur.
cleansing
He
with
will
VAC
speak on
Veriflow
the
Cleanse Choice dressing
experience
and
with
Veriflow
aerodynamic
therapy to
gracioplasty in the
facilitate
management of
removal
obstructive
thick wound
canal
exudate,
incontinence.
such as fibrin, slough, or infectious material, creating an
you have 15
environment
minutes.
that promotes wound healing. Wounds with thick wound
Please stick
exudate,
to your time.
including
Actually, we are
slough
running
and
a lot of
infectious materials,
delay.
are challenging to manage because they often include heavy bacterial bioburden. When managing these difficult to treat chronic and complex wounds, the goal is to quickly move the wound to the healing stage by initiating cleansing of the wound bed, removing of solubilized wound.
Respected chairpersons, respected dignitaries, guests, and delegates. I have got very limited experience on this. Rather, in the last 1.5 months, we got 3 patients opportunity to operate and do this graculoplasty encerclase operation, and they are all obstetric patients. So it's, as all of us know, anal incontinence is the inability to control the evacuation of flatus and stool, and it's a very socially distressing condition where the patient confines herself to the house because she is afraid of leakage of stool, and due to this she has also got low self-esteem and poor personal hygiene. The prevalence of this is about 2 to 6%. This is one systemic review by Kathleen Chin from United States of America. This shows if this is the incidence, prevalence. So I think definitely it will be much more in our setup in India. But I think in some 15 years of practice, I think I have got only 3 or 4 cases of graculoplasty. So probably the patients are not presenting. That could be the less number of patients we are getting. So types of incontinence, mostly passive incontinence and ORS incontinence. So in case of obstetric incontinence, mostly these are urgency incontinence. And passive incontinence we get in case of neuronal causes like CVA or paralysis. Maintaining fecal continence, it's a very intricate mechanism, and also it's an interplay of several organ systems and nerves. Once the fecal mass, the sample reaches the rectum, it causes the distension, and the sensation of distension is transmitted by the parasympathetic nerves, and it induces relaxation of the recto-anal inhibitory reflex. And that relaxation is a transient relaxation. So once it reaches the anal canal, again the other reflex, the contraction of the recto-anal contractile reflex comes into play, and it blocks the release of this stool if the socially acceptable environment is not found by the patient or the person. And the different organ system it is plays a role in this continence mechanism is rectosigmoid junction, puborectalis muscle sling, pelvic floor musculature, anal sphincters, and also interrelated motor and sensory neural pathways. But again, literature says still the exact mechanism is not known how the continence occurs. This I have collected from the gastrointestinal and liver physiology, American Journal of Physiology, and just to same thing what I have already told, like the role of rectosigmoid junction, colon, pudendal, puborectalis muscle, and the anal canals, and the external sphincters. Together they maintain the continence mechanism. But in our patient, because those are all three cases are all obstetric cases, and in spite of everything being normal, only when there was in MRI finding there was only laceration of the sphincters and they were incontinent. The factors interfering continence mechanism is neuronal causes, that is stroke and paralysis and trauma. Trauma due to iatrogenic injuries or following surgery, also hemorrhoid surgeries, or fistula in anu, or fissures, or trauma of rotary accident or history of fall, can cause also structural disruption of the anal sphincters, and vaginal delivery. So in vaginal delivery, our series is only regarding vaginal delivery cases or obstetric causes. In the obstetric patients, the history of significance is the number of deliveries. It is not only that primi gravida only suffer from this incontinence, or structural disruption can also occur in multi-gravida women, and prolonged labor can be a cause of this thing, which may induce also pudendal nerve injury, either form of neuropraxia or axonal injuries, and forceps deliveries or use of vacuums can also cause injury to the sphincters and also perineal tear, and the posterior midline episiotomy. The incidence of sphincter injury is more in case of midline episiotomy injury rather than lateral. Mechanism of injury, again it is disruption of the anal sphincter or the structural injuries to the sphincters or the pudendal nerve injury. This can cause incontinence in women. And the physical examination, on inspection we look for the scar, and in our patients mostly these are the posterior midline scars are there. Anal wing reflex, on stroking or scratching the anal area, there is a contraction of the external anal sphincter, that is to find out the intactness of the sphincter, and also the innervation of the pudendal, because it is external anal sphincter is supplied by, it's a voluntary the somatic nerve, that is pudendal nerve. And the digital rectal examination also plays very pivotal role in assessing the incontinence about the sphincters and anal canal. In the digital rectal examination, we need to see the resting rectal tone, and the resting rectal tone mainly it is contributed by the internal sphincter, about 80% of the resting rectal tone, and the rest 20% by the external anal sphincter. In the digital rectal examination, we can assess the resting rectal tone, and the bear down. When we'll ask the patient to bear down, that will tell us about the pelvic floor contraction. And when we ask the patient to squeeze, at this time we can evaluate the status of the external anal sphincter. In obstetric anal pulses, as in case of normal digital rectal DRE, there is a tight thing, at least we have to use glue and wait till the external sphincter receives the finger, but in this case it is completely lax. Even the internal anal tone could not be assessed as it is in normal situation. So in the evaluation, we evaluated the patient by Wexner's incontinence score, and the other one is MRI. And we have not evaluated this thing by fecal incontinence severity index or by fecal incontinence quality of score. Endoanal ultrasonograph was not available in our center, so we have only depended on MRI. Anal manometry, it is the functional assessment or quantitative assessment can be made by anal manometry, where same thing like the resting anal tone can be measured, and the squeeze pressure can be measured from the from rectum to the anal canal. And pudendal nerve latency, by the nerve conduction study, we can also know the assess the status of the pudendal nerve injury, whether it is there or not. And other test is difficography. In our case, we have only used Wexner's internal scoring system and MRI. MRI also has shown disruption in the sphincters, external anal sphincters. This is Wexner's incontinence score. And the minimum score is 0 and the maximum is 20. And this takes into account whether the patient is incontinent to only solid stool or solid stool, liquid stool, or gases, whether she wears pad only because of this leakage of stool, or whether she has changed his lifestyle due to this incontinence, or taking into account the total is 4. When it is always there, or at least it's more than once a day, sometimes in our case, our patients, they used to change the pads for 4 to 5 times a day. So, and they have also completely isolated themselves. They are not attending any functions, or even they are not visiting their friend's house or visiting the temples. So it is all 20 out of 20 in our 3 patients. So we have used only Wexner incontinence score for evaluating the patients, the severity of the incontinence. And incontinence, the conservative management is we can go for hygiene and diet control. Loperamide also sometimes works because it constipates, decrease the motility of the gut, and it helps in, to some extent, it will decrease the frequency of stool. Instead of 4, it can make 1 a day, but the timing is not a scheduled time, but any time it can happen. So for that, the patients were worried about. They used to avoid social gatherings or social functions, and they wear pads all the time. Surgical management, overlapping sphincteroplasty is there procedure, which also helps in gives good result about 70 to 80%. This is a systemic review literature I have collected. And there is sphincteroplasty plus graciloplasty. And graciloplasty, this gives 40 to 90%. Probably this much of variation is there, and the lower limit is 40%. It is the result of a systematic review. This is some related surgical anatomy. Only thing I wanted to show the pudendal nerve here. Sorry, this the likely chances of compression to pudendal nerve. The purpose is only that to show the pudendal nerve and its intimate relation in the Barth canal. Secondly, because we'll be operating on patients, so little bit anatomy of the external sphincters. It has got again 3 parts: an internal sphincter anatomy. Second, the puborectalis sling. This also plays an important role in maintaining continence. And at the time of surgery, because puborectalis below the puborectalis sling, the anus is about 4 centimeter only. And we have to make a tunnel of all around the anus. It is about 2 centimeter to accommodate the gracilis muscle. And also the perineal body you have to repair both the external sphincter by sphincteroplasty and also the pelvic diaphragm and this bulbospongious muscle, that is posterior vaginal wall. This is graciloplasty, a procedure which is described by Pickrell in 1952. Sir. Okay, sir. So this is about graciloplasty. It's not a new technique. It's a very old technique of 1952, and he did his procedures in incontinent in pediatric age group. And this is technique of encerclase. There is different method of encircling the anal canal with either alpha technique or gamma or epsilon. In the alpha technique, we have used only alpha technique because we used to harvest the so alpha technique only. If you go to the opposite side, then it will be a gamma 1, and epsilon if it is if you encircle from the below and also take a complete round and go to opposite side, it will be epsilon. And gamma also, if you go to the epsilon, alpha, if you remain the same side after encircles, going from the 6 o'clock position, reaching the 12, and come to the ischial tuberosity, then it will form alpha. So this is the patient. So far as so we have encircles. We have given 2 small incision, one in the medial condyle region to isolate the gracilis muscle, gracilis tendon, and the other one is 10 centimeter below the pubic symphysis, pubic tubercle, and just at the region of the pedicle enters, and we have dissected the muscle, and we have brought, and here we have also opened up in the scar region just to which will help us in repairing the posterior vaginal wall and also the disrupted part of the sphincter, and at the same time another with that semi circular incision we approached instead of a 2 lateral incision, because you always wanted to repair the sphincteroplasty along with this encircling procedure. So, and sir, next जाओ so next time or time over. Okay. So this is the result. You can see the scar over here. And in this patient, and the evaluation also is done by Wexner scoring only. This time, we got a score of about 2, which was 15 previously. Now it is 2. This is the pre-op photograph, and this is the post-op one. This is the second patient's result, and this is the first one. The first one other patient, and this is the one more patient whose result I am showing the post-op result because this is 4 months has been passed. So the complication is surgical site complication, as in any other surgery it could be there, but in our case there was no surgical site infection, but this patient only, the photograph I showed you, they developed wound gapping because we closed that wound with Vicryl, because there won't be any need to remove this sutures, but patient developed wound adhesions, and we did just lavish the wound with hydrogen peroxide and normal saline, and did a delayed primary closure, suturing. So perianal wound adhesions is a complication. We have not done colonostomy in any case, because in the review literature, many literatures are there, they have done colostomy prior to this procedure. Skin flap necrosis around the anus is a complication when one goes very thin fluffy ridges. So in this case, we have included the superficial part of the external sphincter. This is regarding adynamic and dynamic graculoplasty. It is called adynamic, though it is innervated muscle, so according to the principle of plastic surgery, it should not be called adynamic, but it is called adynamic because the dynamic variant is there. So should I proceed? Okay. So this is all about adynamic graculoplasty, and it's a simple, reliable, and cost-effective technique if comparison to dynamic graculoplasty. And review literature, I will read out this only. It is aimed to replace the anal sphincter. It's the original data suggests that dynamic procedure is more effective, but the recent study reports similar persistent success rate in either procedure without much complications of the dynamic procedure, because dynamic procedure is many complications only because that is related to the implants or the pacemakers. And following this surgery, patients report an improved quality of life. So as I have already told, the Wexner score from 20 it has come down to 2. Hardly the patient becomes incompetent or suffers from leakage of stool, that to only liquid stool, if she develops diarrhea. Otherwise, he is absolutely all right. I have got evidence in the form of his video, but I think time will not permit to say this. So, adynamic granuloplasty is a simple surgical technique and is effective for maintaining anal continence. It's a reliable and reproducible technique. Thank you all.
As we are running late, I think we will discuss during the lunch time. Any doubts we will discuss during the lunch time, and I will call, I will hand over this.
Thank you.
Welcome to Aprasocon 2024, all delegates and faculties. The next presentation will be by Dr. Tanmay Mahapatra, Barampur. He will be talking on post-operative outcomes in reconstruction of head and neck carcinoma, a case report. No, he's not there. Dr. Reena Means, are you there? He's not.
I would request my co-chairperson, Dr. Chinmaya, to present on chest contouring surgery, both male and female. 15 minutes.
Yeah, female I will be skipping.
Okay, only in male. Health Village Hospital. He will be speak on aesthetic surgery, specifically chest contouring surgery in male and transgenders.
Yeah, directly coming to my presentation, it's about a chest contouring surgery. So basically, I'll be talking on the male chest contour, that is gynecomastia and pseudogynecomastia. So male chest contouring, gynecomastia and pseudogynecomastia, and trans-man chest contouring, I'm skipping this part. So coming to the background, gynecomastia is defined as a benign enlargement of the male breast, mainly ductal, stromal, and the fatty tissue enlargement. And pseudogynecomastia, there will be fatty deposition only. Synonym is adipomastia and lipomastia. Around 65% of the men suffer from that. Now coming to the etiology, multiple etiologies. Coming to the most common is physiologic, senescence and puberty gynecomastia. Then the idiopathic one. Then hormonal factors are there like Klinefelter syndrome and hypogonadism. Certain systemic diseases like cirrhosis, chronic renal disease, certain neoplasms, drugs. So these are the associated factors for a gynecomastia. So if you see the pie chart, the most common is the idiopathic one, and second one is the physiologic, third is the drug variety. rapidly going to the clinical workup, detailing examine the patient. If there is negative history and normal physical examination, we call it as a idiopathic gynecomastia. If it is more than 12 months, then plan for surgical management. Less than 12 months, we will observe our medical management. If there is a positive history of or drug history, if there is a positive drug history, then discontinue the drug. If certain systemic diseases are there, then correct the underlying diseases. If there is abnormal physical examination, like there is a testicular mass, then examine for ultrasound, testicular ultrasound, serum testosterone, LH, estradiol. And if there is a breast mass which is suspected to be malignant or could be malignant, then go for the ultrasound of the breast, some FNSC examination. You can go for a surgical oncology consultation. So my topic will be laser-assisted ultrasonic liposuction-assisted treatment planning. So first, to classify the problem. So there is a clinical classification which most of the clinicians use. Grade 1 is a small enlargement without any skin excess. Grade 2A is the moderate enlargement with no skin excess. Grade 2B, there is moderate enlargement with some extra skin. And grade 3 is marked enlargement with extra skin and ptosis. There is another ultrasonic assisted liposuction classification, that is the Rohrich classification. This is usually used post-surgery to classify the disease load. The grade 1 is less than 250 gram, and in the grade 1 there is no ptosis. There is minimal hypertrophy, primarily glandular, variety soft glands. Grade 1B is fibrous glands. Grade 2 is 250 to 500 gram breast tissue each side, and it is also without any ptosis. Again, 2A is the soft gland and 2B is the fibrous gland. Grade 3 is severe hypertrophy. Grade 3 and 4 are more than 500 gram tissue, and grade 3 has grade 1 ptosis, while grade 4 has grade 2 and grade 3 ptosis. So basically this classification is about volume of the tissue extracted through ultrasonic liposuction and the skin excess and ptosis and the gland. So this classification covers all the three problems. That is the fatty tissue, that is the glandular tissue, and that is the skin excess. All three. So this is a better classification coming to the clinical terms. So next is finding out the problem. So again, I have already told the problems are fat and the fibrous glandular part and the excess skin. So next is the planning of treatment. So choose a plan. So when coming to the Simon grade 1 or 2A, there is no extra skin excess. So you can go for liposuction alone with without gland removal. And coming to the liposuction grade B, Simon grade B, we can go for a liposuction with gland removal. And coming to the Simon grade 3, same as grade 2B, but we have to deal with the skin here. So we have to go for any skin excision procedure along with the liposuction and gland removal. So what is the importance of ultrasonic assisted liposuction here? Ultrasonic assisted liposuction can be a sole method to treat the problem, which cannot be achieved through suction assisted lipoplasty alone. Power assisted can do the job very well also. Along with that, there is inconspicuous scarring for a ultrasonic assisted liposuction. Reduction of blood loss due to the ultrasonic energy, there is a least amount of blood loss out of the all three techniques. Operating time is reduced. Then there is reduced operative fatigue as the machine does the work, so surgeon gets the relief. Better control on the chest one contouring. This gives best in the ultrasonic liposuction. Many papers are supporting this. So what is ultrasonic associated liposuction? So the modern technology is VASR, that is vibration amplification of sound energy at resonance. So improved skin retraction often associated with ultrasonic liposuction. So that is why it can be a sole treatment. So when we do the subdermal scoring in the while doing the liposuction, so the skin contraction is better. So skin excision can be avoided when using a VASR. But the problem is there can be some skin burn. So very carefully it has to be used. And under the nipple, this can be used in a higher frequency to break the gland. It doesn't take away if gland removal is required, it has to be done. But if grade 1 or grade 2A, you can solely depend on liposuction alone VASR. So here is a typical example we'll be discussing on is a grade 2B gynecomastia. So, this is the front picture of this patient. This is the oblique picture of this patient. And in the oblique picture, there are two things we can get is the angle that it creates with the breast, creates with the abdomen. So the projection can be easily visible in the oblique picture. I like the oblique picture more than the lateral picture. This is the lateral picture. The angle is not that much appreciated in the lateral picture. So the planning, by tightening the pectoralis major, we mark the breast area to be treated. Upper part is to be limited liposuction area, and the lateral part and the lower part where we target the liposuction most. These are the area we target the liposuction most. This area and the side area. This side area. Sorry for this pointer issue. So, can I play this video? Can you play it? Time पड़े रहने जल्दी हो. Hello everyone. Today we are going to operate
Forward
gynecomastia. Forward with the help of the. So these are the three ring of the laser liposuction where the ultrasonic waves come. Can you show me? So usually while doing a laser, we use a port skin for skin protection. In gynecomastia, if the skin is tough, so sometimes I don't use the port and ask my assistant to put cold saline. Constantly she is putting cold saline at the port side to avoid the skin burn. So look at the pressure in my hand, there is no pressure, absolutely no pressure. So that is the work. So it is very smooth and the fat is getting emulsified. Some small streaks of fat is, this is the lateral chest wall we target for the chest contouring. And this is the inframammary fold. We have to break the inframammary crease so that the skin will drape properly. If the inframammary crease will be left as such, the skin won't drape and the fold of skin will be under the nipple. So that inframammary crease has to be broken properly. So after the liposuction is done, so the fat is suctioned out, and this is mostly bloodless fat and pure fat, and very less. So this is the pinch test post procedure to know the adequacy of the liposuction has been done or not. So we can hold the gland. This is the suction head of each breast, around 600 ml. Now this is the cut for the gland. So we, due to use of razor, we can actually minimize the cut. Okay, so, and see there is not much bleeding during the procedure. This is the undermining, around 5 mm tissue we left behind the nipple area for its blood supply. It's almost the anterior part of the dissection is complete. Now the gland is coming out. So this is the part of the gland dissection we are doing because razor has taken mostly the fat part. So we are dealing with the only fibrous part. So this is after completion. There is no other irregularity. So this side is not treated and this side is treated. This is the final incision and we are closing the incision in the back. So we have completed. So there is no external stitches. Here, the gland removal, we have completed stitches. There are no visible external stitches here. You can come little high up. There is no visible external stitches, nothing to be removed. Okay. This is the 12-hour procedure. So the contouring to the lateral chest wall along with the breast. So we treat whole at a time to get a better contour. This side is not treated, you can compare with the other side, and no infiltration has been given because when you do ultrasonic liposuction, infiltration followed by immediate the ultrasonic liposuction, we don't have to wait for 10 minutes or 20 minutes that we do in power assisted. Here you don't have to wait because we need water in the breast tissue that helps the process of emulsification. This is the non-operated side. This is the difference that makes the, look at the lateral wall. So once the patient will stand and the skin will contract, this will give a nice contour. The both side fat has been removed and the gland is removed. এটা কিন্তু বন্ধ করি এটা বন্ধ করো So, coming to few results, this is again Simon grade 2B. So this is the before picture and this is the after picture. This is 2.5 months, precisely 2.5 month after picture. So from this you can see the nipple size is half, and there is a V-shaped contouring, and the under the nipple the projections that causes that the feminine look part is over, and the lateral chest wall bulge is also gone. So that is why the main liposuction target is under nipple area and lateral chest wall area. So going to the lateral picture, so there is a scar definitely, there is a little bit of, but there is not much burn, but maybe due to friction even in power assisted we get this kind of scar. So, and this is this side lateral chest wall picture, this is the lateral picture. If you see the projection, angle projection with the abdomen I told in the oblique view, you can see here almost we got 170-degree view, here we are getting 90-degree view. And this is the lateral picture. So another case, here the right side is grade 2B and the left side is grade 2A. The unequal gynecomastia, difficult to treat, always patient has to be satisfied, both sides need to be same. So this is the after, this is the before and this is the after of this patient, and nipple size is same now. Mostly we have corrected the asymmetry. This is the side view, again see there is a around 110-degree angulation forming here, and this angle is around 170. So other side also. Now this is Simon grade 1 follow-up. This is the oblique view. This is the lateral oblique view, this is the lateral view. Then dealing with the skin, with the moderate to severe skin excess. So Simon grade 3 front view, one side is larger, one side is smaller. Okay, this is again the oblique view. The angle is clearly visible between the abdomen and the breast. There is the lateral view. Here we are planning for a periareolar skin excision. So here we have to mark the upper border of the excision. It has to be same in the standing position because nipple height irregularity will be there. Be careful while excising this thing. So this has to be same. Under the lower border, side border doesn't matter. The upper one matters a lot. So again, this is the deepithelialization. If you zoom, you can see the dermal vessels are intact. We are not damaging the dermal vessels. The deepithelialization has to be precise. Otherwise, the nipple necrosis or partial nipple necrosis can happen. So this is the immediate post-operative view of this patient. Most of the skin has been adjusted by the periareolar skin excision. We don't usually put any drain in this kind of patients. Pressure is sufficient. So this is the liposuction, 1400 ml, that is clearly grade 3 in Rorich, and this is the gland. So this is another case of again periareolar skin excision. This is the oblique view, this is the lateral view, this is the front view. Again we have planned. So quickly I am going through it. So this is the post-operative view. This is the succinate and the excision. So this is a typical periareolar excision result. This is the lateral view, periareolar excision. This is the lateral view. This is the. So now coming to ptosis, how to deal with ptosis. So this usually in my center I use double incision and free nipple graft technique in ptosis. So this is the marking here. It is marked little up. While doing, I have changed the marking little bit. And this is a case of severe ptosis with grade 3 ptosis. This is the immediate post-op result of this patient. This is the lateral view of this patient. This is the lateral view. Patient is lost in follow-up, so I couldn't get a 3-month view. Usually gets better, the scar gets better and the nipple thing gets better. These are few other results of grade 2B and grade 2A. This grade 3 we have treated with liposuction and gland removal. Patient didn't agree for the skin excision here, the first one. This is the lateral view to compare the adequacy of the liposuction and gland removal. So for PG students, I have kept this one to find out the grade and the views and the type of technique used. I think PG students are not there. So here is a grade 2A. We have done purely ultrasonic liposuction, and no gland removal has been done in the first case. And the second one is a fibrous variety, grade 1B, Rory's classification. The gland, you can see it's white, dense fibrosis, and the other side is non-gynecomastia side. But to compare, post-operative compare, we have done the gland removal, we have done the liposuction there also. You can see the difference of the gland size. There is less fat, mostly gland. So follow-up, we discharge our almost all patients in the daycare basis 12 hours. We don't prefer any drain unless there is some bleeding during the procedure or a passive drain during excision. Compression garment 6 to 8 weeks. Follow-up massage. Do and do nots, mainly wait. You don't have to bear for a month. Avoid gymming for a month. Complications, all know, most common is hematoma, inadequate resection, mainly complained in the earlier grades, grade 1, grade 2. There is poor scarring, mainly in the skin excision variety. Contour deformity, less formed in ultrasonic and the power assisted. And asymmetry, I have already talked the unequal gynecomastia, there can be a chance of asymmetry. Recurrence when there is systemic changes. So summary and take home message, liposuction can be 3 methods. So preferred is power assisted, ultrasonic assisted. The removal of glandular tissue, that's age-old Webster's transareolar periareolar technique is preferred over the Morcelli's pull-through technique through the liposuction hole. Dealing with the extra skin, the Huang's periareolar skin excision is still preferred. When there is ptosis, we go for a double incision free nipple graft technique. So this is my plan of treatment for Simon grade 1, grade 2B, grade 3. Rory's classification we cannot give before the operation. Rory's has to be done after the procedure, depending on the gland, depending on the fat removal and gland removal. So thank you, everyone.
Thank you. 1 minute. So is there any question? Is nobody going to ask what is the cost of a ultrasonic liposuction machine?
Lipobase will come.
Is anybody going to ask for me what is the cost of an ultrasonic liposuction machine?
Sir, there will be a promotional talk after this. The ultrasonic liposuction, one company is there. There are 3 companies available in India. One company is there. They will be having promotional talk. You can discuss about the cost and other things. And I can discuss about the patient, what usually, I work in a private setup, so most of the patients are paid patients. So you can say roughly 1.5 times the power assisted liposuction.
Yeah, so your job would be to compare regular liposuction and results of a regular liposuction and the results of a
Sir, since I came here in 2015, sir, we are doing only suction assisted lipoplasty in the beginning. So definitely much better results. And power assisted we are using since 2017, but I have left using power assisted since I have used this almost 2 years. Power assisted only I use while doing body liposuction, thigh liposuction after Vaser. So power assisted and this eases the work a lot. Sir.
Very nice presentation.
Thank you, sir.
In prelude to Dr. Subrat Jaina's, you should think of aesthetics in everything.
Sir.
You have shown 2 cases where you have given a transverse scar.
Yes, sir. Yes.
So despite, my question is that despite using so much of EBDs in this thing, can't we circumvent the scar transverse?
So see, when there is a lot of ptosis, mainly if the patient is, first case I have shown is a post-bariatric weight loss patient. So skin retraction post-surgery will be minimal because the skin has already tested time.
Welcome. I am just welcoming on your behalf to my colleagues, Professor Anjana Malhotra, Professor Gautam Goho, and Professor Prashant.
Sir,
please carry on.
Sir, that skin has already been tested because during the weight loss procedure, skin retraction, natural skin retraction already has been done. And there are a lot of stretch marks, so that will prevent the future post-surgery skin retraction. skin adjustment. So in this case, and the nipple is quite low, the inframammary fold. So I cannot achieve the proper skin draping post-surgery. So in these cases, basically when the nipple is down the inframammary fold, I prefer a double incision technique with due consent with the patients. That doesn't mean I have not done liposuction and other cases, because if patient does not give me any consent, so I cannot operate like that. And usually when I do skin excision, I usually ask my patients, I may need another procedure for revision, because mainly periareolar skin excision, patient are not properly followed up. They do something little bit, so scar opens up. There might be a little widening of the scars. I might have to revise those later. So I usually talk to my patients that you may need another small procedure 3 to 6 months later.
My question is
Yes,
that just avoiding that transverse scar, since you are using a razor, that itself helps in skin contraction.
Sir, I choose. I have shown one grade 3B case. There is a almost 2 liter plus succinate I got. So in that case, I have not gone for any kind of skin excision because patient didn't allow me for skin excision. In that case also good skin retraction is achieved, but not all cases, sir. Depending on the skin type, depending on the previous patient's previous illness, like this post-bariatric surgery or weight loss. In those cases, I go for directly DIFNG.
What I am saying, if we stage the thing, suppose in the case you have shown, you have removed so much of litter, and there's a good amount of skin contraction, maybe at the end of 6 months or 1 year.
Yes, sir.
Then later on, if you do a donut excision, that will just give an...
yes, sir, definitely, but it is little cumbersome. If the patient...
let's cut the story short. Chinmay,
I will be listening to your... yes, sir, I am still learning. I will be learning from your...
Dr. Chinmay.
Yes, sir, we can definitely avoid that.
Dr. Chinmay, very well presented, but I also respect what Dr. Rathore told. I would not go for, I will not make any patient subject to this bilaterally symmetrical horizontal scars. I have seen enough of them. I have seen they keep on coming, and this I learned very early when I took up transgenders. You know, the female to male transgenders, they have well-grown breasts. And all of them can be managed with liposuction and with a little patient series of ring excisions.
Sir,
so you could just try that. I'm just telling you, it's a suggestion. Sir, your patients accept it well, but as we already discussed, it should be in our mind.
Sir, actually my second part of the topic was on this only, because of less time, 15 minutes.
Fine, but it is well. Your results with the razor is excellent, right? Talia.
Sir, there will be a promotional talk by the company LipoWays. We are dealing with... yes, sir. There is,
no. We'll wait. We'll have to wait.
After this?
After this. This is not fair. Okay. So, at least I don't consider it fair. But there's an excellent... is Dr. Mainak Malik here? Your title of your paper is stupendous. Sitter had to loan from others after borrowing from Peter to pay Paul. Do you understand this? I hope you do. The kahavat is
this slide switched off. This
borrow from Peter and pay to you do next. Please.
Thank you, Subrat sir, for a kind introduction. Hello and namaskar, everybody. My senior colleagues, my teachers, I can see many faces, many familiar faces, my juniors and colleagues. So, as Dr. Jena has mentioned, this is about something, some pickup line we implement in our plastic surgical practice very often, that pay from, borrow from or rob from Peter to pay Paul. And this is generally used in transferring the vascularized tissues from one region of the body to the other for adequate resurfacing. So I'll be just highlighting some two cases where these scenarios were different. So this idiom actually, it's a very interesting thing. In the 1560s in London, just before the Reformation, during the age of recession, there were renovations of several cathedrals in London. So there were two cathedrals. One is St. Peter's, the other one is St. Paul's. So the cost that was incurred during the renovation of St. Peter's Cathedral was actually taken or borrowed from the funds sanctioned for St. Paul's Cathedral. So St. Paul's was naturally neglected. Metaphorically, they were robbing one church's funds to pay for the other. And this actually means from then the idiom has this meaning that borrowing from one person in order to pay back the borrowed money from a separate person. But still, there is a debt. So I'll be highlighting two clinical scenarios on this, what actually happened, both as a result of electrical burn injury in the neck. This is the clinical scenario 1. This patient was a 24-year-old male with a history of acute electrical burn injury at a construction site where he was carrying a tin metallic sheet on his shoulders, grasping it with both his hands, when a live electrical wire got in contact, as shown in this schematic diagram. So naturally, there was the passage of electrical current through the upper part of his body, and the exit wound was in his right feet. So there was a burn injury, 3rd to 4th degree in the neck and the lower part of the face, which he sustained, and he was brought to the emergency department of our hospital. With this condition, patient unconscious, and there was a stridor and upper airway congestion by laryngoscopy. We had to intubate him in the acute setting. In the first 1 week, we had to manage him in the burns ICU. And then there was this question, when to intervene, what to do actually. So here we can see the extent of the injury. So it was mainly located on the right side of the neck, but extending to the opposite side also, superiorly from the mentum, inferiorly to the manubrium sternum, and towards the mastoids bilaterally. So the extent of damage, we all know that electrical injuries cause damage more than it is contemplated than by clinical evaluation. So we had to wait and watch for some time for the patient to stabilize and the edema to reduce a bit. But there was naturally some other fears also, because neck is a very important structure harboring great vessels and nerves. So there was chances of great vessel blowout also. So we had to intervene. So after 7 days, we decided to take the case, and on literature review regarding this type of injuries, we went through several articles where it is mentioned there were free microvascular groin flaps, case reports. There were supraclavicular flaps, as well as the internal mammary artery perforator flaps, the pedicle or the loco-regional options. Those are mentioned in the literature. And keeping all the things in our hand, it's like a basket from which we have to pick up the right card at the right moment. So already with the predefined procedures. So this is a collage of the things we did as a part of the surgical management in the supine position. This was the extent after debridement, initial debridement. So actually, this type of wounds might require a second debridement at the second sitting or even a third sitting, because the coagulation proceeds, it advances, we all know. But still we cannot keep this wound open as such. With an open wound management or putting a skin graft over this type of wound, where we had to remove this submandibular, right-sided submandibular glands, as well as all the platysma and outer skin cover. So it is very difficult to manage these cases with an open wound policy. So straight away, the first option that came into my mind was the robust, easy to harvest and simple option of a PMMC flap. And there had been case reports of several designs of ALT flap in this type of wounds. We gradually need a butterfly or a bilobe shaped flap where the two lobes will be covering these two aspects, the crests of the two lobes. And actually we designed it like that only, sparing the nipple areolar complex. And this was the extent, the defect area was 15 into 10 centimeter, approximately in dimension. And the flap was planned in reverse and designed like this. There was a separate abdominal wound also. Here also we had to debride and close it primarily, undermine and close it. So there was tension from this side also. So we harvested the PMMC flap, sparing the deltopectoral flap region, and turned the flap 90 degrees clockwise to produce, to give the resurfacing in this way, adding lateral Z-plasties and advancement flaps to the neck, and could manage the neck wound. But the problem was that this huge area of donor side defect, primary donor side defect. So then this idiom came into my mind that why not try something else, because a split thickness graft over this area also will produce contour abnormalities, and the graft won't take up well also, there will be complications. So I had seen some of these type of things being done by my mentor, Dr. Gautam Biswas, sir, while doing several oncological resections at Tata Medical Center. So straight away this option came into my mind, design an internal mammary artery perforator flap based on the second and third perforators, IMA perforators, Dopplered intraoperatively, and to turn it at 150 degrees angle in this way, so that this flap sits at around as this one, and the lateral skin, the surrounding skin could be undermined and produce a closure like this. So we could achieve this thing on table, and luckily I got away. This is the postoperative result. The flap sitting, the primary flap sitting here like a collar, and the secondary flap sitting in this defect like this, the IMF perforator flap. And there was adequate neck extension also. We can see 90 to 100 degrees of extension. So he was happy with it actually. This is the first case. So this is the pre-op to post-op result. This is clinical scenario 2, where there was a subacute electrical burn injury. This guy also was a young male, 18-year-old male with subacute history, 3-month-old history of electrical burn injury, where somewhere he was treated conservatively with dressings, and this was mainly covered by some healthy, some portion unhealthy granulation tissue with an exposed occipital bone. We can see the necrosis, superficial necrosis, and this thing. So what to do, how to plan? This also we encountered several literature review, like the trapezius, classical trapezius flap, how to use that in covering several cervico-occipital as well as lower back defects, and loco-regional options like bipedical flaps, designed in a keystone design, how to advance it, and a breech flap, where the flap won't be having any kind of subcutaneous tissue connection, would be deriving the blood supply only from the two ends. So with these things in mind, we actually planned like this with the surface topography, where the major muscles and the structures are being noted, and the planning in reverse was done in like this. So it was basically 23 into 8 centimeter defect. Problem is that with this trapezius flap, the transverse cervical they're risky to depend on them. So we had to rely on the dorsal scapular artery perforators. So after the flap was harvested in a standard fashion, using the lower trapezius fibers mainly, and mostly we could preserve the upper fibers with some amount of rotation and combination, at the hinge point being at the spine of the scapula, where we had to ligate the deeper branch of the dorsal scapular artery that is going in to produce a greater arc of rotation. So this was the result on table. We could achieve the coverage of this primary defect. But then again, ground zero, what will happen to this defect? This cannot be closed primarily, and a skin graft over this pressure bearing area will not be very much helpful or will desirable. So what to do in this case? So naturally, I thought of a bipedical flap design in a keystone design way, such that the transverse dimensions remain the same. And then also, this is the tertiary defect. This also could not be closed primarily. So putting a graft here also would cause a problem. So sequentially, at every point of time, I have to stop and think, address the most imminent problem at a time, and take time actually. The only problem was the anesthetist. How much more time would it take? I could not answer. So in this way, imagining this defect to be addressed, I designed this one from the lateral aspect. So gradually we are trying to harness the lateral tissues and medialize them. So this was the result, end result. And luckily this also, I also got away with this thing. So this was the thing. In case of a circular defect, this is a concept of sequential bipedical flaps with a circle of X radius. So we can plan a primary flap in a keystone way with X radius, and to resurface this defect, after moving this flap A, we could design another flap, a secondary flap of X by 2 dimensions. From bilaterally this is happening, so there will be gradually the coverage of this area, main area. So we could achieve it, and this was the result. So immediate postoperative day 7, 19, we encountered a seroma, which with conservative open drainage procedure, it got settled, and this was at 3 months' time. So from here to here to here. So this area, I accept that this could have been grafted, but still a widened scar is always better than graft. And this actually represented some kind of mythological figure where the wings had been clipped, as in the Legion series in the HBO, or in our Indian mythology also, the Jatayu bird, holy bird Jatayu with his clipped wings. And this was published actually very recently. So the refreshed idiom, borrow from or rob Peter to pay Paul, would be, if only Peter can afford it, else Peter also needs to loan from others. So this is the bottom line of the presentation. My acknowledgements, all colleagues, residents, nursing officers, supporting staff, patients at AIIMS Bhubaneswar, Dr. Gautamishwar sir, and I'm extremely lucky that Sunil Kumar Raut sir is here. He is my mentor. Thank you. Homage to the great Indian vocalist, Ustad Rashid Khan, who has left for the heavenly abode. My respect and Shraddhanjali to him. Thank you.
Thank you. Can you have some questions? No, be there. Some questions. Mike?
Yes, sir.
Excellent work. Your borrowings are very well justified. But in the second case, I think you over-borrowed. The second case had a small occipital defect, and the remaining area was very well granulating. So small local transposition or rotation flap could have taken care of the business area. And intermediate thickness or a thicker graft could have solved the problem, instead of operating on so much areas and making it so extensive. So this idea is good, the idea is good, but in the second case, I think it was a little overdone.
I accept, sir. Thank you for the question. It was, yes, you are absolutely right. The scalp rotation or some kind of locoregional tissue transfer for that specific part of exposed calvarium could have been done. I accept, but still, when we lie down in supine position, I felt that it was the whole of the occipital bone that was involved. So, putting a graft over there is okay in the granulation tissue. Still, if there is some amount of supple skin cover, might be the results would be better. So I felt in that way, and once committed, I could not come back. So that is the main thing.
Dr. Akshay.
Yeah, in first case, the result is good, and idea is also good. But in second case, I think you overborrowed, because that is a highly mobile area with lots of pressure points. Once the stretching will happen, lots of keloids formation and fibrosis, and painful, it become painful. So with a good granulation tissue, only small area of bone exposed. So in that case, you can put the graft primarily. Once wound healed and contracted, later on you can put a flap or something else to prevent future
Yes, sir.
complications.
I accept it, and so many options. As there are so many options, there are so many ways. As Sri Ramakrishna Paramahansa Dev has mentioned, so I accept.
Congratulations, Manak, especially for the pictorial depictions, means how you do.
Thank you, sir.
In my first case, my question is that, well, you have covered the secondary defect with the internal mammary perforator flap, but did the patient question regarding the level of the nipple?
Obviously, there was a compromise because the right-sided nipple was below down, but I think, as far as
I know,
9 months have passed already, he is very happy with the results.
The severity of the
but I
defect
still
is a
accept.
very,
Yes,
beautiful option,
you are
but
right. Sir.
Only thing is that
had
the
sure.
patient shown any.
At that
secondary
time, the
aspect-
aesthetic thing was superseded by the reconstructive thing. So I had to compromise on that.
Okay, thank you.
Okay, so Manak has confessed that sometimes he borrowed more than he could pay. Fine. The concept is good. You are trying to avoid big scarred areas in the donor site, which is well aligned with my thought that you try to put something, and if not anything, at least a full thickness skin graft.
Yes, sir.
But the only important thing I'd like to make is please discuss about these plans with the patient so that he is not taken by surprise.
Actually, sir, it gets difficult because intraoperatively the patient is under anesthesia.
You can say about
with the
plan,
relatives and everything.
yeah,
we
plan.
try to communicate, but वही question, वही answer आता है. Doctor, आपको जो अच्छा लगेगा
ठीक
वो
है,
आप
then
करें.
it's good. So you have to discuss plan A, plan B, plan C, all of it, at least for the sake of legal shield, that you discuss all probabilities. I think we will end there.
Another.
Thank you, sir. Thank you.
Actually, doctor, जो अच्छा लगेगा करो is a big trap. Don't fall into
That
the
is a
trap.
trap question.
पेशेंट को अच्छा नहीं लगेगा, बाद में आपको भी अच्छा नहीं लगेगा.
Okay, sir. Thank you, sir.
Thank you, Dr. Mainik. Very nice presentation. Then the last presentation on this the second session, sir, our founder president, Professor Dr. Arun Kumar Chaudhary, he will present on reconstruction of composite scalp defect in a marginal ulcer, a challenging case. Sir.
Before the slides have been put into, I take this privilege and opportunity on behalf of the Aprasocon and the founder president of Aprasocon and also the trustee for the Aprasocon. I welcome Dr. Sheena, Dr. Malhotra, Dr. Guha, and Dr. Banerjee, and Dr. Ken also, and Dr. Vikram. We are so happy and we are enlightened to see people from Delhi, from Kolkata, from Bihar. So this is an amalgamation of all the 5 fingers of the eastern region, including from Delhi also. So I hope we have started having a good team, which I believe it. So today, my topic of speech will be, Honorable Chairpersons, reconstruction of composite scalp defect in marginal ulcers. A challenge. In fact, my slides were made just yesterday, day for yesterday,
But I hope this is an opportunity to the young residents. Time you should respect. It is not the time which makes you to respect. You have to respect the time. And time is not the factor for all time to prepare. So with a short notice also, you have to have an extempore speech. And I mean team means what? I work in a public hospital, government hospital, premier hospital of the state, SCB Medical College. We have Professor Dr. B.B. Naik. I start with A. And Dr. B.B. Naik, then you have B. Mishra and Dr. B.S. Das. So A plus B, you know how it became. If another C is there, it became a very strong team. So team is matters because what lastly Dr. Jena has pointed out, when you have a discussion and debate for anything, you definitely come to a good conclusion. And conclusion is the decision making for any noble, not only the best thing possible. So if we go to Swami Vivekananda, wisdom lies not on the amount of knowledge acquired. We all acquire knowledge, but on the degree of its applications, which most of time we lack it. So neither from the eastern region I'm talking of, we are lacking with the academic presentations at the national level or even at the international levels, not because you don't have the talents. We have the knowledge, but we are not able to implement it in the proper forum and in the proper fermentations. So I am going talking of Marjolin's ulcer. So obviously little history required for the background of the whole case. 1828, John Nicholas Marjolins. He is a French surgeon. But in 1903, De Costa coined the Marjolin's ulcer. And all these Marjolin ulcers usually transform to a squamous cell carcinoma of 80 to 90%. But the rest are maybe basal cell carcinomas, other type of carcinomas. But the majority are squamous cell carcinomas. And burn scar malignancy are usually 0.7 to 2%. So if it is the rarest of the rare, what is the peculiarity or why I am going to present this? Because this is of two aspects. One is the prevention and one is the management protocol to treat these patients. These are patients whose results are always good, provided you do it in proper time and place with the proper persons. So chronic ulcer, more than 3 months, at any stage of anywhere, if a scar is there, you have to be very cautious in managing at the earliest to prevent such unnecessarily cancer conditions that comes in the latter phase. So if there is excessive granulation beyond margins, everted wound edges, and the prognosis will depend definitely on the histopathological types, stages, and the metastasis. American Joint Committee for Cancers, they have made out a protocol for the metastasis. So my aim of treatment was appropriate. What is appropriate? It all depends on infrastructure. Infrastructure means the manpower, the instrumentations, the availability of different other multidisciplinary facilities, all that matters with the appropriate treatment to be given. And this treatment has to be expeditious. And interprofessional team. It all depends. Today morning, Dr. Sunil Raut was presenting how you amalgamate with the orthopedic surgeons, because most of the reconstructive surgery will depend on the orthopedic surgeon to refer you as a plastic surgeon to give a reconstruction. Many times it's not happening because of our contacts with them, either personal level or as a professional levels. So interprofessional team, in this case, we have to take a help of the neurosurgeon and good internist, and ICU backup is very much required of the patient care, and other anesthesia, good anesthesia backup is very much required. And imaging and digital X-ray and CT, I remember 2 decades back I was thinking of these things to be a newer modality, but now I think it became a routine test available because of the varieties of Swasthya Yojanas that has come. In our government setup, everything is free. But in privates also, these things are possible because of the Swasthya, either central or the state government's Swasthya Yojanas. And surgical excision with clear margins. Reconstructive surgical technique, again that comes with the decision making. As you know, the ladder of reconstruction always starts with the steps of Grave and Smith. But there is now today we are almost, many centers are well equipped with microsurgical, that is the elevator of reconstruction. So now, 30 years back, we are talking of microvascular free tissue transfers. Now people are talking of thousands. I have done this 1,000, somebody is telling I have done 2,000, somebody is telling 20,000. So the reason being, the technical skill, instrumentation and facilities are available. Most of the centers in the country, and mostly in the teaching hospital, it became a routine operation. So surgical technique is very, very important. Metastasis and follow-up treatments. Now, why I talk about this PET scan? PET scan is a newer gadget, but definitely it has a lot of role in those cancer cases to evaluate, monitor, and to make a decision for the management of the case also. It is not just a diagnostic. As you know, the layers of the scalp, I am not going to talk about in anatomy, but the skin of the scalp, periosteum, bone, and the periosteal meningeal dura matters. So these are the structures being involved in this case. So there is a patient, Kharika Naik, 35 years Hindu female, belongs to one of the interior place of Cuttack district, admitted on 20th of November 2023. She had a burn at 4 months old child. That time since she had a scar over the scalp and which has not been properly dealt with afterwards, and she came here. 3 years back she had an ulcer over the scar and she came out for a treatment in the Cancer Institute. They managed to do some conservative treatment and let the patient went off. And the patient was a known case of severe asthma with COPDs. So post-born marginal ulcer, right parietal lesion of a size of 5 into 6 into 1 centimeter proliferating lesion. He was treated first in the Cancer Institute, where they did an biopsy and found out to be a squamous cell carcinoma. And there was also CT was done there, and they found to be the bone external diplopia was eroded that time. So you can see here the post-born scar with a marginal ulcer, and also it was proliferating there. And the true defect, we planned it, planning in reverse. We made it to be about 12 into 7 into 2 centimeters. And the bone defect, which came later on, that we cannot discuss now because the CT scan was not giving the exact amount of bone that has been destructed. So now on the table, we found when you excise the, with a margin about 2 centimeters, normal margin, and we found out the bone was also been destroyed, both the bones are destroyed and dura was also affected. So here the trick, the patient had a neurological weakness on the both limbs when he saw the patient. So that was the reason for which we called a neurosurgeon, and we measured the flap. You see, we have not gone for a free flap. The condition was the patient was not a suitable patient for a long surgery under anesthesia. And it is so that on table, the patient has a severe asthmatic attack, and the anesthesia told, sir, we are not going to undertake this patient because we know that definitely the patient is going for succumbing. Then I told, as such patient is going to die. So if you do not do anything, she will die. If you do something, no, sir, there is chance of only 1%. Okay, let's hope for the Lord Jagannath. If one can be 100%, that is the benefit of the patient. So we went for excision of the lesion, and also we planned for a flap with these dimensions. So the flap have been designed, and the operation was not a very difficult in the sense of executing it, but we completed whole the surgery within 1.5 hours because patient was not in a good state of taking of the general anesthesia and recovering. And on table, patient has a spasm, and patient went, we could not re-intubate, and we have lost almost all hopes that patient will recover back. So, telling this, somewhere decision making in a surgery became a difficult on the table itself, the what to do, to cancel the patient or to take up the cases. This is one of the situations I have faced in this case. Now, you feel happy when such a poor woman, after 3 weeks, she is okay. The flap was taken up, and the graft also we have taken, it has been nicely settled, And then the question arises, have we done justice to the patient or not? Now we have sent the biopsy. Luckily the biopsy came not to be a squamous cell carcinoma, well differentiated. And the X-ray and chest, we wanted to see the metastasis. Fortunately, we didn't find much grossly, so we went for a PET scan. PET scan is free of cost in government setups in Odisha. So whole body scanning was done by PET scan, and you can see the PET scan, the brain and other part of the body, liver and the spleen. There have been no metastasis, and you can see the rent on the skull bone, and dura is also intact. That means there has not been, they have repaired the dura, but it has not migrated to the brain materials. And you can see the below down are the sections of the axillary nodes. They are activated, but there are no metastasis is there. That is a good for the patient's prognosis. And these are reports of the PET scan, and they have given us that the patient's clearance of the biopsy-wise, the clearance was very much complete of the tumors. By the biopsy report they have shown, and by PET scan also we found that treatment has been rendered properly, so that patient have a better life for a couple of years, then we can evaluate. So as we go for the literatures of Marjolin ulcers, of the skull inverting calvaria bone and the brain, also dura matters. In this case, the patient, we are very much in doubt about the patient's neurological condition, in fact, because they have tampered with the dura, and the dura was also affected that time. But fortunately, this is our department. I think Dr. Sinha has visited our department. It was a department where we started from scratch to this condition. Now the patient is happy, he is working with. So what is the take-home message? Appropriate diagnosis is modern tool of investigation. What is a modern? I don't mean what is modern means PET scan is not a modern now. It is become available everywhere in the country. So you should take advantage of that. A treatment should be expeditious. Even though she is a poor woman, but you should take care that it should be treated as a priority basis. Interprofessional team, neurosurgeon, ICU care with interventioning, all these are very important. Surgical excision with clean margins, you have to plan it properly in reverse. And reconstruction with appropriate and judicial surgical technique. As you tell, we are very fond of doing a free flaps, but if you can manage with a short anesthesia, with a flap available, like the trapezius flap which can fit into the patient's need, I think that will be excellent for the patients. No case has contraindication in treatment of malignancy. In this case, what I have learned, that you cannot tell this patient is not fit, is a contraindicated patient for going for a treatment. Follow up with PET scan to detect metastasis and further course of treatment is very important. Adjuvant therapy in the merit of this case, I have talked to the, personally I went and talked to the PET scan and the oncologist. They told, sir, we have to observe this patient because there have been quite good surgical clearance, and the PET scan also gives a negative, and the lymph nodes are also active, but they are not metastatic lymph nodes. So the patient gets the maximum benefit of our treatment which we have rendered. All bone scars should be monitored, and the patient should be educated to report early. So that is what we are lacking, public relations, and the persons who are coming with the health workers should be also sensitized to bring these patients earlier to get good treatment. Otherwise, most of the majority part of our state or any state, the poor patients are not getting the best possible treatment which can be given, provided we are sensitive and the whole system has to be sensitized. So with this, thank you very much for your patience hearing.
Thank you, sir. Very nice presentation. Now it is open for discussion. Any questions from this audience?
Yes, Dr. Bikram.
Sir, I have 3 questions.
Yes.
Was neurosurgeon involved? Secondly, how the dura was replaced? And thirdly, are you planning to reconstruct the bony defect?
First question, sir, yes. We called on the senior-most neurosurgeon to evaluate the patient, because sometimes, residents, MCH, we have courses, the people come, but they don't have that experience. So we called the senior most, the professor HOD of neurosurgery. He evaluated, but he didn't come that day, but a senior person has come and intervened, and he has also repaired the dura. And the question was, we planned before that if the dura is involved and you have to take off the dura, then we have to do a dura patch or you have to take a tensor fasciolata. So that we planned it before. But it was not needed. They just repaired the dura and that was enough. Second question was?
Third is, sir, are you planning to, since there is a bone gap, in future are you planning?
Yeah, in this case it was so badly infected. I tell you, no, the patient hygienic condition and treatment was not proper. So we didn't find for a titanium. We could have given a titanium mesh. And that is, you know, in a public government setup, to procure something also it takes its own time,
Sir,
to be very honest.
Later on, sir.
Later on, definitely secondary surgery can be undertaken and we can put a titanium mesh. Even though the bone gap is not much, the neurosurgeon told me that, sir, it can be managed now. It is only 6 into 3 centimeter. You can manage without a mesh. But I hope, rightly, I have thought about it also in the planning, that we can have a mesh in the secondary surgery.
Thank you, sir.
If there is no other question, can we conclude this session and go to the next, the immediate past president's lecture? Kaila aguru na, tapore au ebeka.
Okay.
Thank you.
Thank
Dr.
you very
Chaudhary.
much.
And to chair the session, Dr. Sunil Raut, Dr. Sanjay Giri, and Dr. Ramesh Das. Please, sir.
Professor R.P. Das is our senior mentor and one of the eminent teacher and eminent surgeon of our state. And he is the immediate past president of our Association of Plastic Reconstructive and Aesthetic Surgeons of Odisha. So he has worked with so many adversities and so many adverse situations working in a government medical college at Barampur most of his career. So I would like to inform to the audience that this year only we started this oration in our association annual conference, that our immediate past president will have an oration for the younger generation and all the audience. So it's my pleasure to invite Raju sir to deliver his oration and his experience and advice to the younger generations. I think definitely all of us will be benefited from that. Ramesh sir also would like to say something about Raju sir.
Professor Das worked a long time at Barampur. Now he is staying at Bhubaneswar and working also at Barampur. So he is a well-experienced surgeon and we have seen his work earlier with a very good result. With vast experience, he will enlighten us and enlighten the delegates coming from Kolkata, Delhi and Patna. Senior surgeons are there. So Professor Das to deliver the oration.
Thank you, Ramesh sir. So the dignitaries, the guests and delegates on the first row from different, Anand Sinha sir is laughing. The delegates and dignitaries on the first row, I mean to say from this to that. So Dr. Goa is there also. So, no, I am not lucky. So I have been superannuated. I am no longer in the medical college. Now, yeah, that's why. Now, the dear colleagues, residents, MCS trainees, and all other persons. So when Sunil called me, sorry, I'm not addressing him, Dr. Sunil. He's very much close to me. So when Sunil called me 1 month back, exactly 29 days back, So he told, sir, we are propagating for a immediate past president speech. So you have to deliver a speech. So the immediate reaction is, what shall I deliver? I don't have any records. Yes, I am very good at record keeping, minus the photographs. So who will believe me that my results are, Dr. Ramesh Das, he is a known acquaintance, he knows and he has seen my cases, so he can say, yes, a few of the results are good. But without photographic or visual confirmation, nobody will believe me. So also at this present. In this regard, I remember one incident. So just a little bit. So it was 1996. Sachin Tendulkar was facing Walker Yunus. So the other end was Sidhu. Then Sidhu went to Sachin Tendulkar and told that face him and take a run, single run. I will face him. You need not have to. Because in 1989, when Sachin Tendulkar played for India team at the age of 16 years, he met with a bouncer. The total score was 36 for 4, and when Sachin Tendulkar faced Walker Yunus, a bouncer came and hit him in the face. He was not wearing any grill at that time. So immediately he was taken back, and the rest of the is history. But Sachin Tendulkar declined. He told, no, I will not take a run. The very next ball, it is there in YouTube. You people can verify it. The very next ball, he hit a 6 to mid-off. Who was telling? Thank you, Dr. Vinod. So he was hitting a 6. The very next ball, a 4. The very next ball, a 4 again. The very next ball, a 6. And he took one run at the end of the over. So what I say, you people, for the stalwarts, I need not have to give my sermon or preach something. They have grown enough of gray hairs over their head, and they have passed their prime or yet in their prime. So for you people, never miss the opportunity. Once you miss the opportunity, you will run for the bus, as I am running. The moment I landed over here from doing my MCH at PGI, I was offered by the then Joint Secretary, Dr. Patnaik, Mr. Patnaik, because he was having a close proximity to my uncle, maternal uncle. He was classmate of him. He posted me at SCB. So I was so homesick at that time. After coming from Chandigarh, I pleaded before my uncle that no, you should make it that posting at MKCG, not SCB. Then that person, Joint Secretary, told my uncle to call that fellow. I will talk to him directly. So again, I have to run from the station, Bhubaneswar station, and went to the secretariat because of my uncle. So when I went there, he asked, that means it is in Odia, Tome Subhasra kon hobo? So I said, nephew. So what do you think of yourself? Because Subhas and me are classmates, and you have came from a premier institute, that's why I am putting you at SCB. I told no, I will not go there. I will totally stay at Berhampur. So he told, then what is the fun of doing all these things? Then at the end he told, you will review your luck. Someday you will remember. Now the day is this one. I am not regretting about my work. Yes, if you say, have you earned it or snatched it? that Boban advertisement, Boban chocolate advertisement. If you snatched it, crow will come and will take a bite over your head. If you earned it, no crow will come. You will get more. I have earned it. I have earned it. I have earned all my reputation at MKC's Medical College. Yes, sir. Definitely, I will emphatically say that I have never gone anywhere. I was forced to go for 2 years to SCB Medical College with a pretext of he is a good teacher. As if no other teacher were there, MCS teacher. I was the savior. I was forced to go there. So there were a lot of family problems. My missus has a health problem. So I had to look after her. I had 3 kids. So I have to go through all these things. I don't have any regret. I don't have any regret. I don't have any grudge with anyone. Because I am to say that I don't have any visual support, excepting few. So in that visual support also, I am emphasizing to tell the juniors that never show your work to anyone to peep into your personal computer. I didn't have any personal computer. I had a departmental computer. I left that one and everything was there. Some 12 number of cases of ear reconstruction, single stage ear reconstruction. I did it, I started doing it from 1999. Till up to 2010, I did. When my missus had health issues, I stopped doing everything. So as Prithviraj told, I was, yes, I can say and I can boast of myself also that postnatal, he forgot to mention that thing, postnatal anal incontinence. Yes, I was doing. Postnatal anal incontinence, nulliparous prolapse uterus, those things I was doing. But people branded me as a general surgeon. And what to say? Professor Jas, Madam, him. Professor Jas, who was having extreme acquaintance with me, he was telling, अरे यार तुम कुछ कर नहीं पा रहे हो, वो कुछ नहीं करते हो, वो बोल रहा है कि वो you are not doing also lip and palate. So I just simply laughed. They both, some other person, he came to Berhampur to conduct the smile train. So they were, I allowed. Because of my close proximity to DMET, I took all the credit in going personally to DMET and bringing that letter to the MKC's Medical College. When Professor Arun Chaudhary was there, Professor Chari came to operate at Ye. But he faced a lot of difficulties because of lacking of that order. But I allowed. I have always helped people. I never harmed anyone. No one will say that I have harmed anyone. Second, because of me, I can proudly say, because of me, I don't know about the status of SCB, but MKCG, most of the people doing MCH is from MKCG during the period of 10 years. Many people went to MCH. They did, and they are successful. So I have motivated enormously. Now there are, my daughter is there, my son-in-law is also there. My daughter is doing orthopedic PG, and my son-in-law is MCH. Madam knows, and Dr. Goa knows also. He is Tamsuk Das. Tamsuk. And he helped me. And my daughter also. Daughters, Papa ki pari hote hain. वो बताते हैं, why not? And again, I have regret. Sorry. I don't have any regret to tell that this will be probably my first and last podium presentation. I have never presented anywhere. Never presented, never boasted of myself. No, I am doing single stage ear reconstruction. I am doing omentoplasty. I am doing this thing, that thing. Yes, definitely, it was a small place. I was scared of not having good results. So for that reason, I never ventured for microvascular surgery. So even if, when people told that you are not well versed with microsurgery, without operating on loupes or microscope, I did operation using a 5x spec. I did 8 number cases of radial forearm flap in different. And 3 cases of fibular, and probably Dr. ତମେ ସେଇଟା ଦେଖିଛ ତ ଆସିଷ୍ଟ କରିଥିଲେ ବୋଧହୁଏ ଫିବୁଲାର ଓସିଓକୁଟାନସ୍ ଫ୍ଲାପ୍ ଇନ୍ ଆଡାମାଣ୍ଟିନୋମା. I was blessed with instruments. I had oscillating strikers, oscillating saw. I had drills. I had dermatome. I had all the equipments. I am thankful to the then Professor Dr. J.M. Das. Now here, I will be a scrupulous person if I don't say the names of these 2 people. One is Professor Mukherjee sir, and the other one is late Dr. or Professor Sunanda Mitra. What I am right now is because of Madam Sunanda Mitra. Every time when people scold me and they put me in trouble, so the madam, he stood behind me. So he used to call me Daso. So we Odia people, we pronounce Daso, not Das. So here Daso, क्या हुआ? इतना मुंह लटका के क्यों बैठा है? मैं बोला मैडम मेरे को ओटी से निकाल दिया, वो माइक्रोस्टोमिया देखना था मेरे को. अरे गो एंड सी द सर्च द सेलर and go and see the Gillis book of plastic surgery and learn by yourself. So with his guidance, I have learnt many things. Now, few of the things I am trying to project. So please, if you don't like it, it is up to you. But, but allow me to continue these things. So this is, I started off in MKC Medical College under the supervision of Professor J.M. Das after passing out from PGI Chandigarh, and then promoted to lecturer. At that time no assistant professor was there. Immediately you have to join as a lecturer. So 2000 I joined as a lecturer, and 2005 I was promoted to assistant professor, and 2008 I become associate professor, and by some other person motivation I was forced to go to SCV Medical College with a tag, he is a very good teacher, as if I am the savior to the MCS students. But I can proudly say the Ranjit Sahu, is he there? No, not yet. Ranjit Sahu, he declined to appear the MCS. I have motivated him like anything and told, you please, sorry, you have given me more time now. Oh, sir. So, where do I? That good, tremendous MCS teacher. So I went there. I stayed for 2 months. I am thankful to late Ananda Prasad Patnaik, who was my friend. He was 4 years junior to me, but he was more like a friend, but because he was a classmate of my friends. So he allowed me. At that time my missus health issues, so I used to go there. Over here I am no longer in service, so nothing will happen. I used to go there in the morning and used to come back in the afternoon. So he allowed me. I am thankful to him and other persons also. So Vibhuti was there as a assistant professor. So they never grumbled that this person is bunking. Now, coming to, I'm superannuated in the year of 2022 as professor and HOD of here. My credit to that point is, I took all the pain to grant the MCH seats at MKCC Medical College. Now, Dr. Puthviraj is heading the chair and doing it. Now, in that juncture, the NMC supervisor, he came and he told 3 seats. So he was very much satisfied with the setups. The PMC block was there. I was a leprosy reconstructive surgeon with PMR background. So all these things he was very much. He went there particularly to PMR department. We had 4-story PMR department. So all the equipments are there. So he visited and then he proposed, Dr. Das, why don't you suggest for 3? There were 4 cases, but I will grant 3. But here I am little bit miser. I told sir, allow for 2 and rest of the thing will be in place. कहीं ये जाओ नहीं आसा देखो So I am a general plastic surgeon. So my specialty is not microvascular surgery or any other procedures. Whichever case came to me, I never, during my tenure, I never referred those things to any other institute. People still believe at our setup. So what he did, those things I was doing. Postnatal anal incompetence with a little bit of difference. That adynamic or dynamic, whatever you call, that static procedure of a gracilis wrap around. I was doing, but I have a difference. That I used to give 2 incisions over the perineal region to strengthen the perineal body and the posterior region to strengthen the liver trinae muscle. I do a double breasting. And with putting a stent, I used to tighten the liver trinae in double breasting fashion. So I used to do that. I used to do the nulliparous prolapse uterus by putting the round ligament of uterus and fixing on the posterior rectal wall. So in the lower part, there is no posterior rectal wall that was insulated, and through the rectus abdominis muscle, I was putting those things in the anterior abdominal wall. So I had little bit of modifications and all these things. So in general plastic surgery, I did single stage ear reconstruction, Nagatas technique. Nagata was using cartilage in piecemeal, but I did it in a monoblock. This is the post-traumatic case. Now the incision, I take the superficial temporal vascular fossa. That was that arrow given was the artery. Now, this is the cartilage framework. I used to carve this thing with a single monoblock cartilage from 6, 7 and sometimes 8. So that monoblock cartilage with the carvings, these carvings I got it from Bentic Street. That carving tool. So that gauze, which looks like our gauze, that I took, and that I was using as a tool. And with the help of 15 and 24 number of gauge blade, I used to carve this one. So this is the wraparound of the superficial temporal fossa. And perhaps I think this is the other case, not the, I don't know, I don't know. So this was the 10 years class 2, but with bifid ear lobule. Bifid ear lobule. The same thing, that artery is visualized, artery is visible. Then I did the carving over there. And I had the instrument with me. Till now it is there, I think. That potata achi bodhe. Did you have pota achi? I am very much fascinated using the wooden block in harvesting the graft in typical fashion. So I want to tell the juniors that don't deviate from principle. Yes, if you deviate from principle, you may escape 1,000 times. You can say, boast of yourself, "Arey chhado yaar, hum karte hain, ho jata hai." But if complication is there, that cannot be a recoverable one. You cannot manage that thing. If you go with principle, yes, there may be difficulty, but you can manage that thing. So please, so I still use a wooden block for graft harvesting, and typical description of grab and smith, with putting a block below the thigh and asking the assistant to lift, and then pulling, and against the pull you take the graft. So this is immediately after this photograph, that photograph extreme right, that was immediately after the cartilage incorporation and grafting. Now a keloid of the, so these are small cases. People ask, what big cases you do? I told that no big cases I do. I just very much acquainted with small cases. So this is the case with the keloid. So keloid operation, I am very fond of limb flap. I made that surgeon happy. That person might have been feeling satisfied in his grave. I incorporated limb flap in many places, and rarely I encountered any flap loss. So at present I can do Limburg anywhere, excepting leg. Over the scalp also I did it. This is a case of keloid of ear lobule, and I did the ear lobule reconstruction. Now that I incorporated a Limburg's flap. You can see it. Now these are few cases. One is our sister in charge, and the other one is a patient. I could gather this much of photos. That was white forelock with congenital vitiligo. Congenital vitiligo, present since birth. So I did a dermabrasion using 80, 300 and 400 emery paper with continuous irrigation of saline. Now this is the sister in charge of plastic surgery, Jayashree, with white forelock and vitiligo, congenital vitiligo. This is the thing, and I don't have at present any other intraoperative or post-operative photographs, but I rang her up at about 11 p.m. to Trivandrum. She was there at Trivandrum. So I told in Odia, Didi, mata dorkar photo patha. So send your photograph. He was so obliged, he sent. Now the results are there. The same person. I am not manipulating. I am not manipulating anything. Whatever it is there, it is there. Then management of basal cell carcinoma. So we both competed for post of professorship. So when I told someone that please publish these things, so he never published. So I was detained for 6 months unnecessarily. Later on, I become promoted. I got promotion to the post of professorship. So these are the cases of basal cell carcinoma. As I enumerated earlier, I used to do limber flap only. This is the post-op after 7 days. This is another case. Now the mouth opening is adequate. There is no deviation of the ala or other vital structures. This is the post-operative 7th day. The mouth opening is adequate. The nasal aperture are more or less similar. There is no deviation of the nasal tip and mouth opening is adequate. Now another case of nevus that I did with Limburg flap only. Another case. Now this is the case of Kanha. So because of my proximity to the bureaucrats and politicians of my region, I got maximum mileage in this case. I was congratulated by the then governor. I was congratulated by it is the whole team. Dr. Vishwa Mishra was there with the team. So I never took the responsibility of not promoting him. I called upon him and projected him in front of the camera and told that he is also a part of team. So this case only I did simple. This was a partial werewolf syndrome. He has not developed a whole. Only upper torso, that to anterior portion, shoulders and face. So this I did. After excision, after grafting, immediately after grafting, then post-operative period. Now, lower limb reconstruction, I used to do omentoplasty. I have done 5 number of cases in, so after doing this thing and getting good result, every surgery professor, they told, if you do omentoplasty, what we will do? So they never referred the case again to me, so it was stopped. This photo is presented in Aprasocon, Aprasocon, and presented in the category of e-poster. So this is the omentum. Then I lengthened it. The omega arcade was broken, and I lengthened it. Then the usual calculation is 1 feet, 1 feet, 1 feet, 6 inch, 6 inch. So that becomes 4 feet. So from torso to, from inguinal region to, from inguinal region to the, reckon the back over, from inguinal region to the foot, the non-healing ulcer which resulted due to thromboangiitis obliterans, it was covered with that omentum and subsequently grafted, and the result was there. The result was there. Then I do varicose vein. I never strip. I do subfacial ligation of the perforators. So that is the in thing. At present, everybody does that thing only. So there are the perforators under which there is a artery forceps. And the non-healing ulcer over the heel, that was done with a locoregional flap. So this is the case which I did some 15 days back. There was a non-healing ulcer and the joint was exposed initially. So I did the dressing, allow it to granulate. Thereafter, I did a flap cover, lateral peroneal artery flap cover. So that gave say I was very fond of doing things in a very innovative way. So the vascular malformations, CVMs, which are not amenable to surgery without blood transfusion, I used to those things. Initially, I was tempted to inject intravascularly the N-butyl cyanoacrylate. So, isobutyl cyanoacrylate. Isobutyl cyanoacrylate is more costly, and it was not available also. For that reason, I changed it to the industrial grade methacrylate cyanoacrylate. So that is the industrial grade cyanoacrylate. It was what do you say? Fevikwik. So I used to bring and I extract some 100 ml of Fevikwik and inject that thing. To my credit, I have never used a blood transfusion. But meticulously, I went to search for the polymerized resin and removed it. If you leave it, it will cause enormous fibrosis. That is the only problem with methyl cyanoacrylate. So these are fingers. At present, I don't have any other thing. So what I did in the last 15 or 20 days, that I am showing it. So I put a full thickness flap cover. So this I did a full thickness that abdominal flap cover. Now this is the after result after 15 days. Then I was doing leprosis surgery. I was chief instructor in the state of Odisha from 2005 to 2015. Then I stopped doing, and later on Dr. Prithviraj started doing, and at present Dr. Ashish, he is doing. My specialty was, I was doing a case of A2 pulley anchoring in lasso. A1, the typical book description is A1 pulley. But I used to take the lowermost fiber of the A2 pulley. When you do take that one, the flexion is very much. In case of simple lasso, when you put a metacarpal bar, then if you ask the patient to extend the fingers, then if he is able, you have to do a simple lasso. I do ECRL four-tail transfer in a very meticulous manner, Paul Brandt's technique. I never had any problem in that impinging, that anchoring site impinging upon the osseous structure or in the opening of the carpal tunnel. Then I do aesthetic surgery also. So this one, I do PRP treatment. So what you call as vampire facials. That vampire facial I used to do, say year thila to 1919. So one of my seniors, Mrs., he came all the way from states. I don't think that he has come exclusive for me, because I was not taking a single cup of coffee or tea or any remuneration or any gifts in the hospital. So he used to come to hospital. Many cases I got, those are poor cases. The poor persons, they cannot afford to go outside. I never faced any problem. I was never manhandled. I was never threatened by anyone. I'm a local person and I know many, I can pull many strings, so people were scared of me. So this is the PRP treatment, and after 14 days. She was 57. Now I express my deep gratitude and appreciation to the individuals who have played a significant role in my professional growth and development. My esteemed colleagues, seniors, and my family, particularly though I have rift with my father, but still I adore him and applaud him. Because for him I went for MCS. Their guidance, expertise, and unwavering support have contributed immensely in shaping my career trajectory. In this regard, I am very much thankful to my wife and my kids, my 3 kids. Yes, to every parent, the kids are jewel. But I can boast of them that they are not jewel, they are something else. Please bear another 5 minutes, please. I have not delivered any podium's presentation. This will be the first and last. So please bear with me another 5 or 10 minutes. So their willingness to share insights, challenge ideas, and collaborate on projects have been the very reason for my growth and the growth of Apraso in the last few decades. Although my career, I have witnessed stalwarts from this part of the country achieve remarkable feats in the field of plastic and reconstructive surgery. I am humbled to have been given this opportunity to address this gathering of intellectuals and great pioneers and would-be pioneers. As an old observer in this field of plastic surgery, it is with great honor and enthusiasm that I address the aspiring young generation of budding plastic surgeons. It is a remarkable time for you all to push the boundaries and set up new parameters of possibilities. Not only can you help your patients overcome disability, restore ability, enhance physical appearance, you can also elevate their self-esteem. Adapt to changes, embrace innovation, and continuously enhance your knowledge and technical skill by embracing a collective approach to knowledge. Remember, when knowledge is shared, it transcends the boundaries of individual mind and extending its reach to touch the life of countless others. They will benefit the poor. The persons who have having money, they can go to corporate hospital. No problem for that thing. So my earnest request is for younger, not the stalwarts. They have come up to this stage. Collaborate, cooperate, and innovate. Collaborate, cooperate, and innovate. Please. Thank you. Thank you all. Thank you. The first word during my superannuation was thank you. Thank you to all my colleagues. So, no, sir. Please. So, Thank you. I am indebted for your kind gesture. You have given a standing ovation. That part I have omitted. I have never thought of this one. And at least seniors like Arun Chaudhary sir, and he is not there. Subrajana sir not there. Ramesh Das sir, they are senior to me. And once they stood up means it is something. And I am thankful to Sinha sir because he persuaded all to stand up. Thank you. Thank you, sir. Thank you, everybody. Thank you. Thank you. I don't think any question.
Sir,
If at all
No, sir,
you want
oration, there is
the
no-
single stage repair or single stage ear reconstruction or omentoplasty or any other thing, you can personally contact me, I can tell you. But I have started all these things from 1999. I lag behind, I missed the bus. I am not, at present I am trying to catch that bus, but it is far off.
We are not going to leave you, sir.
No, no.
You are with us only. Sir, sir, 1 second, sir. Sir, on behalf of Apraso, you want to give a small memento? After that, we will start the post-on session.
It would be an operative video by our invited speakers. The first speaker would be Dr. Subodh Singh. He could not join us because of his cancellation of flight. So I would request to chair the session Dr. Anjana Malhotra, Dr. Akshay Raut, and Dr. R.P. Das.
Good evening, good afternoon, everybody. I think most of us are back from after lunch, and we will begin the invited lecture series consisting of all video workshops. And to set the ball rolling, may I call upon our President-elect Dr. Subodh Singh, who needs no introduction, to give his talk. Unfortunately, Dr. Singh couldn't join us physically because of his flight cancellation, but he is going to do the talk online. Dr. Subodh Singh is going to talk, he is going to show us videos about unilateral cleft lip repair, bilateral cleft repair with extended open tip rhinoplasty. So now I hand over the mic to Dr. Subodh Singh, please.
First of all, namaskar to all of you, and with me I bring greetings from the land of Shiva and Vishwanath to you all in the land of Lord Jagannatha, and I'm really sorry that I could not be there to meet you all personally. My flight got cancelled after much delays, and otherwise I would have been there to meet you all in person. So without further delay, let me share my screen. So first I would take up, and this talk is meant for junior colleagues, and this is about a unilateral cleft lip repair. So there are not many videos in this presentation, but I will give you points. So the second presentation on a bilateral cleft lip has some videos. So it is important. It is important to understand the basic things in a unilateral cleft lip. Unilateral cleft lip repair is, for plastic surgeon, is an easy repair, provided you understand the concept of deformity and the concept of repair of the lip. If you just go for learning for techniques and all, then it becomes difficult, because you get involved into naming the points, measuring it in the different ways, and you miss the basic concept. So I will take you through the basic concepts and understanding of what a unilateral cleft lip, and then I will show you one type of repair. There are several types of repair, and in the hands of expert surgeons, all cleft lip repairs give good results, but I will just show one and simple cleft lip repair. So as you can see, the deformity can be varied from a minor small cut, a microform cleft, to a complete cleft. So there can be just a defect in the vermilion or the skin, or a little more than that. But if you see in this picture in the lower right, so although it is incomplete, but if you match the difference between the two sides of filter ridges, it is great. So for all practical purposes, this is a severe cleft. So severity of the cleft is not decided by the width of the cleft, but by the difference in the heights of the filter ridges on two sides. So that is also important. So again, even more, so there can be a complete cleft with alveolus or complete cleft of the lip with alveolus as well as palate. So there is a huge range of deformity, and every cleft patient is different from the other. And then the nose may also be deformed, and the nasal deformity may be mild, moderate, or very severe, depending upon the width of the cleft and the cleft of the alveolus, as well as the collapse of the alveolus. Now this is a complete cleft, and you can see there is a wide cleft of the alveolus as well, which is taking the alveolus apart, and along with it, the nasal ella is being pulled apart, and it is almost like a straight line. So this has been pulled apart. Sometimes there is a severe collapse of the alveolus, so the base of the ella is also gone posteriorly. So laterally, posteriorly, sometimes inferiorly as well. So there can be deformity of the nose depending upon the severity of the cleft of the alveolus and how wide the alveolar cleft is. So the nasal deformity is certainly secondary to the deformity of the alveolus and lip. And therefore, if we correct the deformity of the alveolus and lip, nasal deformity will be corrected by itself. So these are the important points, but I'm not going into these details, you know it already. So the most important thing to remember here is the filtral ridge and the cupid's bow. We need to make it symmetrical. This is symmetrical. This is equal on both sides. And the filtral ridge, the cupid's bow is also symmetrical. Our all efforts in a cleft lip repair is to make a symmetrical philtrum, and rest everything will fall in place. So you know all these points, so I'm not going to the details. But in this picture, you can see the dotted line, how the lower lateral cartilages or alar cartilages are pulled apart, and how the midline is also displaced. While the cartilage on the normal side is a little deviated, but on the affected side is too much. This space is filled by soft tissue. So when the cartilages are pulled apart, this space is filled by soft tissue. So here also, when there is a cleft, the nature tries to fill this cleft and it produces more tissue. So there can be an excess tissue here and excess tissue here. So actually it produces more tissue in an attempt to fill that gap. So in cleft, there is no paucity of tissue. There is differential distribution of tissue, and that is what we do. If there is a paucity here on the medial aspect, we borrow more tissue from the lateral side. In whatever kind of cleft lip repair we do these days, after 1950s, we always borrow tissue from the cleft side or from the lateral side. So there must be sufficient tissue from in the lateral side. That is how it can donate tissue to the medial side where there is a deficiency. And also, if we see this part is deficient, this deficiency starts right from this filtral ridge and this highest point of the cupid's bow. Everything goes up here and becomes deficient. So if we can see here, the alveolus is collapsed and there is no cleft of the palate, and then there is a marked nasal deformity. You can see the base of the ella here, while the other base is here. So this is so much placed inferiorly and posteriorly. So, and you can see the direction of the nostril here and here. And this is so long and this is so short. Then the direction of the midline here. and the shape of the nostril on this side and the shape of the nostril on the other side, on the affected side. You can see the difference, and that is what we need to create, we need to correct. And if you see in an MRI, so this is the base of the ella, this is on the other side, this is the midline, and you can see the whole nose is deviated towards the affected side, and this is the actual midline of the nose, and this is the alveolus, and this is the other side of alveolus, and there is a cleft. So in a child, when you assess, if you see this child of an incomplete cleft lip, and if you look at the philtrum, look at the two sides of the philtrum, I will show you with different lines. So this is the highest point of the Cupid's bow on non-cleft side, and if you make an equal line, that should go there. So this highest point should fall here, but it is not. And this is the other side. So all these three lines are equal. Then this is the part of the Cupid's bow from the midpoint to the highest point, and this is on the other side. So the highest point of the Cupid's bow is here on the cleft side. So if you draw a line at the highest point of the Cupid's bow here, it falls here. But the highest point of the cleft side on the Cupid's bow is here. So there is this much of a difference, and this much of the tissue has to be brought in from the lateral side, to fill this gap. So in whatever type of cleft lip repair we do, we make it symmetrical. So these two sides, wherever we measure it from, has to be symmetrical. Whether we measure it from the base of the columella, from the nasal sill, or from the base of the ella, wherever. So it has to be symmetrical. So and whatever type of cleft lip repair we do, we need to see that this is symmetrical. So these are some of the results with different techniques. So you can achieve a good result, including the correction of the nose. So the measurements, the most important measurements are two: the height of the philtral ridges on both sides. Now, depending upon these measurements and the difference between these two, you have to choose a technique by which you are going to correct it, and tissue you are going to bring from the lateral side. The tissue is always brought from the lateral side. So you can have a triangular flap repair, or you can have a rotation advancement kind of a repair. So if you do a rotation advancement, you are creating a defect here by pulling it down, by rotating it down, and you advance flap from the lateral side. So let's see what are the different kinds of vermilion you see in the cases. So some of the cases will have a very prominent vermilion border, and while other cases will not have a prominent kind of vermilion border. And in Indian patient, the skin color is of very different kinds in different patients coming from different areas. So sometimes it may be difficult to find out the vermilion border where it is ending, right? So like in this patient, it is here prominent, but from the midpoint of the Cupid's bow, it is not even seen. So we have to choose different points on the vermilion border. So this is you can see the width of the sill on both sides. Then this is the midpoint of the Cupid's bow. This is the highest point of the Cupid's bow on the non-cleft side, and the equal distance you take on the other side. So this makes the Cupid's bow. Then you are taking a point where the vermilion border is ending, which has ended on the lateral side. But if you take a point here, this will go in upward direction. So you should take it in lateral direction, where I will show you with other drawings also. This is the midpoint of the columella, the bases of the columella on two sides, base of the ella, and base of the ella on the other side. Now base of the ella, some people take it from here or here, but you can take it anywhere, but it should be symmetrical on both sides. Then this is the red line. This is the border of dry mucosa and wet mucosa. This is clearly discernible. It is visible clearly. And if you mark it on both sides, you will see this dry mucosa is narrowing as it goes into the cleft on both sides. And on the cleft side here, on the medial side, it is much narrower than here. So at this point of the highest point of the Cupid's bow, you have to make it as thick as this one is. So you need to add some tissue here in the dry mucosa, not in the wet mucosa, only in the dry mucosa. So this is the thickness that you have to take for the dry mucosa, which is here and not here where the white roll is ending. So you have to shift it a bit lateral. So, and if you take the total width of the vermilion, it is equal on both sides. So these lines, colored lines, are equal. Now, if you take it here, it will be much shorter than this. So you have to place it a little laterally, where this thickness and the entire thickness of the vermilion and the thickness of the dry mucosa is equal to the highest point of the Cupid's bow, non-cleft side. So that's why you choose this point. So this point is not correct. So you need to move a little lateral. So this is not the point, this is the point that you need to choose. So that is how you choose the lateral point. And this is thickness of the dry mucosa on both sides. So you need to take some kind of flap from the dry mucosa from the lateral side and fill it in here. So a flap from here and an incision here, or a defect created here will correct this deformity as well. So you can see here this is narrowing, and we are taking a flap only in the dry mucosa, not in the wet mucosa, only in the dry mucosa, and we will fill it up in here. So this triangular flap is being taken in the dry mucosa only. So the defect has been created, and this is the triangular flap which will go and fit in here. This is muscle on both sides. So whatever kind of repair you do, you have to take this triangular flap in the vermilion, in the dry mucosa. So we pay a lot of attention on the skin, but not as much on the mucosa and the muscle, while we have to remember that the defect is not only in the skin, but also there in the muscle as well as in the mucosa, and we have to address defect in all the three elements. And here you can see the triangular flap going into and making this dry mucosa equal on both sides. So now some of the patients, so with the varied deformities, so I will not go into details, and we have to see the muscles around, because the muscles are also divided and they have an abnormal insertion at the base of the columella as well as at the base of the ala on the cleft side. So these muscles pull the ala apart, and these muscles pull the columella apart, and these are the regions for the deformity of the columella and the deformity of the ala. And therefore, this muscle dissection must be done. The muscle must be separated from the base of the columella as well as from the base of the ala, and it should be repaired in the midline here. And once you do it, and once you fix this muscle also to the base of the columella will become straightened, and the ala will also come medially. So we have to repair these muscles. So looking at this patient with a severe deformity of the nose, so whatever kind of flaps you choose, rotation, advancement. So let me give one example on one of the patients. So this is an incomplete cleft, but the difference in the filter ridge is significant. So this is not a narrow cleft. I mean, it is a narrow width-wise, but it is a severe cleft. So this is the midpoint of the Cupid's bow. This is the highest point of non-cleft side, and then you measure this, and at equal distance you put the highest point on the cleft side here, and then the midpoint of the columella, and then base of the columella and base of the ala. Now you can see this nasal cell is wider, so a smaller part from here will have to be removed. So you measure the nasal cell, and the difference has to be removed from here. Then you make a rotation flap, and I take it into the columella, and then I always take a back cut. So I'm taking a bit up in the columella and then a back cut. And then this is the C flap. I always use C flap for the defect created here and never take it on the lateral side. And then I create a small triangular flap here like Tennyson, but the dimension of this triangular flap is about 1 to 1.5 millimeters. So, and then I create a triangular flap here, and then I create a corresponding defect here. And this narrow defect is being created in the dry mucosa here, and a wide flap will be taken from the dry mucosa on the lateral side. So I just don't give an incision. I remove a curved mucosa from here to have a smooth curve here. So then, the advancement flap is also planned. So this whole thing is advanced like this. And the vermilion border is always cut perpendicular on both the sides. So there's a large flap here and a narrow defect created on the medial side. And this is cut here. I always cut the frenum, and I always give an incision on the sulcus. So this is the marking, and this is the muscle has been dissected. The dissection is more wide at the base of the columella and also at the base of the ella on both sides. But while we go towards the vermilion, the dissection is less wide. So this is the muscle being held. Dissection on a lateral side. So now after the dissection, you can see this small triangular flap will fit in here. So the muscle has been repaired. I usually repair it like a double breasting or sometimes by horizontal mattress to raise it so that it mimics the philtral ridge on the other side. So this is after the muscle repair, and this is a triangular flap which will be sutured here. And a small part, about a couple of millimeters, have been removed from this nasal sill. And the extra part of the C flap is removed, and the rest is sutured here. So in this patient, 6-0 absorbable rapid Vicryl has been used. So this is after the complete repair. And because I do a lot of dissection here, and I also separate the ella from the pariform aperture. This incision goes right up to the tip of the nose, and therefore I give these approximating sutures as well. So I will show it in some of the photographs. So you can see the vermilion is also symmetrical. Nose looks good, although there were not much deformity in this patient. So now coming to the height of the lip in some of the incomplete clefts. So incomplete cleft, in fact, the cleft side may appear longer than the non-cleft side because there is some excess of tissue, and you need not do anything. You never try to slice any tissue from here. Just a good muscle dissection and repair will take care of it. So once you repair, it becomes symmetrical. Or sometimes the lip length in a complete cleft may be much difference on two sides. So this is too small, it appears too small, but just a repair, a proper repair makes it equal and symmetrical. And the muscle. So you can see these muscles are bunched up here, and these muscles have to be brought across and sutured in this region, in the philtral ridge area. So this is just to highlight the importance of a dissection of the muscle and the muscle repair. So the muscle have to be dissected on both sides, and a wide dissection have to be done, and double breasting or a horizontal mattress suture should be given to elevate it so that it mimics the philtral ridge. And sometimes I give a suture here and fix it with a dermis to accentuate the philtral dimple. So double breasting or horizontal mattress, you can see a good philtral dimple here and a raised philtrum. So in both kinds of repair, you can see the good philtral dimple and the raised philtral ridge. So now coming to the piriform aperture, the entire the ella has to be separated by giving a piriform aperture, right? Keeping your knife on the bone, you have to separate it going up to the tip. So this incision, this is a very important incision. This will allow you to bring the ella medially in a tension-free manner. And if you do not dissect here well, you will have to do a lot of different maneuvers to bring it here, and the shape of the nose will never improve. And so you have to separate it, and you have to separate muscles also from the base of the ala. And to correct the alar flare, so there are 2-3 things important. One is good dissection of the muscle from the columella as well as from the base of the ala, and a cinch suture which is taken from the ala to the midline there and fixed to the anterior nasal spine or to the caudal end of the septum. So this corrects the alar flare. So piriform purge incision, good muscle dissection, cinch suture or alar cartilage dissection and suture. The closed, I always do a closed dissection of the nose. So, and the frenum or frenulum I always dissect because this is holding the entire lip structure here. So I always cut the frenum and create a defect here, and the tissue from the lateral side can be filled in here. So the muscle from the lateral side fills the defect of the muscle here. Skin from the lateral side fills the defect of skin on the medial side, and mucosa from the lateral side fills the defect here. So there is a deficiency in all the 3 elements, and tissue must be brought in from the lateral side to fill in that defect. So this you can see this is holding, and the moment you give an incision, the lip falls nicely. So you have to bring the mucosa from the lateral side and then suture it here. And I do a closed nasal dissection, and since I have released all the muscles from all the sides and then rearrange the muscle to the place where they should be, the nose falls in place just by doing a proper repair, proper dissection and repair. Even in severe cleft, the nose falls in place. And I do not open the cartilages in the nose and do not put sutures in between there. But even then, the nose improves with this kind of a dissection and repair. And even in triangular flap, you can see the nose can improve. And rotation advancement with a small triangular flap. This is again a rotation advancement with a small triangular flap. Again a rotation advancement with a small triangular flap. And you can see the good filter dimple here and a good filter ridge. Another patient, this photo we got by WhatsApp. So this is a pre-op and these are post-op. So you can see a good filter ridge and a dimple here. And another patient, a small triangular flap and a balanced lip with a good filter ridge and a dimple here. Thank you very much. And this finishes my talk on the unilateral cleft lip repair. And if there are questions, I will handle it here. And then we will take the bilateral cleft lip repair.
Thank you, Dr. Subodh Singh, for that excellent talk and depicting all the points of unilateral cleft lip repair. So the paper is open to questions. And I think 2 or 3 points which he brought out very carefully, that although Millard in his original description said that the medial lip element is sterile, you shouldn't cut the frenum, but in many cases unless you cut the frenum, you are not going to get that drop down. So that is one very important thing. And then the lateral V-flap is also very important for giving you the lip pout. And to make the red line, this is for the juniors, for the red line to get aligned. And as he said, you have to do a radical dissection all around, not only from the piriform aperture, but between the skin and the cartilages. And once you release everything, hopefully things fall in place as he showed. I have a question. What have you seen about the long-term results of these nose, which you just, you didn't do any rhinoplasty at that time, but did that stay over time?
No, I did not hear the question well. And can you...
Did the shape of your nose stay over time? The shape of your nose?
Yeah, it does. Right. So if I say it remains the same as it appears within 3 to 6 months of the surgery, it is not. Sometimes it changes, but nowadays, for last 1 decade or so, the changes are a little less with the experience that I'm gaining with the primary nasal repair in the with the cleft lip. So the changes are less, but changes do occur, and many of these patients do require preschool or secondary rhinoplasties. So not that if you correct it with the primary repair, so they will never require a rhinoplasty. They will, and there are methods that you can techniques that you can utilize to minimize the deformity later on. For cinch suture, you can use a non-absorbable suture. So many of the time I use absorbable, and I see the widening of the ella. And it is important to correct the alveolar deformity as soon as it is possible. So probably the NAM also helps in retaining the correction that we have done with the lip repair. But if the alveolus is falling apart, then there will be a deformity of the nose. But separation of the entire nasal ella from the alveolus and the separation of muscles from the base of the ella and its repair medially actually helps. So the nasal correction is more achieved by the correction of the lip rather than that of the nose itself. So that must be remembered by everybody. So the good muscle dissection and a good separation from the piriform aperture are the key to improve the nasal shape, and not just the dissection and open dissection of the nasal cartilage and suturing them. So that is what I have learned from my own experience.
Are you using nasal conformers post-operatively like the Taiwan group? Nasal conformers, are you using them routinely?
Yeah, nasal conformers, when available, they should be used, and we do not use it, unfortunately. It is not freely available, or we are not making sufficient efforts to make it available. So, when a good quality and soft nasal conformers are available of a suitable size, that may be used. And currently, we are not using them regularly. For some patients we have used, and the numbers are so small that I cannot tell you whether that made a difference in a significant number of patients. So, but those who have a good experience with nasal conformers may tell you better. But even without nasal conformers, the good nasal correction can be achieved. That's what I want to say.
The other thing is, I saw you giving lateral sutures along the alar groove. Are you giving a McCombs type hitch for your noses?
Am I giving what?
McCombs suture are you using
No, I don't give that kind of suture, but I make a visual image of where the cartilage would be, and I try to approximate them by several external sutures, right? So, and with those sutures, the nose appears to take shape. The 90% of the nasal shape comes from the dissection of the muscle and separation from the piriform aperture. And rest 10% can come with the suture that you are putting in nasal alar groove as well as in the ella, and even to the close to the tip. And sometimes I do put a suture on the tip region where I fix it blindly fix it with the cartilage on the other side.
Are you doing anything for the vestibular web primarily?
The vestibular?
Vestibular
I did not get the raw area.
Vestibular webbing, which will result as we bring in the nose, there's always a vestibular web.
The webbing?
Yeah. Yes.
Yeah, no, because I approximate the two layers with the multiple sutures in the ella. So hardly ever the vestibular webbing is seen, and I remove the excess tissue. So if you separate the muscle, you will find there is a lot of soft tissue as well. So that soft tissue has to be excised. So after the excision of that soft tissue and after the separation of muscle from the base of the ella, and if you go up and if you see there is a excess of soft tissue, you remove the soft tissue and then approximate the two layers of the ella. So, and with multiple sutures. Once you do that, the webbing is rarely seen.
Okay, any other questions from the...
Dr. Shubhat, this
But
is...
if you, yeah.
This is Dr. Prashant Kumar Bhattacharya from Kolkata. Thank you for a good elaborative lecture. And
I'm sorry because I mean your voice is coming from far off place and not that's why I'm not able to hear you clearly. And I hope I am
Prashant Kumar
clear.
Bhattacharya from Calcutta.
Yes, yes, Dr. Bhattacharya.
Good afternoon, and you have given a good elaborative lecture. I want to
Thank
ask
you.
one question only, that if it is a complete wide gap alveolar cleft, in unilateral cleft, what will you do in that case?
You said if there is a wide alveolar cleft?
Did you do any gingivolabial flap in those cases?
I think
Can somebody close to the mic can repeat that question?
I think the question is, are you doing a primary gingivoperiosteoplasty if the gap
No,
is
I'm not doing a primary gingivoperiosteoplasty, and if the cleft is wide, we are not also doing NAM regularly. So we have done NAM in some of the cases, but we have not done NAM regularly. In the beginning of my practice, I had done some primary gingivoperiosteoplasty, but I don't do it anymore.
Dr. Sobod, one question. Do you follow Millard's procedure regularly or Tennyson procedure? Randall Tennyson or Millard's? Which is your preferable procedure?
He's asking, do you do Millard's or Tennyson Randall, which is your procedure of choice?
I am well versed with the many different techniques. I have done several thousand Millards and several thousand triangular flap repair. But once you start doing, every surgeon modifies it. So I have done it. So I have done also triple wedge and other techniques as well. So I have done almost all the techniques known, and I have modified all of them. So my Millards is not the Millards that were described. My Tennyson is not the Tennyson that were described. But I'm well versed with all the techniques, and trust me, all the techniques are very easy for plastic surgeons to do, right? So you just need to understand the basic concept, design the technique, and do it yourself. So there's not, I mean, when we were residents, sometimes we were taught like what is the point number 1, 2, 3, 4, 11, 16, right? So we were too much engaged in remembering those points and the differences and measurements. But it is important for students to understand the basic concepts. Once they understand the basic concepts, they can find out the differences in the two sides, and they can they should know the basic techniques. And it is easy to learn both the techniques, and different departments follow different techniques. So they should see one or two techniques, and they should master one or two techniques initially, and later on they can modify in a way that suits in their hands.
What about bilateral cleft lip? Bilateral cleft lip.
I didn't get that, please.
I think you can start your second presentation, Dr. Singh.
Okay, sure. I'm doing it. So my second presentation is about refinements in bilateral cleft lip repair with primary open tip rhinoplasty, and I do an extended primary open tip rhinoplasty, especially in those cases where the cleft is complete and the premaxilla is projecting, and where the columella is very small. So you can see there is again a range of deformity in bilateral cleft, varying from very minor incomplete cleft to a wide complete cleft with a projecting and many times deviated to one side maxilla, premaxilla. So sometimes it appears it is very wide or one or both sides, or sometimes because of deviation it appears difficult. And you can see the premaxilla is projecting, and sometimes people will think that pre-surgical orthopedics or NAM is essential before you take up these cases, but those facilities may not be available at all places. And I have done 99.99% of my bilateral cleft lip without NAM and pre-surgical orthodontics. So I can say with confidence that if you do not have those facilities, don't worry about it and go ahead and start doing your bilateral clefts. So the goals are to get a pleasing narrow philtrum with well-defined cupid's bow, a long columella which is elusive, and a narrow tip of the nose, symmetrical lip, ala, and nostrils, and a good nasal airway. These are the basic goals that we want to achieve in a bilateral cleft lip repair. But the key issues are nasal corrections. So we need to achieve a long columella and a symmetrical ala in nostrils, and we need to preserve the vascularity of the prolabium as well and get good airway so that the patient breathes well after the surgery. Sometimes when the nostril is too narrow and the columella is too small and you have brought the nostrils up from the place where they were earlier, and the children are essential nasal breathers, obligate nasal breathers, and they find it difficult to breathe. So you need to pull the chin and lip to keep the mouth open. So we have done a lot of cases, and majority of them have been males, as the cleft is more common in males, and all of them had extended primary nasal dissection along with the lip repair, and none of them had pre-surgical orthodontics or NAM. The follow-up now has varied from 3 months to 8 years. So if this is the bilateral, this is how it looks when you expose it. These are muscles, and the tip is also open. This is the medial crura of the alar cartilages. On the lateral side, these are the muscles. So it is entirely open. This is premaxilla, and the prolabium has been lifted up here. So it's a wide dissection which is done in these cases, and I will show you some of the cases. At the end of the surgery, you get this kind of repair. Or I earlier used to put the nasal airway using sometimes some kind of a catheter or a nasal airway for them to breathe well. So the marking is done when we mark the cupid's bow, the midpoint of the cupid's bow here, and 3 millimeters later, lateral. So I used to make a philtrum wider in the beginning. I was afraid of its losing the vascularity, but now I make the philtrum much narrower compared to what I used to do earlier. So a rim incision is given on both sides. And then a good infiltration of xylocaine with adrenaline is done here in between the mucosa and the muscle, and between the skin and the muscle, then at the in the muscle as well, and at the alar bases and in the sulcus, and in the nasal tip as well. So good infiltration of the local anesthesia with adrenaline is done, and then you must wait for about 8 to 10 minutes before you start surgery. Now in the nasal vestibule as well as in the nasal tip and the base of the columella. See, the vascularity of nose and prolabium is excellent. So it has a robust vascularity. So the angular artery descends like a lateral nasal artery, and then it continues as a dorsal nasal artery and a columnar artery and the prolabial artery. So the entire prolabium has a very robust vascularity, and many small vessels are there, and many anastomosis is there. So unless you cut these main vessels, you will not damage the prolabium. And the key to preserve this vascularity is to keep the soft tissue thick and dissect as close to the bone as possible and as close to the cartilages as possible. So you should be close to the cartilages and close to the bone. This is how the dissection starts. The dissection is close to the bone here, and a thick prolabial flap is raised. And then the dissection goes up, remaining close to the medial crus of the alar cartilage on both the sides. Once that has been done, keeping this flap thick, you can cut it here. Now this dissection can go up to the bridge of the nose, and you dissect the entire nasal dorsum supraperiosteally. Now these are now to bring this closer like this. So once you put some sutures here, the columella will be lengthened, and it is important to suture this part because this part will also add 1 millimeter or 2 in the length of the columella rather than going higher up in the nose, and I will tell you why. So then you suture the muscle in the midline, suture the muscle in the pars marginalis, in both unilateral and bilateral lips. It is extremely important to repair the muscle in the pars marginalis. Then bring the two medial crura together, going up to the tip here, and then you can bring back the prolabial flap and suture it here. So that rest part of the hip is easy. You suture the prolabial flap here, then again, because this was dissected, I put several sutures in the sulcus and up to the nose on both sides. And these sutures are removed after 7 days. This approximates it and makes airway very clear. If there is a long columella, airway is open. But initially I used to put this kind of a stent or some kind of a catheter opened here, but these days I avoid that. So you can do this kind of dissection and you can close it and put a catheter there. So the nasal conformers, nasal oxysates or silicone catheter should be used. And when I say preferably for 6 months, I have used only for 7-8 days in most of my patients. But the steroid tip should be applied for at least 2 weeks. And you must preserve all the vascularity, keeping the prolabium thin. Keeping the prolabial thin and keeping the prolabium thick and keeping the dissection close to the premaxilla, and also the dissection should be close to the alar cartilages, the medial crura of the alar cartilages. And patient selection is extremely important. The patient should be healthy. There should not be any upper respiratory tract infection as well. I mean, other lower respiratory tract and other things are, of course, a contraindication. So you should avoid any patient who has had even the upper respiratory tract infection in the recent past. The patient should be well nourished and no URI. And also there is a learning curve in this, and therefore you must observe somebody doing it before you start doing it yourself. So the breathing is easier in post-operative time in this technique, but most of the patients where we were not doing the primary rhinoplasty, they used to have problems in the breathing in post-operative period. So we have followed a lot of patients for sufficient period of time, and we have found that they had a reasonably good results with a good nasal cell and a good columnar length and a good lip height. So these are some of the patients. This is the immediate result after 7 days. The same patient after 6 months, 1 year, and 22 months. Another patient, you can see the short columella here, and after 7 days, you can see after the removal of sutures. So the long columella can be seen, a good open nasal airway. After 6 months, 1 year, 18 months, and 2 years. Another patient with short columella, immediately after removal of the suture, 6 months later, 1 year later, and then this is a 6-year follow-up of the same patient. Another patient with a very short columella and projecting premaxilla, immediate 7 days post-op, and this is 3.5 years post-op. Another patient, immediate post-op, 7 days post-op. Here also the columella is negligible and premaxilla is projecting. This is a 7-year follow-up of the same patient. You can see here the columella is much wider than I would have liked. And this patient at 8 years follow-up had a good columella and good nasal airway, but the problem in many of my patients was that this nasolabial angle was very obtuse. So rather than going on the upper part of the alar cartilage close to the tip, I started using the bases here, which is turned laterally. So this gives you about 1 millimeter or 2. I fix it medially here rather than going much lateral here. So I remain here and suture this. So I'm suturing this part, and I'm not going much lateral to lengthen the columella. So if you do not do any nasal correction, the columella looks like this. But in a similar patient which has a negligible columella, if you do an open tip rhinoplasty, the columella appears like this. Another patient, no nasal correction, no primary open tip rhinoplasty. The columella is very short and nostrils appears compressed. But if you do an open tip, it appears much longer. Another patient, in the patient where the open tip rhinoplasty was not done. So this is 8 years follow-up. You can see the columella and the shape of the nostril, and the nasolabial angle again in this patient is much obtuse. And in other patient where open tip rhinoplasty was done, you can see the long columella and good shape of the nostril on both sides, and the nasolabial angle remains obtuse, but it's not worse than what you saw in a previous patient. So, but immediate you can say, even in the projecting premaxilla cases, you get immediate good results, is a 7 days results in bilateral cleft lip patients, and the angle is not too bad. So there can be some complications. The complications are not severe. So we saw some mild inflammation and redness in 10 patients, transient venous congestion in 17 patients, a nasal asymmetry in 16 patients, ischemia and necrosis of prolabium or premaxilla in none of the patients, and infection and dehiscence in 3 patients. So return to OR for bleeding from anterior palate was in 2 patients. Notch in ELA in our initial surgeries appeared in immediate post-op but improved later. Pinched up nose in 4 patients and the breathing problem in none. So these problems are actually the problems of technique. So you improve with time. So notch in ELA and pinched up nose you can improve upon as you get more experience. And the take-home messages that I would like to give is that primary open tip rhinoplasty in bilateral cleft lip is safe and has its own advantages. And having done bilateral lip surgeries with and without open tip rhinoplasties, I can say that this is a safe procedure. And in complete cleft lip cases where there is a very short columella, I would go ahead and do a primary open tip rhinoplasty and not without it. And if you are doing a bilateral anterior palate repair along with the bilateral cleft lip repair, it causes no vascular problems and you can safely go ahead and do it. And the columeral length that you get with open tip rhinoplasty and nasal definition is much better when you do it rather than when you don't do it. And the nasal conformer should be used, although I have not used it for a longer time. And at the end, I would like to say that it has a learning curve, so you must learn it before you embark on doing it. Thank you very much for your patient hearing.
Thanks, Dr. Subodh Singh. One question can be taken. Because of the shortage of time, one question can be taken.
I am Gautam Guha from Kolkata. You are doing primary
I'm not able to hear it. So if somebody can speak in the mic of the computer or something kept near, so I can hear that.
You are doing primary rhinoplasty in cases of bilateral cleft lip cases. But
yes.
You are not doing the same that is primary rhinoplasty in cases of unilateral cleft lip where the deformity is more asymmetric and sometimes more severe also.
I'm sorry, I'm not able to hear it.
He is asking that you are advocating a rhinoplasty at the same sitting for a bilateral lip, but why aren't you doing an open rhinoplasty in a unilateral lip?
Because it is not required in unilateral lip, and I'm doing a rhinoplasty in a unilateral lip as well, but it is a closed deformity. The unilateral cleft lip, the deformity is only one side because one side of the alveolus has fallen apart. So all the deformities are centralized there. So in bilateral cleft lip, the deformity is symmetrical on both sides, and as there is a cleft in the alveolus as well, the middle part, the central part, the premaxilla goes up, and because there is no pull on the columella and nose, so the columella remains small. So, and therefore it is important to lengthen the columella and open up the nose. But in unilateral lip, there is no requirement of opening the nose, and therefore I do not do. If it was required, I would have done it.
Thanks, Dr. Subodh Singh. Excellent display of surgical cleft lips. Next speaker is Dr. Rakesh Ken. Craniofacial clefts, clinical presentation, classification, treatment strategy. Thanks, Dr. Singh.
Thank you so much. Thank you so much for your patient hearing.
Dr. Ken's videos are not playing, there's a problem. So his video presentation will be tomorrow. He is giving tomorrow's talk just now.
Chairperson, delegates. So I am presenting on craniofacial cleft. I am very much thankful to the Association of Plastic Surgeons of the Odisha for giving me this opportunity. As we know, by definition, the craniofacial cleft are different from the facial cleft. They are other than the common cleft of the lip, palate, and they are known as the rare craniofacial clefts. They occur in the various pattern in varying severity. They occur along the predictable embryological lines and can be unilateral or bilateral. You can get a different type of cleft on one side, you can get a different cleft on other side of the face. Incidence, when I try to retrieve the incidence, it's a variable. This is also not a true incidence. And nowadays, the people are more and more focused on the deformity of the maxilla and centered over the orbit. And they are more focused on the presence or absence of the alveolar cleft along with the craniofacial cleft. As we know the embryology of the face, how the face is developed, that means there are a lot of processes are developed around the ostromodium which form the future mouth. And these processes, they form the various part of the face, we all know about it. And failure of the fusion, how they get failed, that develops the craniofacial cleft. So there are a lot of theories about the failure of the fusion, failure of the formation of these cleft. So one is the failure of the fusion. This is the old theory, which was given by the Darcy in 1869. So failure of the fusion of the process, that leads the cleft. Then theory of the mesodermal penetration came. When there is a failure of the penetration of the mesoderm leads the craniofacial cleft. This is more acceptable theory. After that, there is a theory of the neuromeric theory, which is given by the Carsten in 2000. And according to him, the brain predicts the face. Means the face develops from the series of development. This is a neuromeric theory. That means the face develops from the series of the developmental field, each with a specific cellular content and the genetic definition. And there is a unique barcode for each neuromeric zone, and which is shared with all cells existing a particular level to form the mesoderm and ectoderm of the embryo. And this system permits the mapping of the face into developmental zone with distinct spatial origin in their precursor tissue unit. And very interesting point of this theory is the anatomical and the clinical observation of the Tessier and his classification system of exactly comparable with this map. So this was a neuromeric theory given by the Carsten. I'll come on to the classification. According to American classification, which is the American Association of the Palate Rehabilitation, given by the Karfik, and other classification are the Karfik, given by the Karfik and the Tessiers. So one interesting thing about the presentation of these cleft, you cannot put these cleft in a particular class because the presentation is very much variable. And till date, none of the classification, existing classification, can clearly define that this particular type of deformity belongs to particular type of cleft or particular type of class. So according to American classification, which is proposed by the Harkins in 1962, there are the four, they classified in the four major category. One is the mandibular cleft, second is the nasoocular cleft, and another is the oro-ocular cleft, which was the two type, and then there was the oro-oral cleft. The disadvantage of this classification were there was not based on any bony landmark as referral point. Major midfacial cleft find no mention in its, there is no description about the median facial cleft, and oromedian canthus cleft is described as part of the oroocular but drawn as a oro-nasoocular cleft. So there was a disadvantage. After that, there was a classification given by the Buchai. He mentioned the importance of the infraorbital foramina. So any cleft which is going medial to the infraorbital foramina is the type 1, and which is lateral to the infraorbital foramina is the type 2. But there was also the problem because these clefts are not the fine lines, so you cannot say that which one cleft is going lateral or medial to the infraorbital foramina. Tessier classification most widely used and acceptable, and most of the cleft we can classify according to Tessier's classification, and it was proposed in 1973 and published in the 1976. Tessier devised a system in which a number is assigned to the site of each malformation depending on the relationship of its midline sagittal plane. Midline sagittal plane. So you can see in the another photograph the midline sagittal plane, and it moves from the midline sagittal planes laterally. So he given the name, two important aspects. One, which is cleft which is cranial to the orbit is the cranial cleft, and which is cleft which is caudal to the orbit is the facial cleft. And interestingly, any cleft which is the facial cleft, it has on its counterpart which is extending into the cranium. And the number was started from the midline sagittal plane, that is the 014, and when you move laterally 113 to 12, and like this. So this was the classification of the Tessier. The problem with the Tessier is the difficult to describe all type of the cleft. All presentation of the various craniofacial cleft can't categorize, and there was a lack of description of the encephalocele and the dermoids. It doesn't provide the detailed picture of the specific features, and it's failed to describe the nasal aplasia, anophthalmos, microphthalmos, proboscis, and so many other things, abnormal things, which cannot be, they are not mentioned in the Tessier's classification. Then there is another classification that was a spectacular frame classification. Those who want to go in the detail about this spectacular frame classification, it is published in the PRS January 2012. They can go through it. Midline craniofacial cleft or the median craniofacial cleft, which is the 014 cleft, further classified by the two of the important persons. They were the Derek C. Vaughan and the Henry K. Kawamoto. This was published in the Plastic Surgery Journal. The classification of the median craniofacial dysplasia of the midline Tessier cleft, which is a 014 cleft, according to them the presentation is variable. According to them, they are the three types. One is the median craniofacial hypoplasia, means there is a tissue deficiency. Second is the median craniofacial dysraphia, means there is a normal tissue volume but cleft. Third is the median craniofacial hyperplasia, means there is a excesses of the or duplication of the face. Now, one by one to different cleft, how they present. 014 cleft is the midline frontonasal encephalocele, present with the encephalocele, may present with encephalocele. Median cleft of the, there is a median cleft of the lip and nose, and there is maybe a wide gap between the canthus. 130 cleft is the, it passes through the pyriform aperture. You can see in the bony, in this picture, lateral to the nasal spine and the septum. Orbit is displaced laterally, and you get the notch in the ala. These are the examples of the photographs of the cleft 113. 212 cleft is present with the nasal ala cleft near the base, orbital dystopia in the microophthalmos. You may get the hairline or eyebrow malformation. 311 cleft, the characteristic of this cleft is a defect of the maxilla and the infraorbital rim or the floor, orbital dystopia and the microophthalmos. 410 cleft, you see here the example of the 410 cleft. There is a cleft of the cheek, cleft of the lip lateral to the cupids. You can point out here that it is lateral to the cupids and meets lower eyelid medial to the punctum. Is continue as a number 10 cleft, present with the cleft or notching of the upper eyelid. And there is a cleft between the lateral incisor and canine. Remember, the cleft 410, there is a cleft between the lateral incisor and the canine. The orbit, maxillary sinus and oral cavity, they communicate. 59 cleft is a cranial extension of the number 5 cleft. You can see here how severe it is, found in the superolateral angle of the orbit, eyebrow involvement, eyelid involvement, orbital floor divided into its lateral third, and it's a very extremely rare cleft. Number 5 cleft is a lip is cleft near the corner of the mouth and courses up to the lateral third of the lower eyelid and across the cheek. Passes lateral to the infraorbital foramina to the middle third of the orbital floor. Orbital maxillary sinus and the oral cavity may be confluent, and alveolar cleft in the premolar region. This is a difference from the 410. So the 910 cleft is run towards the supraorbital rim. You see here, supraorbital rim, and the 10 cleft run towards the frontotemporal region. So this is the, okay. 10 is continuing with the superior orbital fissure, and 9 involves the rim, eyebrow and the forehead deformity. You can see the deformity of the eyebrow and the forehead. Number 6 cleft represents the incomplete form of the Treacher's-Collins syndrome, and there is a coloboma of the lower eyelid at the junction of the medial 2/3 and the lateral 1/3. There is anti-mongoloid slant of the eye. Cleft starts from the eyelid and is directed towards the angle of the jaw. Number 7 cleft, there are a lot of names are given to this cleft. Actually, we call it the macrostomia. So this number cleft is starts from the lateral aspect of the angle of the mouth. And underlying problem, you may get the deformity of the lateral alveolus extending up to the pterygomaxillary junction, hypoplastic zygomatic arch, and the preauricular skin tags. So it is very much common. Number 8 cleft is seldom seen as an isolated deformity. It begins near the lateral canthus and extends temporarily. I have seen it was extending up to the occipital region. The osseous component lies in the region of the zygomatico-frontal suture. A bony notch can be palpated in at the same site. You can see the example of the number 8 cleft. When there is a combination of the 6, 7, 8 cleft, means there is a deficiency of the zygomatico-maxillary, zygomatico-temporal, and zygomatico-frontal suture that resulted into the absence of the zygoma, and this is the true picture of the Treacher's-Collins syndrome. Number 30 cleft, I don't have the photograph, I have seen only a single case in my career. Now, come to the craniofacial cleft. So each malformation is unique, and therefore treatment plan cannot be generalized. Only certain guidelines and principles can be followed, and one crucial decision is the timing of the surgery. As we know, the brain develops very fast in the first 3 months, 6 months, and it doubles in the 6 months, tripled by the 2.5 year. So considering this fact, the intervention should be tried if it is affecting the growth of the brain. And associated facial deformity can be corrected at the time of the primary intervention. When facial clefts are associated with the synchondrosis, you look for the synchondrosis, correct it. Wide open skull defect is there, and then do for the correction of the defects. If there is a mid-phase hypoplasia, address the mid-phase hypoplasia and plan for it. Orbital dystopia, look for the dystopia, shallow orbit and hyperoptosis, and look for the deficiency of orbital rim, orbital asymmetry. And there is, because of the most of the time the cleft is passes in the line of the nasolacrimal duct, there is, you get the abnormality of the NLD, and do something for this, and if there is a deformed nasal radix, do the nasal correction. If the malformation are mild, and the surgery should be delayed, and patient with the ocular involvement, if there is a exposure keratitis, do something for the correction or the reconstruction of the eyelid. Ectropion is managed by the back cut or at the tissue, or you can use the forehead flap. In case of the inadequate local tissue, forehead flap or nasal flap can be used, or do the medial canthoplasty. Here you can see here the cleft in which the forehead flap has been used for the nasal reconstruction. For the nose, median cleft correction may be done in the early childhood. Primary rhinoplasty for the bifid cartilage. Paramedian defect of the nose is reconstructed using the cartilage graft or composite graft for the asymmetry and the notching. Alar retraction may be corrected with the local rotation flap or the Z-plasty. Correction of the nasal septum duplication is done after nasal growth is attained. For example, the oronasal nasoocular cleft, which is the 311, 410 or 59 cleft, when the deformity is there and eye is exposed, you can do the soft tissue correction by doing a good planned Z-plasty. So you can see in this picture how to design the Z-plasty and to bring the tissue from over the nose to lower eyelid, and lower eyelid is pulled up. So you can do in this manner Z-plasty. And when there is a soft tissue deficiency, you can use the forehead flap for the reconstruction of the nose. Alar cleft is a very big problem, it's very notorious to correct. Because of these bilateral problems, sometimes bilateral or unilateral problem, you can use a composite graft for this, or here we have used the forehead flap even for this deformity. Even it not looks very good. So there are different methods for the correction of the alar cleft. And oral commissure for this lateral cleft or the commissure cleft, you can do the correction, and the problem can be addressed at the age of the 3 to 6 months. And good mobilization and reorientation of the orbicularis oris muscle. And when there is a divergent or convergent non-paralytic strabismus, the ophthalmologist should be involved. For mid-maxillary deformity, correction can wait till the adulthood. Repair of the orbital dystopia and the hypertelorism is delayed until the orbital maturity attains, which may be up to 6 to 9 years. And for the mandibular reconstruction, you have to wait. You can use the fibula flap. I have observed that even the deformity is severe and you cannot correct it, sometimes the prostheses are good. So you can use the prosthesis for the rehabilitation. All in these cases, even you have done the cranioplasty, underlying bone, you have done something for the bony correction, you can put even then the expander, and that expanded skin can be used for the soft tissue reconstruction. So the tissue expander can be used in the craniofacial deformities. Craniotomy is one of the important, the basic step for the correction of the different deformities of the craniofacial cleft, because many a time you require the transcranial approach for the correction of these craniofacial clefts. So for that you have to be familiar with the cranioplasty to remove the frontal bone flap and to mobilize the brain and to correct the deformity, like in here the example of the hypertelorism, or when there is a cleft of the midline, you can remove the these air cells of the ethmoid air cell, dilated ethmoid air cells, you can remove, you can do the osteotomy and correct the deformity. Similarly, when there is a cleft associated with the encephalocele or the defect at the skull base, or anterior skull or in the anterior part of the naso-orbital ethmoidal region, you can do the C osteotomy of the orbit and can mobilize both the orbits and can bring them closer and can correct the hypertelorism, as well as you can fill the bone into the bony defect. And for the approach, when there is a cleft is passing through the nasoocular or naso-orbital region, when you want to approach, you can remove the frontal bone flap or the supraorbital rim for the access, and to approach it, reduce all the contents of the brain posteriorly, and to apply the bone graft. Bone graft you can harvest from the same frontal bone flap. Sometimes you get these deformity, these patients when they were operated by the neurosurgeon, and these are very challenging patients because of they have intervened once and you don't get the good plan of the dissection. But again, you have to remove the all biomaterial, use the autologous tissue, autologous rib graft or the iliac crest graft. You can use it and try to correct the deformity. Sometimes these are associated with the intracranial anomalies like the Dandy Walker or the dural cyst. You involve the neurosurgeon, they will do for this. All the abnormal bones which is present in the facial cleft region, there should be excised. You get a lot of extra bone, dilated air cells that can be excised, and you can remove it and try to give a good shape of the face. Many a time you require the multiple intervention for the correction of the craniofacial cleft. Repeated because of the patient comes to you for the further correction, then you keep on doing it. And in this patient, I remember the more than 16 or 18 time I have intervened for the correction of the nose. And you require a lot of things to do because of the tissue is fibrous tissue, not soft, but you have to plan accordingly. You get the patient like the proboscis, when you try to bring it as a flap, this part of the nose, we brought it there at the site of the nose, but the appearance of the nose was not good, and finally we planned to do a arm tube flap because of the forehead skin was very thin and there was underlying osteotomy for the hypertelorism correction. So, like in the case of the facial bipartite also, you see the midline cleft, this cleft, and there is a sincipital type of the encephalocele coming out from the base of the skull. In such type of thing, you require the transcranial, means the bicoronal flap, transcranial approach, as well as from the buccal sulcus. You have to mobilize the orbit and the maxilla in the single unit, and both orbit are mobilized and they are brought medially. Then you can only close this cleft. So, this is a facial bipartite. When there is a deficiency of the bone, you can harvest the bone from the rib or you try to correct the nose, whatever deformity according to the deficiency. In case of the nasolacrimal duct abnormality, you have to learn the process like the DCR, dacrocystorhinostome. It's a very easy procedure by which you can stent these nasolacrimal duct system and you can drain it inside the nasal cavity. So, many a time you require the DCR for these patients because of the cleft is passing through the nasolacrimal duct area. And bony defect, you can harvest a lot of bone from the same bone, frontal bone flap, you can split it, or you can harvest the bone from the rib or the iliac crest. But most of the time, I harvest the bone by splitting the calvarium. Biomaterial I do not use in these patients. I avoid using this, but sometimes when there is a requirement is more, large volume is required, I use the matpore for the augmentation of supraorbital rim or for the reconstruction of the supraorbital bar. So, periorbital correction you can do, you can use the forehead, you can do the celastic stenting by doing the DCR. Many times you get the problems like sometimes there is the appearance of some swelling, and that is because of the entrapment of the mucosa, abnormal mucosa in the line of the fusion or in the line of the clefting. So, that abnormal mucosa forms the mucocele that has to be excised completely, our lining should be removed. So, the mucocele is a big problem. So, techniques used are unique, age specific, and according to the demand of the reconstruction. And if I summarize the birth to 1 year, what you can do, you do the cleft lip palate, soft tissue, suture release. Up to 5 years, you can do the orbital translocation, nasal deformity correction, you can plan, box osteotomy for the hypertelorism. Up to 5 to 10 years, you can go for the alveolar bone grafting, orthodontic treatment, severe maxillary bone defect can be dealt during this age. 10 years onward, completion of the growth, you can do the contour defect, eyelid defect correction, bony defect correction, and go for the orthodontic treatment. At the completion of the growth, do mid-face surgery, rhinoplasty, and the orthodontic treatment. Now, where the lack of consensus of the timing and technique used at each stage of the reconstruction, multiple intervention and limitation of desired result. The management of this complex problem remain in a state of the evaluation. However, the technical requirement must be balanced with the careful judgment and the benefit versus risk. Thank you.
Dr. Rakesh. Now it's open for questions. Any question?
Six months, sir. 6 months. 6 months, but you have to take in consideration the other points also.
And what is the maximum age?
Anytime, sir.
Anytime. Okay.
Because the patient comes late to you. They
Okay.
do not come at the right time.
And what is the mortality rate out of this?
10%. I lost 1%. Actually, I lost one patient because of the ICU problem, not because of surgical complication.
Okay.
ICU is a very important aspect of the management of these complex problems. So lost the one patient because of the tube got slipped. It got came out. So they could not intubate timely. So that got the brain dead. Otherwise, surgical complication you have to take care of, well plan it, and reduce the bleeding. Then it's not a very big mortality rate. It's not very much.
Since duration of surgery is long,
So we have reduced the duration of surgery. We have reduced 4 or 5 or 5 or 4 hours. Most of the patient I extubate in same OT. We don't send the patient to the ICU even.
Okay.
Most of the patients, 60-70% patient, I tell them to extubate them, and most of the patient I finish in the 4 hours. And another thing which may not be a good message, always involve a neurosurgeon, but I never call the neurosurgeon. But I'll suggest, because I am trained in I have got my training in the neurosurgery 1 year residency, so I do all these flaps, all frontal flaps, mobilization, mannitol, what to do, how to deal with the brain. So I do it. I do not call. But because I am working in the government sector, I always send a call to them, stand by, I can call you. And some complicated case in which the brain is herniating through coming out through it, they comes to you. But in like a simple plagiocephaly, you want to move a bone forward. I don't call them. And I think the neurosurgeons, they don't enjoy even, just they will give you the bone, you will reshape it, and they will wait for you. So that reduces the time.
what commonest complication you faced during your practice?
CSF leak. When you do the hepatologism, when suppose you have injured the dura and you could not notice intraoperatively, later on when you put the drain, your drain, that thrombobag drain will full with the CSF.
And how to manage that one?
By giving some drugs which reduce the CSF production, gradually it settled.
Diamox.
Diamox. We give the Diamox.
Okay. Thank you. Thank you.
May I now call upon Dr. Dinesh Kadam. All of you must be knowing, he is the editor of IJPS, and he has done a wonderful job by recently digitalizing all the old archives. All the old archives of IJPS have recently been digitalized, and they are available for everybody to view. So he is going to talk on orthognathic surgery. Dr. Dinesh Kadam, please.
Respected Chairperson, Madam Nakshay, all the respected delegates, and first of all, I'd like to thank for inviting me for this conference. Bhubaneswar is not new, but coming to this particular conference is, of course, for the first time. The topic which I am going to speak to you is not very commonly done in many places. So I think it is very important for us to, this is not very difficult, like what Dr. Rakesh spoke is something which is, you need really expertise to do. I mean, you need a training Here you can do it yourself if you are doing a maxillofacial trauma. So what defines normal face? It's there are a lot of beauty, the ratios, including it is there in the nephritity, and the normal what is in models which you have seen, and it is said in ratio in nature also. But for us, we need to have some proportions to define. That is, of course, the upper, middle, and medial to lateral and lateral to medial. But the perfect bilateral face is symmetry is largely a theoretical concept. It is not actually a practical. If you look at this particular one study which is published from the Taiwan, see the first the black and white is right and left. The middle one is left it's a mirror image of left. Left plus mirror image of left. The red one is right plus mirror image of right. If you see all three are different. So the left plus left is different. Right plus right is different because left is more a smiling face and right is more. So there is if you make it right and left is definitely a different. It is not symmetrical. That is what is trying to say. So the normal is point at which we can define and what the patient can accept. So we get to see these kind of deformities with oval face with a lot of functional problems. Now, are we comfortable in treating these patients? The orthokinetic surgery is basically from Hugo, who was actually a student of Harold Gillies also, and Paul Tessier. So they were all contemporaries. Paul Tessier were doing craniofacial and he was doing on the lower jaw and the maxilla. So it complemented each other. So it is an essential armamentarium for today's plastic surgery, and which involves correction of functional as well as aesthetic considerations. There is a lot of proper planning and precise diagnosis which is important, which includes orthodontist, that is a dental team, and the prostho, speech and all that is there. Planning includes, I'll just show you a few examples of clinical examination, cephalometry, photographs and all that. It's like, for example, this is extraoral photographs you take, and then this is analyzed in terms of both X-rays in the profile views, and then these are detailed analysis is done both soft tissue and as well as bony, radiographic cephalograms, and then intraoral photographs to see the dental occlusions and take the impression. And these are actually, they do orthodontic corrections to decompensate all these compensated dentition. And then this is pre-surgical orthodontics, which is important. For example, in open bite, they can correct it and bring it to a compensated, decompensated status so that you can bring it. Like, for example, it's open bite, and once you correct it, so you will see that maxilla is backwards and the mandible is forward. So this needs to be corrected. So there is a surgical correction which needs to be done and with the periodontic orthodontist. So this is actually for the making impression as well as models. So this model is made by the orthodontist to create for a mock surgery. So we need to know exactly how much, for example, so this. You can see this is the model. Once we do the mock surgery, we can bring it forward and backward. How much to bring, again, they give the splint and all that. So this can also be done by 3D cephalometry. Nowadays they are doing it. For example, this is the maxilla and this is mandible. Then you can bring, this is a gap which needs to be brought forward. So we do a splint so that you can, in the introp, it acts as a guide for us to do. So these are 3D virtual planning. Once you do the mock surgery, you can create a splint here. Now the types of procedures are genioplasty, which is simpler of all, which involves only the chin, and bilateral sagittal, that is the bringing the entire mandible forwards, and maxilla, and then bimaxillary, that is maxilla and mandible together. This is genioplasty, is bringing the jaw, the chin forward, either forward, backward, or reduction or augmentation. Or even you can reduce the transverse the width also. For example, in this case, you can see this chin is backward, and if you take the X-ray, and it looks like the lip is very prominent, but once you correct, like this is the so this is the planning. We can, once you do the cuts, so this is once you mark the cut and then mark the midline and then do the cut. We need a saw which is NSK is good enough, or any handy saw with a thin blade you get. So the entire chin is cut. This is the nerve is spared, and then you bring it. So once you bring it forward, you know how much to bring it, and then you can plate it. So this is, you can get this is the simplest possible. So in facial asymmetries also you can correct. You can see there is a chin deviation along with soft tissue that is in lipodystrophies. So this can be corrected again. You can see this is the midline shift which is corrected here, along with other adipose facial flaps and all that. So this is the post-op, and then you can see this is 13 years post. You can see the stable results with the free vascularized ALT flap also for the augmentation of the G. So this patient came thinking that this lip is prominent, but if you look at lateral profile, you will see that chin is very, very short. The chin is very retruded. So if you just correct the chin instead of doing the lip reduction, and we bought because her soft tissues are quite thick, and we brought forward at least about 5 mm, and then you can see the difference in her facial profile, and what was appearing very prominent lip has become a sort of acceptable. Of course, you will get to see these kind of deformities with asymmetries, which can be corrected with the midline shift. And again here, you can see this can be corrected either with the soft tissue correction or bony or implants, whatever. Then you can correct this chin also. Then only you can get the midline harmony. Like I did put a Medpore implant for this. That was because that was easiest possible which we can do. And then of course the midline correction of the chin with the genioplasty. And we can shift this. You can see this is the midline we marked, proposed, and then what is actual. And this can be after the correction. And you can see this is the correction. So the Medpore implant is filling the mandible, and then the chin is corrected well. So this is a stable results, 7 years post-op. Of course, he has put now very weird, but still we can make out the chin is in the midline. See, here you have a little prominent chin. Although she is a cleft patient, her maxilla is, of course, is now, if you see the occlusion, it is good, but chin is, she was very worried about chin. And then this is what we need to reduce the chin now. So once we expose, just to show closer. So once we expose, then we can mark the again midline. Marking the midline is important, and leaving a bit of cuff of tissue is here, muscle, because otherwise you'll have a sag of the chin. That will cause sort of witch deformity. That we need to be careful. And then this is the marking. One is we are planning to reduce the vertical height. So that means we need to have 3 cuts. So in between the thickness which I am going to reduce is also marked here. So this is the thickness I am going to reduce. This is the RQ. This is the thickness, the height of the. So once we do the cuts, the lower chin is attached to the soft tissue. Only the middle portion I am taking it out, a portion of it. calipers is used so that we will have a uniform cuts. And then you can, this is the cut we have done. So this can be easily, see, this is the bone which I am going to remove. Okay. This much bone is removed so that the vertical height is reduced. So once we do this, then we can.
So this is what we have removed.
This is the bone I reduced. So this can be brought forward and fixed with the plates, mini plates. This is not very difficult operation, and anybody can do this, but you need a little bit of planning. This is the, you can use mini plates to fix this, or 1 mm or 1.5 mm plates with a 4-hole or 2-hole is also good enough. So you can see the difference in her face. See, this is a prominent chin. This is after the correction. So you can, this correction is, she is quite happy with this. So BSSO is like we are breaking forward the entire mandible. So both sides you are giving cut. This is for a representation how what exactly it is done. Like suppose you have a prominent mandible like this. So you are going to give a cut on both sides. So you are decomposing. This is what the orthodontic surgeon is going to do. So once we do that, then you remove the bone and push entire mandible back. So this is bilateral sagittal split osteotomy. That is, you are splitting the mandible in the sagittal way and also preserving the nerve here. So this is how it is planned, and these are the cuts, different cuts by, this is the originally described by Obigozer, and he changed it now. Now what we use is basically a dull point. We described, these are the cuts which are markings, and this is how it is planned. So if you are bringing forward the jaw, you are bringing the jaw forward, or if you are setting it back, then you are removing the bone and setting it back. And these are the steps of osteotomes. And this is a splint which I told you that this is what is the planning. In the planning we keep the splint so that we are only doing the occlusion based on the splint. Because once you bring forward, because we lost completely all the occlusion, so all the points are lost except this splint, which is the guide for your occlusion later. So for example, in this we have a she is a prominent chin, maxilla is. You can see after the orthodontic treatment, the chin is forward, and is basically prognathism. And here we done the cuts both side and fixed it both side. And you can see intra-op, this is the occlusion, and this is the post-op. You can see her face from this to this. On the lateral profile, you can appreciate her maxillary, the mandibular protrusion is corrected, and even her occlusion is corrected. Yes, completely. So in asymmetric mandible also we need to do this. We do the bilateral sagittal split osteotomy and then correct it, and you can get a good stable occlusion and results. Now maxillary osteotomy, that is Lefort, where you cut the, just like a Lefort fracture. So this is a controlled fracture. You cut it and then bring forward. Basically in maxillary hypoplasia, especially in cleft and other issues. So you can, so this is the osteotomy, and then bring it forward and fix it just like a Lefort osteotomy. So this is the three-dimensional. I'll go to, this is the position. You need to mark this so that the midline is lost. So this is important. And then incision on the sulcus, and then these are the osteotomy cuts where you can do high osteotomy or little low based on the maxillary hypoplasia or the pathology. And rotation, either backwards or forward, and it all decided preoperatively in the planning. And these are the cuts, and then this is the osteotome at the pterygomaxillary junction. And you need to be a little careful about, because there is a lot of pterygoid plexus around this. And there is also nasal osteotome, septum osteotome, so that you can do a down fracture of this. So lateral nasal osteotomy and midline osteotomy. Then only you can, these are the, just to red flag where you can be careful because nasopalatal artery is one which can cause bleeding, anteromaxillary junction. And this is used for the down fracturing. And this is how you can see after the complete fracture. You can bring it forward and then use a splint, or you can as a guide. The entire maxilla should be floating. So it's only supplied by the palate. Okay, the soft tissue release also, sometimes a lot of scarring will cause a problem in the, although you have done a good osteotomy, that also needs to be released. So this is burr. Suppose if you are pushing it up, then you need to burr this nasal spine and then bring it up. So these are fixations. This is a patient with cleft maxillary hypoplasia. You can see this maxillary hypoplasia, and after the Lefort 1 osteotomy and fixation, and you can see the difference in the upper lip position, both lateral and front profile you can see. The teeth also occlusion, and this is a stable after. This is a patient with severe maxillary hypoplasia with cleft, and then after dental correction, then you have the processes also, and of course with abe flap also we have augmented the lip. Then there is anterior maxillary osteotomy. You take only the part of the maxilla. It is not the entire Lefort 1. This is only part of, like for example, segment of the. For example, this you have a very prominent teeth in this thing, and you do the only anterior portion of the only premolar. Once you remove the premolar, then you fix it. Then you can see this prominence is corrected. See the difference between the pre-op and the post-op. This correction, and same thing here also. This girl, prominent maxilla, prominent teeth, and that can be corrected. And you can see the profile, the show of the tooth show is low. You can correct it. And bimaxillary osteotomy is something which is now both upper and lower. You are doing Lefort 1 also, and you are doing BSS also, because you need correction which is more than 8 mm. So you need to set back or bring forward the maxilla, and so this is very severe maxillary hypoplasia. You can see prominent jaw. So we are doing both Lefort 1 and then setting back the maxilla. This is one splint which we are correcting, giving, and then the second splint. So after the bilateral sagittal split mandibular osteotomy, you can see the post-op. Now you can see the difference. See from this state to this. So you can see the good occlusion, good chin profile, and then of course in the nasal this thing has to be done, that all. So all these patients, like this patient requires a bimaxillary osteotomy, upper and lower. Again, these are all upper and lower osteotomies, and also reduction of the chin, vertical reduction. And in this patient, you can see profile, the chin is forward and the upper lip is backwards. This requires again bimaxillary osteotomy. You can see open bite also. You can see a lot of these changes. And then, see, we are reducing the vertical height here. Lefort 1 and reduction of the vertical height. This much of bone is removed. And then we do the bilateral sagittal split. This is the after Lefort 1, and this is a splint, and sagittal split osteotomy of the mandible, and this is the final occlusion. And this is his post-op. This is his pre-op, and this is post-op. Pre-op and post-op. You can see the difference in his profile. See, good occlusion also. So this is how the post-op you can look, skeletal correction. And of course, this is the last part, which facial feminization, which involves chin reduction. Facial feminization procedure, of course, involves forehead contouring, hairline modification, eyebrow, cheek augmentation, rhinoplasty, and jaw and chin contouring. This is male face. Rhinoplasty done, and then we do the chin vertical reduction. This is also reduction of the jaw line. You know, the prominent borders of the mandibles are removed. And then this is a transverse reduction. This is a male chin is quite transverse. So we reduce the part of the bone and then make it more pointed. So it's a feminine chin. So you can see the difference of this chin and this chin. Okay. So this is the frontal forehead reduction. This is, we reduce the forehead bossing, and then also the sinus. This is the. See, once we reduce with the burr. Okay. And then this is trachea. We are reducing the frontal bone. Frontal sinus is opened and reduce the frontal. Like this. So this is the frontal bone is opened, sinus is opened. The whole thing is opened and then reduce it. So this is reduced with burr. It is made very thin, all this. Then you replace it back. So you can achieve the contour of the frontal bone and also reduction of the eyebrow, prominent eyebrows. Make it more feminine. So this is what you achieve intraoperatively. You can see the difference. Difference in the pre-op and for this frontal, see the forehead and see the chin and the nose, of course. So the orthognathic also applied to the, these are all so of course it requires a bit of training. You can, there is EVA foundation, all that you can. This instrumentation and team approach, accurate diagnosis, of course, planning and mock surgeries, splints, surgical procedure, good instrumentation, and keep updating your skills and keep analyzing results. You'll get it. Thank you.
Thank you, Dr. Dinesh. Excellent result. And question can be taken.
Yeah. Normal patient. Yeah, yeah.
So how much recurrence or are the results of the magnetic advancement stable on the long period of time of that patient?
Yeah, cleft, you need to use bone graft. There is no doubt about it, because there a lot of scarring is there. So that's what. If you are bringing forward more than 8 mm, then you need to add chin reduction. You can set back the mandible so that your speech is not affected. So 6 to 8 mm advancement, you can manage the speech. But beyond that, the speech becomes a problem. So that has to be kept. Yeah, bone graft is must, because otherwise you will relapse. Will have a relapse. Yes. Yeah, yeah. Sure. Yeah. No, it's very difficult to access because if you are seeing it, then probably. But the whole idea is to avoid that. So the cut should be such that, like you do the cortical cut with the saw, and then you are splitting with the chisel and the osteotome with a gentle, this thing. Nerve will be in the medial segment. It will not be in the lateral segment. So it is, unless there is thinning of the cortex or your cut has gone little, medially and all that. It can happen. But if you are injured the nerve, it generally recovers. Traction, because 40 to 50% of the patient you will get some traction in the neuropraxia. But permanent damage is about less than 5 to 10%. VPI is, that's a potential problem if you are advancing maxillary, which is beyond 6 to 8 mm in. But again, in one patient we did correct again with the pharyngoplasty, that improved.
Are these plates or evo plates? And why do you start movement?
Sir?
Are these plates or evo plates?
See, these are regular steel plates, titanium plates. No, no, no. AO actually doesn't have any, that depot synthesis is one which, that is a titanium plate, that is quite expensive one. So your regular plates are good enough actually. Yes, sir. But yeah. You need to see post-op orthodontics is important because once we do the procedure, then they will correct minor issues.
In two of your cases, you have shown that genioplasty done primarily for aesthetic purpose.
Yeah.
There is no functional deformity. Then
Yes.
why can't a silicone implant can be used instead of a traumatic osteotomy?
Yeah. This is silicone implants. See, you get about 6 mm silicone implants. That is, I think a lot of people use it extra orally. Take a chin incision and use it. That is the most common. This, of course, if this is long lasting, if the patient can afford it.
Okay.
If you know it. It is not very, the point of this presentation is to show that this is something which is not very difficult procedure. You can do it if you are doing any maxillofacial surgery or such.
Thank you, Dr. Kadam. I think both the two sessions showed the extension of the clefts into rare craniofacial clefts and then orthognathic surgery, I think, which is the final correction of your deformities of cleft lip. So once again, I thank all the speakers for a wonderful session.
So it concludes one of the most awaited session for this conference. It was by the invited speakers. And now we have the next session will be on East June. Before that, we have a major supporter for this event, Mollike Healthcare. So I request their medical advisor, Dr. Sandhya, to have just a couple of minutes presentations. After that, we will be starting our East June session.
New folder. So till his presentation, I'll use those extra 30 seconds to introduce myself. So I'm Dr. Sandhya Bhoya. I'm the medical head for Monliki. And as you all know, we deal in wound care. I did my medical school from Nagpur and practiced for a few years, then went to US to do my post-graduation in public health and preventive medicine. There I worked with the federal government for about 7 years. And I presented both at the national and state level, mainly working in the area of cardiovascular, obesity, and diseases. Received award by President Obama, Silver Award for my volunteer work, and the Women of Achievement in the field of science by the Bowling Green Human Rights Commission. Then I decided to come back to India, and I was working in specialty care and recently joined Monliki. So first of all, I would like to thank you, sir, for giving us the opportunity to have a very short presentation on what we do. So Monliki has been established a long way back in 1849, and we've come along a long way since then. In 1980, we invented the patent for SafeTech technology and the Mepitel wound contact layer. Since then, we've been having many products such as Mepitel, Mepiform, Mepilex, and recently we came up with the concept of moist model, which we are going to talk here and see here. And in 2025, we are going to see some new products coming in, the Granulox for the sole support. So we have started in India with focus on 5 indications, mainly pressure ulcers, diabetic foot ulcers, VLU, surgical incisions and burns. And the main aim of Monliki for wound care is to prevent the patient burden on wound care and also enable patients to quickly return to normal life after surgery. So the 3 clinical challenges we relate to are pain and trauma, the delayed wound healing and high treatment costs. So with Monliki products, literally our products have that SafeTech technology which gives a traumatic experience to the patients where there's no pain while the dressings are removed. There is early wound healing, and of course, because of the less frequency of dressing change, there is an economic cost which is beneficial to the patient. So as we all know that, pain is one of the most traumatic factors for the patients. And according to the WWHS, it's been guided and said that, the treater should always select a dressing that is traumatic to the wound and the surrounding skin. So I think at dressing changes, pain matters the most, and it's something that the patients dread, right? So for this, we have safe tag in our dressings, and it is a unique punctating adhesive technology that minimizes pain to patients and trauma to the skin. Definitely, it helps in managing the exudate. It manages the infections and bioburden, reduces the scars, prevents blistering, enabling mobility, and protecting the fragile skin. So basically, if you see what is the technology behind safe tag, here you see you have a picture of the traditional adhesives where they are not entirely covering the burrows and the pits, but the dressing with the safe tag completely seals off the wound and it helps in preventing the blister formation. So there is less risk of macerations with the help of these dressings, as you can see in these pictures, right? I'll focus more on this. So again, the skin stripping, you can see here the electron microscopic picture of a dressing with safe tag, and safe tag contact with the skin layer is much more, which kinds of prevents the blisters. So these are some of the products that we have, and I'm pretty sure that most of the audience here is aware of those products. Mepilix AG, specifically used in infections, and again, it is a 5-layer dressing that we have. And some of our products widely used all over the country are Mepitel, Mepitac, and Mepiform. So Mepitel 1 used in non-to-high exudating wounds, mainly in graft fixations, abrasions, skin tears, granulating wounds, and epidermolysis bullosa. Again, the absorption capacity is quite high. And then we have 3 types of dressings according to the exudate. We have Mepilex Light, Mepilex, and if there is an infection present, Mepilex AG. The second thing I wanted to cover here is the MOIST platform. So this was an educational model which was developed by a group of advocates in wound care to help for a proper dressing selection. And what does MOIST stand for? M for moisture balance, O for oxygen balance, I for infection control, S for supporting strategies, and T for tissue management. So I'm pretty sure you're aware of the MOIST therapy for wound healing environment, that the MOIST is maintaining a proper balance of moisture results in faster movement of epithelialization and faster movement of keratinocytes, resulting in early wound healing. And the products in Monleki do maintain that moisture balance, which again improves the wound healing in patients. So as I said earlier in my previous slides, there are 5 layers. So the first layer, in the first layer, you do not really have to remove the dressing every time you put the dressing, because you can simply track the exudate spread relative to the new dot grid which is present on the backing of the film. Then the second layer manages the exudates. You have the third layer which helps to soak, and this exudate does not come to the upper layer. And again, with the safe tag, the dressing does not really stick to the wound. So in the MOIST, the another concept was infection control. So as we know that infection can be a serious complications in wound healing. And for that, we have Exufiber AG, we have Mepilex AG, and Mepilex Powder AG. So again, it can be used in burns, in leg ulcers, for low to moderate exudating wounds. And how does this work? It works through the silver ions which are released into the wound, resulting in the antimicrobial effects. So again, this is a concept which is not yet practiced all over in India, but globally widely practiced. And here we want to promote this MOIST concept in all the wound care that is available. And again, we do not have yet the Exufiber AG, which is going to come soon in India, but we do have the Avance Solo Adapt, which is there for support. So thank you so much, and if you have any questions, I'll be more than happy to address them. Thank you. And thank you, sir, for giving the opportunity, because I have a flight to catch. Thank you.
Thank you, Dr. Sandhya. So going to have our Eastern session. I'd request the chairpersons, Professor Gautam Guha, sir, please take on the stage. Dr. Anand Sinha, sir, and Dr. Vishwajit Misra. So this session is also being supported by one of our major supporters, but we don't have any presentation, we'll have some lectures related to their products. So, Vishal?
Good afternoon, everybody. Our first speaker is Dr. Anirban Ghosh. He will speak on innovations and future prospects of single-layer acellular dermal matrix in medical science.
Seniors and my fellow plastic surgeons, the topic of my presentation is innovation and future prospects of single-layer acellular dermal matrix in medical science. So, as we all know, there has been advancement in medical science which has ushered in a new era of innovations, notably in the field of single-layer acellular dermal matrix. Now, next few slides are on my experience regarding the usage of dermal matrix. This is my first case. Over here, this is an exposed dorsum of foot where there is exposed tendon. Initially, it had been debrided and dermal matrix had been applied. Then after 7th day, skin grafting had been done. And this is the result after 21 days. We can see the wound has settled and the scar has healed. And this is the result after 90 days. And this is the video where the elderly lady is able to bear her body weight. She is walking freely without any support. Now this is my second case. This is a 50-year-old female. She underwent tummy tuck surgery and post-operatively I encountered lower abdominal flap necrosis. And she also had divarication of recti and a ventral hernia as well. So I had put Prolene mesh in the over the rectus sheath, and so there was mesh exposure also. So after debridement, I had put vacuum dressing, and so since I had to do some coverage, initially I had used 3 millimeter dermal matrix, and on top of it again vacuum dressing. And finally I got good granulation tissue, and again I had put 1 millimeter dermal matrix, and on the same sitting I had put skin graft, and this is a result after 3 weeks where the mesh is covered and the skin has regrown. This is my third case. This is a patient, he presented with snake bite and he developed compartment syndrome of one of the upper limb, and we had done fasciotomy, and the exposed tendon and all had been covered with dermal matrix, and after 7 days we had put skin graft. Though there is some scar contracture on the elbow, but there had not been much restriction of movement. Now this is the fourth case. This was a bike silencer burn on face, and he presented with a thick eschar where escherectomy had been done, and on the very same sitting I had put this dermal matrix which was 1 millimeter, and after 5 days I had put a very thin skin graft. Though the take of the graft did not look very satisfactory initially, but later on after 2 weeks the wound healed beautifully with just some residual raw areas. This is the fifth case where a young lady had presented with compartment syndrome with blisters on left lower limb. So thorough debridement and fasciotomy had been done. The resultant wound had been a circumferential wound extending from dorsum to mid to third of leg. Again, dermal matrix had been applied all around along with vacuum dressing. And this was the neodermis after 2 vacuum dressing, and after that we had put split thickness graft, and this is after 2 weeks post skin grafting. Most of the wound has healed excepting few areas of raw areas. Now coming to the theory, single layer acellular dermal matrix, it actually ensures active healing. It restores function and it improves quality of wound healing. The benefits are like it ensures active healing by fast cell migration, fast revascularization, improved skin regeneration. It improves the quality of wound healing by improving the scar elasticity and appearance, reducing wound contracture, faster reepithelialization. It also restores function by giving better functional scores, better sensation. And this single layer acellular dermal matrix is, in the long run, it is cost effective. The reason it reduces the hospital stay and the overall cost is also reduced. Now coming to advantage of single step procedure over two stages. Like in single stage procedure, there is no requirement of second surgery. There is shorter hospital stay. It saves the cost of the surgical and nursing time. It's a daycare procedure, and it overall reduces the patient's risks of complication. Now, in one-step procedure, generally the one-step procedure is selected when the bed is well vascularized and we don't need much of dermal support. The wounds where we can directly put skin graft, we can put a layer of dermal matrix. On top of it, we can put skin graft. The bed which is not much vascularized, we can put 2 millimeter, 3 millimeter dermal matrix, and we can wait for 5 to 10 days, following which we can put skin graft. In both the cases, I prefer putting vacuum dressing. Now coming to the product, what is Matriderm? It is basically a porous matrix. It is derived from bovine collagen. It is made of native collagen fibers. There is no chemical cross-linking unlike other dermal matrix. It also contains elastin. The same thing, like it contains native collagen, there is no chemical cross-linking. It contains elastin. It is clinically proven. 1 or 2 step procedures are generally done. The best thing about these dermal matrix is it restores patient's quality of time. At the same time, it secures the quality of surgeon as well. The Matriderm difference. The first difference is there is presence of elastin unlike other dermal matrix. Then the collagen is very much similar to human collagen. There is no chemical cross-linking, and since it's a single layer thing, one-step procedure can be also done unlike other dermal matrix which are available in the market. So the basic indications of Matriderm, the first is burns. It can be used on burn wounds. It can be used on trauma wounds, both acute and chronic wounds. It can be used on the wounds on the defects after cancer excision. It can be used in the donor areas. It can be used as an adhesion barrier in nerve repair, in tendon repairs, and it can be used in mucosal defects as well. Thank you.
Dr. Oniban, nice to have your presentation. It's a good presentation. So, can you go back to slide number 5?
The case 5?
Slide number 5. No, not the slide number 5. No, it's 3, 5.
Yeah.
Acha. I just want to know, tummy tuck surgery, bracket it is written abdominal flap. What does it mean?
Basically, the flap which got necrosed, that has been mentioned.
Oh.
The lower abdominal flap had got necrosed, and the first picture where the flap was necrosed, that picture is missing.
Yeah, I get it. Because these are two different operations.
No.
Flaps,
abdominal flap for reconstruction
He's showing a raw area being covered by some technique. That's about all. That's not good.
Abdominal flap, what we use for reconstruction is a different thing. Over here, the surgery has been mentioned, tummy tuck. The flap which got necrosed was the lower flap. The picture which is missing here is the necrosed skin. That picture is missing. So just to emphasize on the necrosed portion, I have just mentioned.
I got it. In your case number 5, can you go back to case number 5? Yeah, the previous one. Previous one.
This one?
No. Case number 5, that facial one.
That was 4.
Yeah, this one. So the classical teaching is after proper debridement, putting an FTG in this case with adequate fixation. What
that is an
advantages
option.
Does this dermal matrix provide by using this thing and a single stage of thin
this was not done on single stage. I had done on 2 stage.
In a 2-stage way.
Yeah.
So what?
The thing was like after debridement, after taking out the eschar tissue, I was not very sure of the vascularity of the bed. So I did not put skin on the same sitting. Rather, I chose to put a temporary cover in the form of dermal
There wasn't
matrix.
any punctate bleeding from the bed?
There was bleeding, but I had I thought I might have a requirement of redo debridement.
So if you put
So
a
to
dermal matrix also in this case, then a redo debridement would entail removal of that matrix.
Since the wound had not been much contaminated, and as I have already told, and if you are not sure of the vascularity of the bed, you can put dermal matrix.
Okay. Thank you. This is
Thank you.
We're running short of time. Thank you so much, Dr. Anirban. Now we invite Dr. Vikrant Ranjan. He is in Ranchi Medical College, probably leading the department there. He will talk about small incision AV fistula for RRT, a practical approach with do's and don'ts.
Good evening. This is one surgery which as a plastic surgeon we are doing routinely. Some people are doing it actively, some people are doing it occasionally. So what I'm going to discuss is here, how can we minimize our incision for the sake of the benefits? What are the indications and what are the things we have to avoid it? Basically this is, I call it peripheral kidney. This is one of the things which is most indispensable in case of renal failure patients. Safest for renal replacement therapy. Daycare surgery, obviously after 1 hour patient can go. Outcome is very good if we follow the precautions and the patient follows the instructions. There are certain basics to follow. Number 1, the rule of 6 is there. I have included some of the indications. Number 1 is the anastomosis should be more than 6 millimeter. There should be 6 millimeter diameter of the vein and not more than, not less than 6 millimeter of that anastomosis. If we are doing it in the distal part, the size can be up to 1 centimeter, 1.5 centimeter. It entirely depends on the blood pressure and the size of the vessel. Then depth from the skin should not be more than 6 millimeter. We should not wait for more than 6 weeks for the maturation. If it is not maturing, then it is time to revise the surgery, do the next, the other spot. Proline, we follow, I personally prefer 7-0, and that is what I think most of the plastic surgeons are using. But I've seen many people are using with 6-0 also. The flow should be more than 600, just to remember a rule of 6. Otherwise, even if it is 400, then also it is good. And there should be at least 6 centimeter unbranched segment of the vein, so that there should not be the flow diversion. Then there are certain precautions for the patient, limb folding and elevation and soft ball physiotherapy and massage, no weight, no pressure, like that. Then intraoperatively surgery related, that is very, very important thing, because on table it is us who are going to decide the outcome. If it is good, then obviously it is going to mature. In very rare instances, there are certain factors which are leading to failure. Post-operatively, the patient care is to be continued, and dialysis technician has very important role, because puncture is, again, it can be disastrous for the survival. Wrong puncture. Now, we are routinely, we don't bother about the size of the incision, but what interesting thing is, I have seen that while patients are in getting their dialysis done, everyone is like they will look at the incision, they will discuss about their fistula, and if some trouble is getting, or some size, your incision is smaller, then they discuss these things, how painful was the procedure, post-operative, how uneventful your maturation occurred. There are certain things which is being discussed. So why not minimize the size of the incision? And there are so many, like if we go for the smaller incision, then less dissection, obviously, while we go for the other surgery, suppose unfortunately we have to revise it, we have got more options. Cosmesis is better, scar is not on the hand, it is over the heart. Then we can also better market ourselves than neurosurgeons or CTVS or even nephrologists doing AV fistula. So this is arbitrary classification. There can be incisions, and there are none where it is reported like a small incision is 1 to 2 centimeter. But for the sake of small one categorization, I mentioned in my study, 1 to 2 centimeter is small. I have taken 2 to 3 centimeter medium. More than 3 is like unspecified. And many I consider less than 1 centimeter, less than equal to 1 centimeter. So this is the size of the small mini incision. With this much incision, I have performed 13 cases, and I will show the data. So this is the size of incision, and repair is done by 7/0 only. So now see, this is the basic thing what I am showing you. We don't need any bulldog clamp because there is no place for that. All we have to do is to make a loop. We have to take it out, hinge it out, put the forceps, limbs below it, and bring both the things together and do the anastomosis side by side. That is a very, very important point. And once the anastomosis has been done, then what we can do, we have to ligate the distal part of the cephalic vein, because then only the maximum flow will come proximally and the maturation will be better. The video is there, so that is the basic thing. The most important trick is take it out and put the forceps. That is the thing which will help you most. There will not be absolutely any blood during the anastomosis, and doing side to side is much easier than doing end to side. Then certain incisions are like a small incision with this technique only. But if we are going for the small to medium, like 2 centimeter around, then we can apply the bulldog clamp and we can do the anastomosis accordingly. See, there are certain points where I have ligated. The proximal branches I have ligated also, if we look carefully on the proximal part. One incision, one suture is sufficient. Now, when to select for the small cases or mini cases, first of all, it should be more preferably on the distal part. The blood pressure should be not less than 120 systolic. Then the vein should be visible, and preferably always make it that it should be a point in lean and thin patients. If the patient is obese or edema is there, obviously it's a negative for this small incision. So again, it's very shaky staff is making. I'm just telling you, a side-to-side anastomosis is sufficient with 7/0 prolene. Always do it under, and it is not possible without your loop magnification. The thrill, after this anastomosis, after 1 or 2 days, it is sufficient. The flow will tell you whether it is going to mature or no. This is arterial. this is a thrill from the fistula. It can be made that. I haven't done any mini less than 1 centimeter in the elbow, and I am still I don't know whether it will be possible or no. But yes, up to 2 centimeter, it is very well within our reach from the at elbow region. Also, we can go for the brachiocephalic or brachiobasilic. In my first, it is my early data, first 100 cases in last 2 years. In 13 cases less than 1 centimeter, there were 3 failures. And if I calculate for the percentage, it's almost 23%. The maturation at end of 1 month was 61.5%. The point is, my first 2 cases failed. Like within 2 days, I did the 4 cases of less than 1 centimeter size. It was more or less, I was going. I was also looking for the indications. Despite my my best effort, the first 2 cases, not in first 2, out of 4, first 2 cases got failure. Then that needed revision. If it is less than 2 centimeter, complications were none, and the failure was in 1 case, 5.6%, and maturation at the end of 1 month was 15 cases were mature, 83%, and rest of them were mature at the end of 1.5 months. I was not worried about that. And less than 3 centimeter, there was maturation was 85.4%, and more than 3 centimeter, maturation was 85.7%. My point is, at the end of 1 month, maturation rate is not much different according to the size of incision. The only, the data showed 61.5 because it was my mistake in selection. So, interpretation or my pitching is that mini incision failure, where in early 4 cases I told you, it doesn't matter maturation because when you select the size of incision, unless basic principles are followed. If you violate them, obviously it is not going to mature whatever be the size of incision. The study data interpretation based on the location of AV fistula is still underway because I have included, I have taken the size as constant, not the location. That could be a variable. And time taken in, now very important point is time taken, we say that in small incisions, the time will be more. Yes, in early cases. But once we are through with the 10-15 cases, the time gradually will be started decreasing. My standard time is now in small incision is around 45 minutes to 1 hour, while when I started it, it was around 1.5 hours. So when to select, I just summarize it. Visible cephalic vein, lean and thin patients, better general condition. Patient should be willing for post-op exercises, and it should be preferably in the distal area. Less than 60 years is one relative indication. Patient is fit, you can go for 70 years also. Blood pressure should be more than 120 millimeter of systolic. Loop magnification is light source is must. You can use microscope if you want. And experience, that is also important. First do many cases of the AV fistula at least 50-100, then go for some other newer thing trial. And when not to, any patient who is not fulfilling selection criteria should not be encouraged. Even with a little doubt, you should avoid it. When there is some struggle in mobilization or multiple branches are there, convert it. And when there is side branches ligation which requires difficulty, just go for the increase in size of the incision. And there is certainly no place for egos in our practice. So when I started, this is my first incision, and this is what now it has came to. Not all the cases, but yes, it is. The credit for this and inspiration for this was from Kalpesh Gaziwala sir from Mumbai, and his one article was published in IJPS 2021 in COVID era, and then I started doing this, and my series is ongoing. Definitely will go for publication also. Thank you so much. Thank you, sir.
Nice presentation, Dr. Vikram. Any questions?
Sir. Okay, sir, one by one. Number one is diameter. Diameter is again, sir, it is variable. If the blood pressure is, if the vessel is lean, small caliber, say it is 1.5 or 2 millimeter diameter, then also if the blood pressure is good now, I go for the anastomosis. But in those cases, I do dilate it with the jewelers, and then the size of the anastomosis, that is increased. In my case, I go up to 2 centimeter, number one. If it is less, length, diameter of the vessel is suppose 2 millimeter, then blood pressure is good, then I go for this. But if the radial artery, in some of the cases, you find that radial artery diameter is also small. Those cases, I avoid it, I just go for the proximal areas, because it is not going to mature properly. I have to see the patient also, the indications, blood pressure, the general condition of the patient, then the size, the other comorbid condition, whether patient is going to exercise or no, compliant or no. So these are multiple factors. Even branching, that is also very important. So that is one thing. So depending on the size of the lumen, the length of the anastomosis is increased in my opinion. And that longevity, no? That longevity is very variable, sir. It can go from my cases done 7 years back also, it is working now. The cases which I do, even within 1 month also, it gets, after 3-4 dialysis also, it gets thrombosed. So that is not, because once it matures, then it is not more or less your fault, if you have taken all the precautions. Sometimes dialysis technicians, I told you that they puncture it blindly. Or newer technicians are taking, learning. So the puncture, they can lead to hematoma, then that can lead to thrombosis. Sudden fall in the blood pressure, that can lead to thrombosis. Multiple factors are there. So longevity is, once it is mature, that is beyond your control. Now, if you are selecting brachiobasilic, then obviously it is a trouble, because it can be a problematic in the puncture. In that cases, do go for the superficialization. If it is, you can at least counsel the patient. Then if it will be there won't be any problem in the longevity. So there are these two things. One thing more.
Complication.
Complication.
Common complication.
Complications are practically, I thought that so many patients are having diabetes and renal failure, immunity compromise. But surprisingly, there was no rare complications of infection. But pseudoaneurysm is one complication which is common, not common, but it is seen. Out of 100 cases, you may find 1 or 2 cases of pseudoaneurysm, whether it is operated by you or your colleague, but it can come to from anywhere. And then you have to go and do that's a very meticulous surgery. Sometimes infective aneurysm, pseudoaneurysm, that is again more troublesome. That normal traumatic pseudoaneurysm is okay, but infective one is more difficult to treat. That may require your, that's nightmare also, like the bleeding. Yes.
Sir, I want to ask, sir, what should be the minimum diameter of the radial artery, so that we should not go for a radiocephalic fistula? Because if the artery diameter is small and the blood is coming in a small volume, then the fistula will not work properly. So what should be the minimum diameter of the radial artery? We should not go for a radiocephalic fistula.
Yes. If it is more than 3 millimeter, 3 millimeter or like that, you should go ahead. But if it is less than that, then obviously there are chances. But if you feel that it is very small, the vein is also very small, then avoid it. If the vein is larger and it is radial artery is smaller, super avoid it. So 2 millimeter or more than that is one basic thing, if blood pressure is more, or if it is 3 millimeter, go ahead. Nothing is going to happen.
Sir, most common cause of failure in your series, sir?
Surgical. It's our. If
thank you
we
so
are
much.
very well into that indications, there is no failure as such. Yes, sir. Pardon, sir?
Brachiocephalic fistulas.
Yes, sir.
If it ruptures, so there is pseudoaneurysm, how do you deal it?
Means brachiocephalic fistula obstruction.
No, ruptures.
Ruptures.
Aneurysm ruptures.
Sir, aneurysm happens, like pseudoaneurysm happens. Rupture is not, yes, that neglected pseudoaneurysm of brachiocephalic or brachiobasilic at brachial artery, yes, that happens. The patient will come initially with a small swelling. They may give you a call that, Doctor साहब एक छोटा सा वो सूजन है, but ठीक है ना, दर्द हो रहा है. But what happens? They won't come to you. When it starts increasing in size, then they will get worried, because dialysis technician will warn them that no, I'm not going to puncture it. Then they will come to you. And what happens at that moment? Then you go for some surgical for the correction of the repair of the pseudoaneurysm. You'll tell the expenses also. CKD is one disease where the financial bankruptcy is there. bless us that government schemes are there. Otherwise, patients are not going to survive for more than 5 years, however well-to-do they are. So what happens? Financial reasons, they will not go for the surgery, and in that cases, I have seen that there can be rupture also. There will be a small puncture point in the skin, and then suddenly there will be a gush of blood. Immediately press it, take OT, under tourniquet control, repair it. There is no chance. And then you may have to leave the skin. Plan incision laterally or medially, not just over that, because skin is almost gone there. So it's very tricky thing. Then repair, then Abgel, and then dressing, pressure dressing, and then after that. In one cases, I have to ligate the brachial artery also. After 1 or 2 incidences of the rebleed, I have to ligate it was infective pseudoaneurysm. I have to ligate that brachial artery also after all the efforts. I could not able to, because 15 centimeter of the area was infected, totally infected. So I just prayed, and with the collaterals, it was surviving. Hand was fine. Otherwise, it was going to be a very big trouble.
Vikrant, thank you so much for your
Thank you, sir.
Thank you very much for the lovely presentation.
Next, I'm calling Dr. Pranab Kumar. His presentation will be on female cosmetic genital surgery.
So greetings from Bihar and Jharkhand. Thank you, Aprasocon, for this opportunity. I know that we are running out of time, so I am going to be fast and forward. So female cosmetic genital surgery, with the increasing awareness about genital appearance and sex, there is increased demand for aesthetic surgery of the female external genitalia. So it is a less discussed topic in our training, but it is in high demands in aesthetic practice. So I will start this discussion with a case that has come to me of a young unmarried female who has history of normal vaginal delivery leading to perineal tear, and perineal repair was attempted 1 year back somewhere else. So how to approach this case? So first we have to know the anatomy, the systematic, and then we have to know the deformity. So the systematic examination of the mons, labia majora, clitoris, labia minora, carunculi, remains, and vaginal introitus, all has to be done in the dorsal lithotomy position. Use speculum at times. So patient goals have to be realistic about the procedure, and you have to discuss with her the anesthesia, surgery time, the possible scars, potential risks, post-surgical recommendations, what to do, what not to do, and recovery and total downtime. So nearly anyone who presents with realistic expectation is a candidate. So, and anyone with active inflammatory conditions or infection or history of coagulopathy, smoking, so you have to avoid surgery in these patients. Our one advantage is there is no ideal in this anatomy. So we have to understand that what are the options we have and what are the options we can offer to our patients. So genital rejuvenation has to be surgical or non-surgical. In the surgical component, there are external aesthetic surgical techniques and there are internals also. So external, it can be related to mons like lipomodeling, labia majora, augmentation or reduction, labia minora, reduction, hymenoplasty and clitoroplasty as well. And internal, perineoplasty, vaginoplasty or their combination. And non-surgical has to be done with the laser or PRP. So we all know that hymen is considered a sign of virginity, and we must always help the patient understand that it is not about tightening of vaginal walls. And in order to actually go back to being a real virgin, we would need to also perform a vaginal tightening procedure. So when to do? So 5 days after the menses is stopped and 10 days before the expected menses. I prefer to do it in this time frame. And for patients who desire structural integrity and need the hymen to be intact on visual inspection as well, the repair should be performed 2 months before the consummation of marital vows. So there are different techniques that are described. So Goodman technique, the adhesion technique, and the turnover flap techniques. In all of these techniques, we use the remnants of the hymen and repair it. What I am preferring these days is a 2-layer technique in which the hymenal tags are identified, the 2 layers of hymen are created after freshening the edges, and repair is done in 2 layers. So no standard hymenal appearance to reproduce or reconstruct, just use the hymenal tags and repair it. EMLA can be applied in the lithotomy position, local anesthesia has to be given, proper exposure, proper anesthesia, atraumatic technique, and a combination of all these 4 methods has to be used. And we can use Weichel 40 rapid, or you can use also the normal Weichel 40. So when a patient comes, so proper exposure is essential here also. You can see the hymenal tags, which are present with the help of a scissors. It can also be done with the help of a scalpel. The two layers has to be created, and then the layers are repaired with a small orifice left. So these are different cases in which hymenoplasty has been done. Sometimes the patient may send you WhatsApp pictures also that the sutures are still there, so you can ask to wait or they can come to you to get the sutures removed. Standard analgesic and antibiotic regimens have to be followed in the post-op care, gentle irrigation after urination. Patients are encouraged to take showers and limited physical activity with no exercise for 4 weeks is advised. So other technique is labia minora reduction technique, in which there are two options, curvilinear excision technique and wedge excision. As you can see in the curvilinear excision technique picture, that there are this whole part is excised and the repair is being done. So there is a scar along the suture line at the periphery, but it is relatively easy and it is more popular. So you have to examine, whenever you get the patient, you have to examine all these things, labia minora also. So there is this classification that shows that which part is exactly prominent in a labia minora. And the other classification is regarding how much prominent it is, class 1 to 3. So whenever we get a patient, so you have to excise the part and repair it. In this patient, we have also done the hymenal repair. So this result is after 15 days. So again, the other thing is in the internal aesthetic, we have the vaginoplasty and perineoplasty, in which the vaginal mucosa is excised and the perineal muscles are repaired. So again, coming to the same case which I have mentioned earlier. So you have to examine the case. Gaping vaginal introitus is there, hypertrophied labia minora, midline scar in the perineal area, hymenal remnants can be seen, and visible vaginal mucosa is there. So the plan is to repair the perineal muscles, reduction of the vaginal introitus, removal of excess vaginal mucosa, and hymenoplasty. So all these things have been done. So this was the immediate post-op results, and this was the result after 14 days. So we have to understand that what are the options we have for genital rejuvenation, and we have to explain these things to our patients. These surgeries are comparatively easy, but whenever someone comes to you for hymenoplasty, you must explain that all the options we have that can be done for the cosmetic improvement of the patient, and let the patient choose which procedure is best for her. Thank you so much.
We can have 1 or 2 questions if there are any. Yeah, Akshay.
Sir, I will say something like this, that the worst part of this surgery is that nobody takes the training, nobody reads the book. There are very good books available, and there are some colleges are here, this online 3 days courses, and they are training everybody to operate these cases. So when a good surgeon operates these cases with a traumatic technique and proper exposure, as you can see in that all these pictures, then there will be no harm and there will be very good results. Sir. Labia minora, sir. So there are 2 different procedures that I am explaining, hymenoplasty and labiaplasty, sir. So which? So if you have enough remnants there, which I am saying that this is the case series of 105 cases, sir. So I have experience of 105 cases. So all the time you will always have the hymenal tags. You just have to use it properly. Yes, what you have said that it is a described method, that if you don't have hymenal tags, you can't find any hymenal tags that you can use, then you can use the posterior vaginal mucosa also as well as the labia minora for the reconstruction of hymen.
No, after putting the injections, most of the time what happens that hymenal tags, they become friable and it's difficult to bisect also.
That's why, sir, what I am showing in this picture, that the best thing is that always has these traction sutures to properly expose the hymenal part. As you can see, there is no problem if you expose it properly and then put the Gylok and adrenaline solution and then you wait for 10 minutes. And afterwards, when you will excise it, then in a, except then a single case or two cases, in all other cases, at least I should say that like this, not to be egoistical, I was able to dissect, excise and repair properly, sir. Sir.
Thank you, Dr. Pranab Kumar.
Thank you,
Our
sir.
next speaker for the session is Dr. Karnav B. Panchal. He will speak on double free tissue transfer
Thank you, sir.
for head and neck reconstruction, our experience.
Good evening, respected chairperson, seniors and colleagues. First of all, thank you very much for giving us the opportunity to the organizing team to present our work. So, when you have such advanced patient of T4 squamous cell carcinoma, there is no doubt that double free flaps are required to give them adequate functional and aesthetic result. But these are the only indications, and for such patients only double free flaps are required? So with that question in mind, we like to present our experience of use of double free flaps in head and neck reconstruction. So when we analyzed our indications of 103 consecutive double free flaps, we found that only in around 60% of the patient, an extensive defect was the indication for a double free flap. So coming to the lesser known indications for a double microvascular tissue transfer, the first is when you want to give a functional component to the patients who has lost a muscle. So you can see this is a patient who had an extensive tongue defect, only a part of the posterior third of the tongue is remaining. So obviously the patient won't have any inherent tongue function remaining. So what we do in such patient is we take the gracilis muscle along with the obturator nerve, we take a thin radial forearm, we hitch the gracilis vessels to the radial forearm, and we co-opt the obturator nerve to give function to the tongue. Now then there are smaller defects but intricate defects. You can see this patient who has a through and through defect involving a part of the skin of the cheek, the lower lip, commissure, upper lip, the mandible and the mucosa. Now if you really want to give a good functional and aesthetic outcome, you require tissues from different place. So here we took a fibula. Because we are using fibula only the skin for the mucosa, we could double barrel the segment, and to give a better color match to the cheek skin, we used a thin radial forearm flap, and we used a sling to reconstruct the lip primarily. And this is the patient intra-op and the post-op result. The lip was competent. So coming to the combinations of double free flap, it is just not the defect, but sometimes the anatomy of the flap per se is such that you require two flaps from the same donor side to reconstruct a defect. This is example of a patient who had a through and through defect with a mandibular involvement. You can see a standard fibula was planted. But on dissection, we found that the proximal perforator was arising higher up. So in this case, it is not possible to dissect higher up and take the ligate the posterior tibial. So then the proximal perforator was taken as a separate flap. So you can see we have the fibula, standard fibula, and we have the proximal perforator artery flap as a separate flap. And in this case also, since you are using that tissue as a separate flap, you have the freedom of using a lot of bone in the fibula to give a double barrel to the central arch. This makes sure that the position of the lower lip of the patient stays good even after adjuvant radiotherapy. Now, if you look at the literature on double free flaps, especially on the vessel selection that are used, it is mentioned even in 2018 articles that sequentially linked flaps are not preferred because they have a higher rate of complications. When we analyzed, we had a small number of patients, around 20% of the patients, wherein we had sequentially connected the flaps. So this is a through and through defect. So this normally you can, most of that standard teaching is that you take a soft tissue flap and fill the defect. But is it the only thing that matters? Finally, the function and the motor function is quite important. So you can see we have looped the marginal mandibular nerve. So what we did, we used a myocutaneous anterolateral thigh flap. So the vastus lateralis muscle was used as a free functioning part. Now to use it and then create two islands, it is difficult, so we harvested a radial forearm flap. Now we start our dissection simultaneously with the head and neck surgeon. So by the time the excision and the bilateral neck dissections are going on, we already can raise both of the flaps. But the critical thing is the duration of the surgery. So in order to reduce the duration of the time, what we do is that we have joined the radial vessels with the side branch of the lateral circumflex femoral artery. So by the time the head and neck excision is completed, our flap is almost ready, and so we don't end up wasting a time of two vessel anastomosis. So this is a patient post inset, and this patient recovered some of the function of the muscles of mastication. But as in all cases, vascular complications do arise, and they need to be detected early in double free flaps. So when we collected the certain review articles, the re-exploration rate in double free flaps were around 15 to 25%, and the failure rate ranged around less than 5%. In our series, we had 10% of re-exploration rate, and unfortunately, we had lost 6 of the 206 flaps. So in conclusion, the indications of double free flaps are evolving, and we should always keep in mind the functional part of the reconstruction and just not recreating the mucosa and the skin defect. Time is an issue, and this can be reduced if we try to fabricate the flaps in vivo, and they are safe. But the most important thing in double free flaps finally is how you insert the flap. Thank you.
Any question from the audience? Thank you.
Thank you, Karnav. Jana Malhotra ma'am. We haven't seen much woman power since morning. And let me tell you all that she recently had a promotion as the Principal Chief Medical Director of the Railways. We congratulate her for that. And she'll be taking over also as the Presidentship of E-Zone APSI. She'll deliver a talk on paradigm shift from bilaminar to riding the rainbow, a journey in plastic surgery. Yeah.
Respected chairpersons and members of this august audience, at the outset, I'd like to thank Apraso and the organizing team and Dr. Sunil Raut for giving me this opportunity to talk here today. Actually, on their request, I'm actually presenting what I presented in the Amit Ganguly lecture at Aprasocon. And since many of you weren't there at Aprasocon, so we thought that I could repeat it here. So I titled my talk, A Journey in Plastic Surgery, Riding the Rainbow. And this rainbow was actually the 7 parts of plastic surgery which all of us do. So we compared it to all the parts of the rainbow VIBGYOR. And unlike any other super specialty, plastic surgery has a lot of branches, and each branch has a different aspect, and each one doesn't pertain to the other in many stages, and it has more branches than any other super specialty. So going on to that plastic surgery, riding the rainbow, I'm going to share my experience of riding the rainbow, the various subspecialties of plastic surgery. So I begin with general plastic surgery. And these are some of the common flaps all of us use. We saw some talk about this in the morning also, about all the nasolabial flaps. And we've used the double rhomboid flap also very often for small defects around the angle of the mouth, as described by Dr. Ian Jackson, with good results. And of course, all of us have used the Karapanzik flap, and again the radial forearm with slings. And this Karapanzik flap above is a 20-year-old follow-up. This patient was operated in 20 and then succumbed in 2020 to COVID. So again, AV malformations part, as somebody was mentioning in a talk earlier, also forms a bulk of work of general plastic surgery. So this patient had a traumatic AV fistula, was operated elsewhere and came back to us, and then he was embolized and then operated within the next 48 hours and again reconstructed by a radial forearm flap. This is again an uncommon venous malformation. The whole of the internal jugular vein was actually the low flow venous malformation, and it was excised. And again this one in the forearm, in the flexor compartment of the forearm, and again totally excised, and you can see the ulnar nerve and the ulnar vessels which were preserved. Then expanders all of us are using. So this is again a delayed follow-up of a burn patient on whom we gave the scalp expander. So she's become a doctor now, and this is again her 9-year-old follow-up. And when the oncosurgical team of our hospital was doing modified radical mastectomies, we were trying to reconstruct those defects at that time by the pedicle tram flap. Subsequently, we've moved on now. So these are some late examples of reconstruction by tram flap, and we are now also using the DF flap for reconstructions. And in smaller breasts and patients with problems in the abdomen, we've used the LD flap. This is one of the patients in whom we used an implant with the LD flap, and she agreed to a reduction on the opposite side. So we did a reduction on the opposite side, and she actually came back for a nipple areolar reconstruction. And as wide local excision became the norm, so our work changed to oncoplastic breast reconstructions in the form of volume displacements, and again volume replacements in the form of small filler LD flaps. Now pressure sores also forms a great part of any plastic surgical unit. So this patient had this ulcer for 25 years and came to us. At that time, perforators weren't mapped, so we gave a bilateral gluteal rotation flap. You can see the posterior wall of the rectum is actually showing through the pressure sore, and this is his 18-year-old follow-up. And then subsequently, we've used now S-gap flaps and TFL flaps, all flaps for all types of ulcers. So now I take you through this small diagnostic dilemma. Both these children came to me in the year 2008, and when we did the study of the first boy, he was XY, and this girl turned out to be actually XX. And on further investigations, she was a case of congenital adrenal hyperplasia. We excised the pseudo penis in 2013. But then, in 2009, and she recurred in 2013 due to poor hormonal control. So we re-excised her. You can see we've tried to preserve the nerves to the clitoris. And again, you can see her now in 2023. The results persist, and she has attained menarche. Whereas this boy was then a male, so it was a perennial hypospadias repaired by the Bracas method. And you can see him now as an adult. And some uncommon cases like this case of iatrogenic hypospadias, which was a result of a long-standing condom catheter and was treated as a hypospadias and repaired as one. We come to the second part of the rainbow, which is cleft and maxillofacial surgery. So most of our work is done either in the mission model or in the center model with the help of Mission Smile. And we've done 3,000 surgeries till now and counting. And as part of the exchange programs, I've gone to China and Philippines and Africa and operated on cleft children. So Dr. Moeller himself had visited us during one of these missions, and he taught us the Moeller's method. You saw the cleft lip Dr. Subodh Singh showed. So this actually, the medial incision goes right up into the columella, and then the cuttings modification is used to give very good results. These are some of the patients on whom this Moeller's method has been used. And the cleft palate, obviously, we started with buttocks, but now with limited incisions and intravellar veloplasties. And as Dr. Dinesh Kadam was showing, he went the step further. So these are some of the maxillary and zygomatic fractures. And this is an interesting case. He was a gateman at one of our level crossing gates and was attacked by robbers. He was treated primarily, a tracheostomy was done, a rise tube inserted and sent to us. So in those days, we didn't have titanium plates. The mandible was fixed with bone graft and stainless steel plates, and then the upper lip was reconstructed by radial forearm flap. So you can see in him 2 years after surgery and then 23 years after surgery in 2023. We come on to burns now, and we have a dedicated burns unit. And early burn wound excision was started in a unit in 2018. And the cadaveric skin graft is being outsourced from the National Burn Center at Airoli. So these are some of our survivors following early burn wound excision. And these are some of the statistics of early burn wound excision. So this child is a pediatric burn who came to us during the COVID time, and after using allograft from his father, then we used the Meek micrograft because we didn't have any donor skin. And this was reported in the Times of India at that time. And this is again, the railways has the highest electricity in its OHEs. It has a 25,000 volt, and despite all precautions, we often get these high voltage burns. So this patient lost all 3 limbs, and he was amongst the first patients in the eastern to get the myoelectric prosthesis in the eastern part of the country. So you can see him then, and you can see him now still using the myoelectric prosthesis to eat. And as part of our advocacy, we have been doing this burn awareness at all major stations of Southeastern and Eastern Railway. This year, we've extended it to North Frontier Railway, where pre-Diwali, all these posters and videos are displayed. And the main thrust of this is pour water on burns. And I thank Dr. Nikhil Fanse for collaborating with me on this. We move on to the next part of the rainbow, which is microvascular surgery. And as Dr. Vikrant was saying, so AV fistulas are all done by us. And the residents actually hone their microvascular skills by doing AV fistulas. And our microsurgical work is based on mainly 3 flaps. That's the radial forearm flap, the ALT, and the fibula when there's a bone defect. So this is one of the first patients on whom we gave an ALT flap for this ulcer. I was thinking whether I'm doing the right thing by saving this limb. But you can see this was done in 2001, was shown to Professor Amit Ganguly, and this is him now in 2023. So it's been used for all types of head and neck defects, tongue defects, for mucosal defects, and we've combined it with other flaps like the Karapanzik flap to give oral competence. And this is another uncommon case of basal cell carcinoma, where again, at that time, we were just doing radial forearm flaps, so it was reconstructed by the radial forearm flap. And this boy is a very interesting case. He came with this innocuous looking nevus, but when we went to excise it, we found it's extending not only to the cranial bone, but into the dura. So a radial forearm flap was fashioned with forearm fascia to cover the dural defect. And this is his, again, 19-year-old follow-up. This man came to us following a traumatic amputation of the penis. The penis was reconstructed on a saphenous AV loop. And subsequently, when the sensation reached the tip of the penis, we gave him a penile prosthesis. And 3 years later, he's got married and had a child. The anterolateral thigh flap now forms the workhorse, and these are all the types of defects. It's been, we've divided it in all its perforators, used it for inner lining and outer cover. And also this is a case of total glossectomy, again reconstructed by the radial forearm flap. And this is his speech result. And we've used it on amputation stumps when patients come to us with amputation to preserve the limb length. And again, this is one of our patients, again 7 years later, he's walking on the prosthesis without any ulceration. And the free fibula flap, obviously for bony defects, it's the go-to flap. Again, the paddle has been used in all fashions. And these are some of the patients. And then we've combined it with other flaps in bigger defects. Of course, not the second free flap, but with the DP flap in this case. And we've gone on to use CAD/CAM technology, as in this patient, and the dental implants you can see have been given on table. And this is his 2-year-old follow-up. And maxilla, all flaps, earlier we used to just use obturators. Now we've used the free VRAM flap, the free TRAM flap, and of course the ALT and the fibula. And now for small defects and for just skin only, we've gone on to use the MSFP free flap. So these are some patients, this small sole defect and the weight-bearing part, again a dorsal reconstruction, and for the tongue. And after seeing Dr. J.P. Hong operating in Calcutta, we've started using the suprathin ALT flap, and this has been used in one of our patients for resurfacing the neck. And the microvascular coupling device is also used. It's been used in 32 cases so far with good results. And we have the ICG camera as well, which helps us to mark the perforators not only for the DF flaps, but also we are beginning to use it now for the lymphedema work, which we are starting upon. And I come now to the next part of the rainbow, the extremity reconstruction. So these are some sarcomas which have again been reconstructed by pedicled ALT and pedicled AMT flaps. And around the knee, of course, it's either the MSAP flap, which is a go-to flap, or superior genicular artery perforator flaps. And we've used keystone flaps, again perforator flaps. And this patient had this complex defect where a combination was used. So in the upper part, we used a wraparound ALT flap, whereas for the sole, we gave a dermal matrix, and which was then skin grafted. And you can see the patient now walking after the completion of his Elizarovs. For lower third leg defects, the sural artery flap was the go-to flap. We are now supercharging it because of the venous problems we've often encountered with the reverse sural artery flap. And then for bigger defects, again, we are using the ALT flap in all kinds of defects of the lower third. And I'll just share with you two uncommon cases. This child came following a monkey bite, and all the tendons, the posterior tibial nerve was injured. So after 5 days completing of 3 doses, we repaired all the tendons, and then we repaired the posterior tibial nerve using the sural nerve, which was also injured in the place. And you can see the 11-month follow-up of this child. And this is another interesting case who came to me when she was 3 months old, and she had a transverse growth arrest and a phocomelia of the right limb. So this constriction band of the left lower limb was corrected. She had syndactyly of the upper limb, which was also corrected. But she was the youngest patient. She learned to walk on a prosthesis at the age of 1 year. And now you can see her in 2023 She ran recently the Calcutta Marathon also. And fingertip injuries, obviously all the local flaps like Atasoy, Brunelli, we're using again dermal matrices with very good results in small fingertip injuries. And the posterior interosseous flap is the go-to flap for dorsum defects. As well, we've used it proximally based to cover defects around the elbow joint. And nerve injuries, all of us treat. This is an uncommon posterior interosseous nerve injury which we got. And again, you can see his 5-year-old follow-up. And we've gone on to do revascularizations and replants. So this is one of our patients who came with the thumb like that. This is again his 4-year follow-up following the revascularization. And this is another replant, the 8-month follow-up. So I come to the last part of the rainbow, which is the aesthetic surgery. So actually aesthetic surgery got a boost when we did the ISAPS live stream webinar in 2019. So this was the patient operated then by Professor Gerald O. Daniel. So this was her 19, you can see her in 2021 and now in 2023. So she continues to send us patients. So this is one of her friends on whom we did a root graft mammoplasty. And these are some other reduction mammoplasties in which we are using the superomedial technique. And the gynecomastia, I think there was a paper where they again showed the good results with vasoliposuction. That's what also we are using along with gland excision. And these 2 cases of breast asymmetry where lipofilling has been done to, and in this case, this is a 1-year follow-up of the lipofilling. Now, abdominoplasties obviously are routinely done. So this patient had an abdominoplasty 8 years. Later, she came for a monsplasty. So this is, it was done in 2020, and this is again the 3-year follow-up of the monsplasty. Blepharoplasties again are being done. And I'll share with you, we did the ASurge 2006 was again conducted in a hospital. So these are 3 of the patients which were operated on then. This is the result in 2008. And this is the result now in 2023. These are some of our own rhinoplasty cases. And the last part is, I believe none of us can go forward without some innovation research and teaching what we know to others. So as part of that, we were able to start the DNB program in 2019. And this is some of the teaching and research. Dr. Kawamoto also visited our hospital. And this is, of course, during the ISAPS live stream course. These are the regular microsurgery workshops we hold for trainees at West Bengal. And during COVID, we had lots of webinars where we realized you could get international faculty at no cost. And some publications from our department. And some of the ongoing studies in which AI printing with stem cell therapy for diabetic foot ulcers is showing encouraging results. Thank you. And as teachers, we believe that we are successful only if our pupils become far better than their teachers. Thank you.
Thank you, ma'am. It was wonderful. It was more of an oration, so I don't invite any questions for this.
Thank you.
Thank you so much, ma'am.
Now I call upon Dr. Rajan Tandon from Kolkata. His presentation will be paradigm shift from bilamellar to single layer dermal matrices in clinical practice.
And greetings from Kolkata. So I'm going to give a little different perspective, and I'm not going to repeat what Anirban's already said, otherwise you all get bored. So I started using dermal matrices in 2020. I think it was February. So it's nearly 4 years now. And for the first 3 years, we just had availability of the Biolab in Integra. And for the last year or two, we've got single layer ones, a couple of them. including some ECM matrices also. So with that introduction, I think everyone knows this. I don't think I need to, but every word out there is important for the juniors. And these are the available matrices. Actually, the last three are ECM matrices, while the top two are dermal matrices. Now, I think Dermacell has promise, but the problem with Dermacell is very, very expensive. And they have availability issues. So we started using Metriderm in the last 8-9 months more regularly. So I will just skip over these because Anirban's already done it. So for me, in one sentence, the indications are difficult wounds, difficult areas, difficult patient in terms of psychology as well as physically, a moribund patient. So I think these are the areas where actually this just slips into the reconstructive wheel. I think it's made a dent, and you now have a spoke in the wheel with the dermal matrices. So I'll show you a few cases. I'll take you through my journey of how we started and how we've just evolved and changed into a single, sometimes a single stage, but usually a dual stage. So this was beginning of our practice, I think sometime in 2020. Young girl, parents extremely influential and ready to spend. So I had heard that Integra is very good, and from my friends in Britain, we never had it. So I said, okay, on the 3rd degree burns here, I would use it. So we used Integra. And on day 15, this is the way we were actually, we learned about Integra, that this is the peach color that you get. And in the upper part, which were deep dermal burns, we just used skin graft. So this is a week and a year later. So if you, sorry. So if you see the texture, the color match, I think it's all much better than you see the left, hypochondrium area. So another place that is really difficult is the dorsum of the toes and the fingers when you have burns. So this patient actually came to me 2 months after his burn when they were not healing. As you can see, a moribund, very, very morbid patient. We don't want to do too much, but you certainly want to debride very well. And then you see that the extensor expansions, some areas you see the dorsal joint lying open. So we used Integra again out here. And unfortunately, we didn't have a very good take of the skin graft. However, he was reluctant for surgery, and so was I, because he was really a bad patient. So we kept dressing, and at 8 months, he just appeared one day and looked like this. I will show you the next video. And this is 2.5 years later when he came with cellulitis in the other limb. So it's a near normal appearance, despite no take of the skin graft. So generally, I found that when you put a dermal matrix and there's no take of the skin graft, it takes about 4 to 6 weeks and it generally heals like a normal skin. Makes me wonder sometimes whether we should just put an allograft or just leave it alone. Another patient who had deep burns on the fingers. Now this is the problem we realized of using Integra and keeping it for more than 3 weeks. You have hypertrophic granulation coming up. So actually within 3 weeks you should graft it. Ideal is 2 to 3 weeks. This is how it looked after 1 month. And this was in the early days of my practice, so I felt not so great, but 9 months, pretty good, both hands. And then, see, this is good function in the left hand, although there is a web creep, there's no doubt about that. But good pliability and good function. This lady did not come for the correction of the web creeps. This patient, we had actually grafted him for necrotizing fasciitis defect 3 years back. And then he came to us with another traumatic ulcer over like the tibialis anterior tendon for 4 months. He tried everything before coming to us. The reason is obvious, cost. So we debrided and then we again used IDRT here. 3 weeks down the line and then we grafted it. 6 days looks good, but at 2 weeks we found we lost the graft. We just used allografts on him because he couldn't afford more than this. In a month and a half, it's almost healed on its own. And this is what it looks like at 10 months. And these are his videos. You see the pliability, and we've managed to retain the function of the tibialis anterior. Another patient where you really don't need to use Integra, or you don't need to use a dermal matrix all over the place. So you just use it in the areas that are exposed. So this is what it looks like at 1 year with decent pliability. I will not show it again. Now this was a salvage procedure where we lost the outer paddle of the fibula. We had given a double paddle fibula, but the fibula was all right, as you can see. Probably kinking of the perforator, perhaps a technical error on our part. So we did a salvage DP, but he had epilepsy. So when we left him, after I think 7 days or 5 days of the DP, we left him. I think on the 10th day, he had status epilepticus. Following that, he got treated in his district hospital. I don't know what happened really. He came back to us after 3 weeks with the flap black where we needed it the most. So then we racked our brains, and then we started using Integra then. So we used it. We wanted to graft at this stage, but then he had some issues and he came back after a month. Now this is another problem. The granulation is too much, and this leads to a lot of secondary contracture. So if you don't do the grafting early, now in case of matriderm, you can actually do it at 5 to 7 days, what you do at 3 weeks in case of Integra. So that's a big advantage and the change in the practice. So this is another bad patient. Ultimately, as you can see, he's got those ulcers for 6 years, and these are very, very difficult to treat. So we did do decompression dressings and debridement, and we, again, at that point of time, I think this was the first case we used Integra actually. And then those healed. But then 9 months later, he developed new ulcers, but not in the areas where we had used the dermal matrix. So post-tuber excision also we used it in a dermatofibrosarcoma. This boy did not allow us to take a knee, although I wanted to do a skip flap, but he did not allow us, so we decided that, okay, we will excise and we will use the dermal matrix and just graft it. So this is a decent result at, although there is hyperpigmentation, but functionally good, can wear shoe, can do all activities of daily life, even plays football. And no recurrence, 9 months, but his father is in touch with me. He's gone outside, so he says he's fine. So now this is where our practice turned somewhere last year, and we started using the single layer when it was available, because with the bilaminar matrix, it was really, the costs were very high, it was taking too long, and repeated hospitalization. So here there's a huge scar in that anatomical snuff box area, although we could close a bit of it, and also in the dorsum of the hand. But this post-burn scar defect, we actually put matriderm 1 mm. So here, that's another advantage. You have different thickness and different kinds of matriderm available. So we put that, and then we did a primary skin grafting. We did not use any NPWT. We just used normal dressing like we do in skin grafting with good immobilization. This is what it looks like at 4 weeks. This girl is from Bihar, so I don't have a long-term follow-up, but I hear she sends me good messages, so I think that is a vindication that she's okay. So in some of these patients who are really sick and unwell, and I had actually debrided this patient, and I thought of doing an LSMA propeller flap. But although I got a very good Doppler signal, but on exploration, very often you find that the Dopplers cheated you. So it didn't look like a very good perforator though. So I actually just closed the exploratory incision and then debrided it well and convinced them to use the single layer matrix. And this is, we used the flex 2 mm. And then we did secondary grafting after 7 days. This is what it looks like at 5 months, so pretty good, with very little secondary contracture and good healing, stable healing. So you can get away with, doing little for these patients and achieving more. Diabetic foot stump, now this patient was a very bad patient, elderly, a lot of comorbidities, and with critical limb ischemia. And he had occlusion of both the anterior and posterior tibial arteries in the proximal leg. So he had already lost 3 toes, so we managed to debride, amputate the toes and get angioplasty done of the anterior tibial. Posterior tibial could not be done. And then we dressed for 2 weeks, and then we did partial closure, but over that stump, again, I used it in a single stage. We just put the flex and the skin graft. And again, no NPWT really. So again, here we lost large part of the skin graft. It's maybe 70% is lost. But over a month, see, it's healed. And it doesn't look like scarring. Maybe some secondary contracture, but it doesn't look like scarring. So extensive degloving with some areas open. Again, not a very affording patient, but very old. CABG done 5 years back. And, when you're dealing with these patients, I think it's best to just keep them alive and going, rather than doing anything fancy. Although, I think in bigger centers, they could have attempted I just have a team of 2 surgeons, and I don't think we can take the risk in private sector. And then he could not afford too much. So we just debrided early, put him on dressings, and then what we found that there were some critical areas exposed. And he could not afford too much. So we made him buy the Metriderm for the right heel and the TA insertion that was exposed. And we had in our stock an old IDRT, which we used for the right tibialis anterior that was exposed and the left medial malleolus. So again, patient again trying to get funds, so waited for 2 weeks. What we found that while the take was good in the left medial malleolus and the heel area, but the tibialis anterior, we had to debride quite a bit of it. It didn't have a very good take. So I think the tendon was exposed just for too long. So this is 3 weeks after grafting, he's still in follow-up. I think he will recover. We've allowed him non-heel weight bearing on the right foot. On the right foot. And his left foot is more or less recovered. So this is a case we just did last week. I just show it for completion, that we did a complete release of the scar, and we put a 2 mm matrix, immobilize it with NPWT. So I've heard a lot that it gives good results. This is the first case I've done, so I really don't know. But then we need to do our first case sometime. And this is the grafting that we've done just yesterday. Again, immobilized by NPWT. And the Z-plasty we did for a right little finger. There was a residual defect on the middle phalanx, distal part of the middle phalanx. So we just put the little bit of Metriderm that was left there. So in conclusion, I would say that it does help cover small areas of tendon and bone exposure, provided you do it early. I think with the tendons, you don't wait too long. If you wait too long, they desiccate, and then there's no point doing it. It doesn't take very well. And it does reduce the rate of secondary contracture. I think the idea is that it being acellular doesn't invite too many myofibroblasts there. So if not too many myofibroblasts, there's lesser secondary contraction and hypertrophic scarring. Provided with Metriderm, I think you should do it within 5 to 7 days. Don't wait too long. You wait too long and there's granulation tissue, and hypertrophic granulation causes too much of secondary contraction. So it offers an easy solution for difficult situations. And I think it is definite spoke in the reconstructive wheel. But if it is a fit patient and affording patient, I think here also it costs. So it's not about affordability alone. I think it's a fit patient. Flap, if it's the best option, should be done. There's no question about it. It doesn't replace it in any way, but it does salvage situations. And it can be applied not only as short stay surgery, we started even applying it in the OPD, in some well-debrided wounds, because it's very, very easy to handle, especially not Integra, but Metriderm. And of course, it has a cost benefit if it's used properly. The advantages here is that we really save on time, energy, money, man days lost, and very, very easy to apply, and it virtually just goes and adheres to a well-debrided wound. You don't really need to fix it very, very well. So I think that's a big advantage of the single-layer matrices. And of course, in some cases, well-selected cases, where the wound is really, really well vascularized and good, clean wound, and you feel confident about it, you go for a single-stage surgery. So I think change is the only constant, and ability to adapt to this change is a measure of our youth. So if you want to stay young, I think keep changing. Thank you.
Thank you. Thank you, Dr. Tandon. Your application of single layer ADM in a various wide spectrum of wound.
Yeah.
It's good presentation. Thank you very much. Because of lack of time, if there is no question, any questions? Only one questions.
I showed it. I've just done one. In fact, today I've stacked a second layer. So in some situations where, in some situations where like the calcaneum, if the posterior calcaneum is open, it's quite wide actually. It's about 2 to 3 centimeters, if you see. And if it's well debrided, then you can actually put the matrix, a thicker matrix, and leave it for a week with negative pressure, and then review it. If it's not ready and it's just a slight layer, you want more, you can stack it. You can put another layer. And then wait another week and then do the grafting. Exactly, so that's my point. Where the graft loss happens, if this kind of creates a collagenesis in the area, over 4 to 6 weeks, we find that it tends to heal. But if you put a graft, there's better control over the pigment. So sometimes you're doing it like on the neck, on the abdomen of a young girl, you're doing it for even aesthetic reasons, right?
Thank you, Dr. Tandon. Now I call.
Thank you.
Call back Goswami from Ranchi. He's not here. Dr. Goswami is not here. Now I call upon Dr. Vikram Singh Rathore from Kolkata. He is speaking on how to harvest maximum out of minimum FUT method of hair transplantation.
Last talk today?
Dr. Prashant Bhattacharya had it.
Oh, I thought I am going to give a concluding talk today. I am really thankful to the organizing team to invite me here. So how to harvest maximum out of minimum in FUT method? I have no financial disclosures. These are my hair gurus from whom I learned directly and indirectly about the hair transplant. And as we all know, there is a limited donor area. You know, there are saved areas, various doctors have described the markings. There is a disparity between the supply and the demand. So how we can do it? By minimizing injury during the harvest, variation in the length of strip, variation in the width, variation in planning the HT procedure, like first FUT followed by next FUT, or FUT first, then FUE next, or untouched strip technique in which FUT in FUE is done first, leaving an area of FUT to be harvested later on, or do an FUT first, later on do FUT plus FUE in combination, or FUT plus FUE from the beard or a chest. So while how to minimize? Start. By making your incision beveled along the angle of exit so that there is no injury in the part of the scalp which is remaining as well as in the part of the strip which you are harvesting. And then once you have made a upper dermal cut, use a double traction hook to gently pull out the two edges so that there is no injury again on the follicles. Using magnification, loop or a video microscope for slivering. Then simple mathematics, if you want to connect A to B, a straight line, when you want a less follicles to be harvested. A gentle curve, you will harvest a bit more. A steep curve, still you can harvest more. This you can see in this patient, result the 5 months and compare the donor area both before and after. Then we all know about the pre-transplant scalp relaxation exercise, which helps in ease of harvest, ease of closure, and also helps in taking an extra of a strip. Then, what else? After tumescent, so if you do an tumescent and do an on-table massage, so what you get is either a few millimeter or up to a centimeter extra width which you can harvest. So what I do, again I have closed, and that's the sequential strip harvest technique. So after removing the first strip, temporary closure, do tumescent, do a massage for 7 minutes minimum, and here you can see this is a bit of laxity. Again you can harvest a second strip. Repeat the same procedure, you can harvest again a third strip. But keeping in mind the width and the length decreases consecutively. So you can see the patient immediate after 2 months and 10 days, 3 months, 3 weeks. And this is the appearance at the 3 months and 3 weeks of the donor area. The density and the appearance of the donor area remains same as it was before the surgery. And same patient, after 9 months, you can see the donor area. Hardly you can make out any scar, visible scar. And on the right side, you can see before and after appearance, the donor area density and appearance remains same as it was before the surgery. So now planning an HT, so FUT and FUE beard in this patient, I harvest 8956, of which FUT 7366 and beard 1590. And that's the result at 2 months, 10 days, 3 months, 3 weeks, and the result at 9 months. There's a small video of result at 9 months. And that's the untouched strip technique, a pictorial demonstration. So, on table scalp massage, what is the possible mechanism of action? It could be a stress relaxation or a hydrodissection, biological creep mechanism, yet to be discovered. I started this technique in 2014, and till date I have done 258 cases till now. And these are few of my representative cases. This is case number 2 with 4180 grafts. Case 3, planning FUT, FUE, grade 7 baldness. And when you really want to enjoy or you want to relax, your team is there to do massage for you. And that's the real transformation at 1 year. Case number 4, case number 5, 6. In this I harvested 6,300 grafts in one go. This is the first strip, second strip, immediate appearance, donor area you can see, and that's after 7 years follow-up. Case number 7 with 5802 grafts. Case 8. My second passion is cycling. Thank you for patient listening.
Thank you, Dr. Rathod.
Thank you.
Is there any...
You have told 6,400 something grafts. Does actually, it is grafts or follicles, sir?
It's the grafts, not follicles.
Okay, sir.
Do you add PRP in the subsequent sessions?
Yeah. For definitely, in order to expedite the result and to take care of the untransplanted area, I advise my patients to PRP or a GFC in a post-operative period.
There is a article, Dr. Anil Garg
Yeah.
presented in the, I think, 2017 conference. he was using simultaneously at the time of surgery.
Yes.
With PRP, with this implantation of the...
Yeah, I am using a PRP as a graft holding solution.
Okay.
Also, I am just doing PRP first in the recipient area and then I harvest.
Okay.
So there is a gap of around 2 hours. So the PRP get distributed in my recipient area very well, and the part of the PRP I use as a graft holding solution also.
Thank you.
Thank you.
Thank you.
Thank you.
Dr. Bhattacharya. Dr. Bhattacharya, please.
Respected dignitaries on the dais and off the dais and my colleagues. First of all, I want to thank the organizer forcefully taking me in this auspicious days of Aprasocon 2024. My topic is definitely a unique topic, that is limb salvaging by using bipedicular sandwich flap coverage for exposed bone in large wide composite defects, where we are puzzled to do anything. I'm not going into this. Management of composite defects of leg following trauma requires planned orthoplastic procedures right from the outset. Timely planned intervention results in reduced amputation rates and improved limb salvage and functional outcome. Right from the time of presentation of the patient to emergency with such injury, process of decision making in terms of salvage or amputation, local flap cover, free flap cover, bone reconstruction first, or soft tissue, or both combined, come into play. Early intervention and primary surgical decisions after proper cleaning and debridement play a vital role in preventing such composite defects. We should always be aware of management mechanism of injury, type of injury, age of the patient, patient's general condition at presentation, other comorbidities, and delay in time from injury to presentation. These are the things we are having it regularly, day by day, every one of us. And these are the devastating wounds. We all know about the Gustlo's classification. Objective for choosing bipedicular flap. This paper deals with Gustlo type 3B fracture and other extensive soft tissue wounds where different types of surgeries can be performed, like local transposition and rotation, fascicuteness, myocutaneous, osteomyocutaneous, and muscle flaps. Reverse flaps like sural artery, sensate flap, perforator flaps, angiosomal flaps, depending upon the availability of healthy vascularized tissue. Free microvascular flaps also has been performed. But these are the initial procedures which we used to do previously and now also in some cases. These are the things, combination of skin grafts and flaps, exposed tendon where we used to compartmental graft, amputation, reverse sural artery. These are the things we used to do previously. This is free flap also, reconstruction of unstable post-traumatic wound over heel. However, the above flaps are not readily available and the surrounding tissues may not be dependable, leading to failure of flaps, even free microvascular flaps. In such cases, bipedicular bivalve sandwich flaps are very much satisfying and predictable and less cumbersome and easy to perform in lower limb wide defects type 3B wounds. What is bipedicular flaps? Bipedicular flaps are random patterned flap but receive a blood supply from two pedicles, allowing the surgeon to use local tissue with an augmented nutrient blood flow, simple to elevate and economical in operating time, simple solution for difficult problems in extremities. These are the schematic representation. This is a small wound with open tibial exposure. We did a bipedicular flap. This is a wound with exposed tibia with chronic osteomyelitis of tibia. We did bipedicular flap as well as skin grafting, and later on in the same sitting we did a muscle flap, gastrocnemius muscle flap. Advantages: bipedicular flap gives predictable vascular and nerve supply from both above and below. Bivalve gives required sufficient areas of soft tissue coverage, including muscles, the huge defects including both bone's length, both in length and breadth. Usually fasciocutaneous flaps are used, but myocutaneous and mixed flaps are also can be taken. Sandwich flaps to cover lengthy defects from both sides, predictable vascular and nerve supply, large area in length and breadth can be covered to by fasciocutaneous flap. Used bilaterally to make it sandwich to cover wide defects, can be used in both upper and lower limbs, can be easily done by general and orthopedic surgeons also. Much expertise of plastic surgeon is not needed. More lengthy and costly procedures like free microvascular flap, perforated flaps, cross-leg flaps, other flaps may not be the solutions to cover the large and wide defects. Cost effectiveness and single stage procedure. Donor side area defects can be minimized. We did 40 cases in 4 years. Inclusion criteria, gastrullotype 3, wide gaping, all age groups, every sex, wounds involving all extremities are included. Exclusion, wounds with excessive bone loss were excluded. This is one case with exposed tibia and highly infected, wound debrided, and in the same sitting we have done bipedicular flap on both sides. This is exposed tendon Achilles, we did bipedicular flap with skin grafting. This is exposed wound around knee with osteomyelitis of patella. So we did bipedicular flap on both sides along with skin grafting. This is exposed implant. We did a bipedicular flap on both sides. This is amputation stop exposed necrosed. We did bipedicular flap along with skin grafting. Upper limb compound fractures, we did bipedicular flap. Chronic osteomyelitis with lower limb tibial defect. This is a case where 5 years osteomyelitic limb was there and limb was debrided. Tibial osteomyelitis excised, sequestrum removed, and all the orthopedic surgery has been done by us, along with muscle flap. Muscle flap gastrocnemius we have given to the osteomyelitic wound with cavity, and after that we give both sides bilateral, bipedicular flap, sandwiched in between, and raw area covered with skin grafting. Exposed wound around elbow, we did bipedicular flap and skin grafting. Compound injury, gastrotype 3C, here also we give bipedicular flap and skin grafting in the raw area. Infected granuloma over tendon Achilles, excised and covered with bipedicular flap, and raw area grafted with skin. Long open tibial wound with osteomyelitis repaired with muscle flap and bipedicular flap. So complex lower extremity soft tissue defects pose significant challenge to the reconstructive surgeon and often require use of free flaps, which puts significant demands on patient, surgeon, and healthcare system. So bipedicular flaps are random flaps with blood supply from two pedicles. It allows surgeons to use local tissue with augmented blood flow, and if sandwiched from both sides can cover large and wide extremities defects with predictable vascularity. This study describes our experience with lower extremity wound reconstruction using bipedicular flap as an alternative to pedicle flaps and free flaps. Thank you very much. Conclusion, bipedicular flaps provide a safe, fast, and relatively easy alternative for coverage of certain complex open wounds in lower extremities, simple to elevate, economically in operating time, easy to perform, minimum expertise and knowledge, predictable, and cost effective. Therefore, bipedicular flaps are simple solutions for difficult problems in extremities. Their use does not include the use of more traditional options of predicted muscle or free flap coverage at a later time should they be required. We believe bipedicular flap to be a much underused flap in superficial soft tissue reconstructions. Active consideration of this flap can be suggested as a reconstructive option for a variety of defects on multiple body sides. Thank you.
Thank you so much. Lovely presentation. We can have one question at the maximum if anybody wants to ask something.
Limitations, if the surrounding skin is very much devitalized, I mean vascularity is impaired, then I did a case just 2 or 3 days before. There was vascularity was jeopardized. The superficial venous system and deep venous system got clotted and everything. So atherosclerotic artery, and in that case we cannot use, and in that case we cannot use anything. So we have to go for amputation. But still, there also we can try this. I have tried it, but failed.
Thank you so much. We had a very long session, but it was quite good. Thank you. Thank you all the speakers for giving their talks. We'll hand it back to the organizer. We are holding Navicon in Ranchi on 15th to 17th February. Please join us. It's going to be a different conference with no long talks. It's basically symposias mostly, small presentations, 4 to 6 minutes, and discussions. Everybody gets a talk there. Thank you. Please go on the website. Yeah.
I'd request our Secretary of East Zone Association of Plastic Surgeons, Dr. Akshay Raut, to start the general body meeting of East Zone chapter.
Before Akshay comes in, let me much headway in the last 10 months that we were in the office. We've been trying to get the body registered. Papers have been submitted. Maybe another month or so, we would be getting our papers done. The non-members of East Zone may kindly enjoy a cup of tea or coffee outside. Number one, the change of guard. As we had said earlier, the secretary and the treasurer remain same. We have 3 EC members. We're going to add 3 more today. We're going to choose one president-elect. For
last meeting, I'll tell you.
Yeah, go ahead.
Actually, first GB meeting of East Zone Plastic Surgeons held on 29th April 2023 at 4:30 p.m. at Kolkata. Everybody listen carefully. At Rotary Southern Kolkata, and it was held in the sites of annual conference of Association of Plastic Surgeons of West Bengal. And meeting was attended by plastic surgeons across East Zone, notably from West Bengal, Odisha, Bihar, Jharkhand, Tripura, Assam. And agenda was the validation of Association of East Zone Plastic Surgeons. It became ratified as a Association of Plastic Surgeons of East Zone, EJAPS. And in that meeting, it was decided that that president was Dr. Anand Sinha from Jharkhand. He took over from Dr. Burma. Then secretary was Dr. Akshay Raut. Treasurer was Dr. Biswajit Mishra from Odisha. And 3 executive members like Rajan Tandon. Where is he? Rajan Tandon from West Bengal. Dr. Pritam Das from Tripura. He is not here. Dr. Pranav from Bihar. And it was decided that except for secretary post, which is for 3 years, rest of the posts are for 1 year only. And that agenda was, first priority was for registration, and that organization has to be ratified. And as for the registration process, it has already been started. And by February or end of February or March, I think the process will be completed. Regarding Vice President, Dr. Anjana Malhotra was, at that time it was declared as Vice President for the coming year. I think according to that meeting, she will take over in this year. Okay. And about the addition of more executive members, that depends upon the members who are sitting here. If they will propose, then we can extend it. Another 3 members is already there. Their tenure is finishing. And it is not an election process, it is a selection process. So from each zone, we can choose a member. Each state. लिखी दियो प्रशांत भट्टाचार्य from proposed and seconded by as a EC member from West Bengal.
Please follow the sequence of the agenda that you are saying. Okay. You have just asked for the idea of consensus on addition of more executive members.
Yeah.
So first we have to discuss that how many members.
No, at that time it was decided that 1 year. If you are, listen, if you are suggesting, then your point is taken. If everybody agrees for that, then we can do that, no problem.
We have to follow some protocol from guideline. The Association of Plastic Surgeons of India, they have 3 years. So we have to follow some guideline.
Okay, sir. Okay, sir.
In Aprasocon also, we have made the same guideline. So what Dr. Giri has told out, our General Secretary of the Aprasocon, I think that is a valid point.
Okay.
That we should have minimum 3 years. Although 1 year is nothing. It passes up very quick.
If everybody says yes, then it will be taken.
I think, Dr. Akshay, I have one point. All these things we are discussing has a little debate. It is okay. But has it come in the bylaws?
Yeah, it has been mentioned in the bylaws also. I made it. I will circulate that.
Yeah, I think I have been also pursuing you that bylaws should be given to every member.
Yeah,
so that a consensus should come. Please, a consensus should come out so that everybody shares and not only actively participate in that.
Okay.
Then all good suggestions that will come and it can be fermented. Because you see, when we make bylaws, I was the president and Dr. Sunil, where is Sunil? Sunil was the secretary. We have taken quite good time in sitting together, making lot of ratifications, modifications, taking up different associations of the country and also the national body. Then only we format our bylaw. Still 10 years have passed. Still it is valid and it is working very nicely. So right like Dr. Giri has told, these small things matters in the long run. Because whatever you made in the registration, suppose in Calcutta, I suggested first time in Calcutta, because of its geographical area in Kolkata will be better for registration. So in that issue, you cannot change those bylaws, it's not so easy to change.
No, sir, bylaws will not be changed and that PDF format is there. I will circle. Yes, sir, it will be circulated and your opinion will be well taken.
No, actually now if you have already given as 1 year and you have sent it for registration, then changing to 3 years, you...
No, because bylaw has not been implemented, it can be changed to 3 years, it's not a problem at all.
No, but have you sent it for registration with the bylaws?
No. Only I have completed the certificate processing only. So I have not sent it for registration.
Change it every day.
See, we had shared the North Zone chapters, this thing, once, about a year and a half ago in the group. Most people have gone through it. Believe me, there are not many changes. We just change the name of the states and everything else practically remains same. We're going to carry on with that only. Since last time we had only 3 office bearers, so this time the whole house is here. We decide what we normally follow in the APSI or any other organization. That the executive body members are there for 3 years. The secretary is for 3 years. The treasurer also should be for 3 so that he gets some time to complete. The president only changes every year. It's already decided now. Just only the house has to say yes or no. That's about all. So we go for 3 years with the executive body, the secretary and the treasurer.
Okay.
3
years.
Yeah.
For example, we have Calcutta, we have Odisha, we have Bihar, and also Northeastern states. So four ECs would be there. We cannot neglect Northeastern states.
No, we are not neglecting.
Let him complete now.
The representation should be there from each state.
Yes.
So that their problems can be sorted out. Not that Northeastern people will come to this Calcutta and they will take. At least Northeastern we have, I think, 7 states.
Seven.
Calcutta is West Bengal 1, Bihar, Jharkhand 2, so 8, 9,
11. Altogether 11.
So 11. So मेरे हिसाब से 4 ECs. Because we have not gone to the registration of EC. So if we have 4 ECs, everything will be properly represented. There should be representation.
There's no harm adding one more because, see, we need people to represent there.
Pritham is from Tripura and Pranav from Bihar. From Odisha, one from Odisha and one from okay.
So every year we add 4 so that we have 4, 3, 12 people. Good enough. Yeah, good.
So you can propose a name also. One.
Odisha, we need one name.
You can propose one name. EC. No, that was 3. No, that was 3 members only.
So now we assume that
every state has to have a representation.
Not necessary.
This year it will be 4. Yeah. Why now?
So we invite 4 people to join the EC this year. Will that be okay with the house? See, there's no money to be paid, no record to be maintained, so that there's no harm. We add more people, so more the merrier, more work can be distributed. So 4 is fine every year. We ensure one from Northeast is there somewhere. I mean, 1 person there from the Northeast every year. Yeah.
And other thing is, final is, again we'll select a VC for the next year because ma'am will take over as a president. So VC will be there and it will be a selection process, not elections. So in my viewpoint, I propose Professor Arun Chaudhary to be the VC.
Proposed by him, seconded by me. Unfortunately, he should have been on the chair earlier, but he was busy with the APSI election, so we gave him a break. He deserves it more than what me and Dr. Anjana deserve, but... Sir.
Last year, I have contested 2 times in 2019, then in 2021, it was e-voting. So in 2022, it was in Amritsar, it was also a physical one. So all these 3 times, from the Eastern region, all people have volunteered and not only have supported Dr. Sinha and all the team members. I'm really, with humility, I'm telling, I'm really thanks to everybody for the support. But last year, I didn't speak out because strategically there was some change was going on. Let us not discuss of that. I think we have already made in the video meeting we had last time with the Zoom. So there is a lot of politics going. It's simple from outside, but inside, in a pan-India of APSI, a lot of politics going on. So even this year, this should not be the topic now, but I just speak out. We had 2 candidates, one from Bhubaneswar, Dr. Giri and Dr. Aprasocon. So both are
Rathore also.
I'm sorry, Rathore is there. So 3 candidates were there for EC members. They could not qualify. Not because they are not meritocracies. They are absolutely meritorious, they are genuine, honest, doing lot of whatever required for the eligibility to be an EC member of APSI. But again, I tell you, there is something going on on the ground. I wanted to break that chain of Maharashtra's house chain. Somehow this time, Shubha won only with few votes, only 64 votes. So if I would have fought, now I'm telling you, expressing the real fact, if I would have fought and Dr. Kalra from North would have fought, then definitely it was gone to Maharashtra. So there was no doubt here. So strategically, I didn't file my nomination. only because I wanted to break that chain. At least that break his chain, and now Dr. Subhash Singh became the president-elect. So for future, we have to think for last 30 years, from Eastern India, we have no representatives in the national level at vice presidents. So it is not I am telling you a disgrace, but it is matter to be taken very seriously that why we are not qualified. Or nobody from the Eastern India is qualified to go to the center as an executive, as an executive. So also only Bina qualified from Bihar, Patna. Otherwise, we have only 3 executive members now. Dr. Gautam Biswas somehow voluntarily told I am not going to fight in these political elections. Then second point was Manoj Khanna. Last time you know Amritsar what he did. Even we decided in his zone that we will have one candidate. I was told to be nominated. I have been nominated also. Then last moment he jumped from the parachute in Amritsar. So you know all these things we are not going to discuss. But my point is that we should be unified like Maharashtra and other South people. How to unite? All the members are here. Now find out the way and means. It is not personal. Everybody, the democratic right is to can stand for any post as executive member or whatever. But if you think personally, individually, without doing a homework for that post, I don't think anybody is going to succeed. And if this trend goes on, you will say after me, there will not be executive member from Eastern India to fight for a vice president administration. So we do apology for telling all this. I request all of you to take it very seriously because why I am telling you, unless you have a representation, first 2-3 days in the meeting, you must have seen those people whom they choose, they will be the premium speakers. And you will be sitting on the 3rd, 4th day and the speaker, I remember one day I was chairing also, madams, I was lucky to be chairing your A.C. Ganguly Memorial Audition. But unfortunately, fortunately, I was given that chance, I don't know how it happened. But on the last day, we will be chairing a session. You will be saying, speaker will be there, 1 or 2 people will be there. That is the scenario I have been going, because from 89 till then, I have attended all the national conferences, all the international conferences.
Sir, wind up, sir.
I told all these.
We get your point, sir.
These points are very valid points. Why, if you are really interested to really have a very strong, robust, united front, then we can go ahead and make many issues, many things possible for the students.
We'll do that, sir. So first of all, I have the privilege of welcoming Dr. Sudarshan Balyar Singh and Dr. Amit Balyar Singh, sir. Welcome to the group, sir. His own chapter. Thank you so much, sir.
To summarize the final, that Dr. Anjana Malhotra, she will be the president. Dr. Professor Arun Chaudhary, he will be the president-elect, vice president and president-elect, that is president-elect. And 4 EC members is to be taken from this year onwards. And secretary post is for 3 years and is going to end after this term. And treasurer is our Dr. Biswajit Mishra. He is for infinite time. And one request, if everybody agrees, then I can take another person as a assistant general secretary, so that that registration process and everything will be smoothened out. So
No assistant. Let's make it into a joint secretary. Yeah. Joint
secretary. And I also talked to Dr. Ashish Patnaik, he will do my work. So if everybody agrees, the joint secretary he will be.
Where is he? Is he here? First class. But does anybody object to him joining us and helping? Fine.
Okay. And any other agenda? Somebody has asked. Yeah. No, somebody has asked that why there was a failure in Aprasocon 2023 and what is the vision of that president, upcoming president, and what will do for the unity of this East Zone chapter. So these are the questions somebody has, I think Pranav has asked that one. So anybody can answer that.
No, I'll answer that. I'll answer that. Since they are, to me, number one, we are not failing, but we are not succeeding. दोनों में बहुत फर्क होता है. Failing होता है जब आप बिल्कुल sure हैं कि आप निकल जाएंगे and then you slip off and you go back. Unfortunately, we had 4 people initially, then we made it into 3. From any zone, more than 1 or 2, definitely there's going to be some friction, number 1. Number 2, whether we like it or we don't like it, we have not made forays into the south, the west and the north as an individual member. We've been calling them over here for the workshops, get to know the faculty. Unfortunately, we are not going there to talk so that people get to know you more. From my personal experience, it took me almost 3 years of moving around in the whole country to convince people that probably I'm the right person you should vote for the next NABI election. That was 2 years ago. It takes time. It doesn't happen overnight. It doesn't talk of the unity of the East Zone. It talks also of the candidate, how strong he or she is and how much movement he or she has done individually also. If you've done a good movement individually, the zone is going to back you definitely. Plus, most of us have not voted also this year.
Yeah, that is, even online was there, but many people didn't vote also.
So let's first pledge that all those people not become APSI members, first become APSI members. Number 2, we decide that yes, all of us are going to vote. In fact, the people that we've now chosen at the executive board, it was their job to ensure from their state almost 100%. What about almost? It should be 100% voting. It's online. Could be holidaying somewhere in Mauritius also, or rather Lakshadweep also, and you can vote from there. So please get on to that. I'm not demeaning anybody's candidature, but yes, we need to become stronger in our candidature. We got to move around. We have to move around with them also. I'm prepared to move around. Second, impact at the APSI level, as just mentioned. I had mentioned also that I'm going to do that. The very fact I got a list of 45 PGs from the Eastern Zone was this, that 45 into 3, we have 135 PGs with us, or trainees with us. That's not a small number. You got to storm the conferences. For the NABICON also, I think we just have 12 papers from the Ps from this part of the country. Even though I won't be the president next year, but let me assure you, I want to take at least 15, 20 from the East Zone, some in the best paper and also in the free papers to Coimbatore. And I will make sure the papers are accepted and they are put up in the prime time so people can see you. The papers and their guides should be presented into the hall to defend them also. Will that be okay for all of you? For this, I've already spoken to Dr. Pauline. He will have at least 2 people in the Coimbatore, Dr. Seema Rekha Dev, Dr. Kalita from Guwahati. They've all been in touch with me. Let us start from there. Let us make our presence feel on the academic level strongly before we talk about ourselves. Same thing happened in Amritsar. Probably something happened in Indore also. We did not have a good representation.
Yeah, this time...
We had, unfortunately, we were not given the prime slot talk. Very nice. So let's go for further. That's number 1. Number 2, regarding the unity and the consensus, it's up to the parent state body to project one member. The East Zone chapter cannot decide everything. I was at a loss when I saw 4 people standing. There's no way you can tell someone you cannot stand. No. That's his right to stand.
No, that is conscience.
He is post-MCH. He knows how smart he is and how much foray he can make into the national level. We don't decide. We can only advise and talk. We talked to Sunil. Sunil withdrew in his favor. It's a very good gesture. Came in the group also. But the state level bodies have to decide whom they want to project next as the executive or whatever post in any of the elections, not only APSI. Could be NABICON also, could be ISKCON also, could be what Brickyplex says, ISRM, anywhere. So I believe those questions have also been answered from my side. ऐसा नहीं हम लोग घर बैठे हुए कुछ कर नहीं रहे. We are trying hard, but there is a problem. We do not have a strong recognition whether you all like it or you don't like it. This time, Coimbatore, allow me, Dr. Anjana also will be with me there. We're going to make a strong presence there. I will catch hold of all the PGs from here and there. My term as Nabi also ends in February 2nd week, so I'll have a little more time with myself. Nabi, yes, was a hectic year. I have broken all the records of Nabi by making about 13 workshops all over the country. Yes, I'm quite happy with my performance there. Unfortunately, could not do much here. He also became too busy. We could not even go for proper registration. We met twice, but we could not do it. But we will not do it for you. Anything else? Yes, Pranav.
He's asking one.
I will need 2 minutes. So before coming here, I talked to Dr. Veena and Dr. Verma also. So I asked that what is the vision of vision, what is the need of it? We all have state associations with us. Why do you need it? It told me that we need to strengthen the academic association and its unity, the feeling of unity among them. The thing is, sir, what I feel that someone has to ask it, so I am asking it. It's not of my personal venture. That a secretary report has to be given. That what you have done in the last year, as a secretary, as a president, no executive members have been done, meetings, no executive meetings have been done, not called for. Number one, sir. Number two, but I have posted it also, no academic activity has been called for. Don't let your kids fight first. Fight your own fight. If your officers are not attending the conferences in enough numbers, please don't ask your PD MCS president to fight for. You are in strong position. They have their professors, their faculty with them. I was still expecting someone to say this, that 135 PD that you are counting, 180 or 200 members you have, you should ask your members to attend with you. That you are. But don't let these PD students spend the money to attend the conferences for what? They should not be asked to fight your fight. So the thing is that you have to answer, and everybody has to answer, that what is going on.
Fasting is actually till now.
Right there.
First question is already answered by Veena madam, so no need of answering that. That is my answer also. Second is, what is the work of the secretary and secretary report? That was the question. Actually, till now, the association has not been registered. So, first and foremost duty to register. So, answer of the question. Actually, once it is registered, then it will work like a proper association. Number 2. Number 3, don't fight your kids. Don't fight your kids. मतलब पीजी लोग फाइट करना नहीं चाहते, नहीं चाहिए. Fight, yes. That was a good answer. That was a good answer given by Atal Bihari Vajpayee, sir. Actually, he told why Afghans won against India. India is such a large country, but Afghans won because we have divisions. Only those persons who are fighting in our caste, they will fight. Brahmins will not fight. Like I am caste, I will not fight. That is why the lesson is everybody has to fight. Kids has to fight, women has to fight, everybody has to fight. Not the kids will not fight, father will fight.
We got your point, Ashish. Next point if you have anything. We got your point.
Next point, sir. Next question.
Okay, fine.
No,
whole idea has been...
I'll answer Pranav's question.
Whole idea has been misunderstood. We're not letting them fight. We are fighting with them, number one. Let it be go on record. We are fighting with them. I am going to take the responsibility of fighting with them and their professors also. ये बात का बतंगड़ नहीं बनाने का है, ये fact है that we have to go with proper academics. Yes. Yes.
क्वेश्चन में आंसर करता हूँ। नहीं वो ये कर रहे हैं ना, नहीं फर्क नहीं है, उनको बोलना चाहिए।
I think give a stop to that, full stop to that discussion of students. One thing is in Odisha, we have 102 registered members. I don't know how much is there, madam can speak about West Bengal, or more than 100. What about Jharkhand and Bihar? So I think the membership should increase, and the national membership also has to increase. And the attendance to the conferences in the national level should increase. I think that should be the norms. Now, how to do it, it all depends on individuals per se and your group in the different places. I think that should be the aim to increase our numbers first, because voting and whatever you are talking, it matters not the quality. The number of votes. So we have 102 till date registered members of Aprasocon. So I think West Bengal has more plastic surgeons in Kolkata and nearby than in Odisha. But the membership.
No, total member.
First of all, this topic should be cleared. No? I think, first of all, what we are actually, what East Zone Plastic Surgery are. Actually, we have not done any criteria for making membership of East Zone. Now itself. No, not yet done, but not yet membered. I mean, number of members.
No, sir, last time it has been discussed that once the association will be registered, then membership drive will go on. So that has already been discussed. So yeah, they are ready.
There's two changes we have to make our office balances.
That we should have an united candidate from East Zone or not.
Okay.
Otherwise, if we are not united, we cannot dictate someone to take off and give your nomination to central level.
Only important to attend conferences and attend meetings and present. It's also important to organize international level meetings.
Yes.
I think
Where the zone can take a lead, this is my own opinion, subject to everyone's support. Everyone has their state association meetings, and it follows this same pattern. I think all of us have it the same way, where the local PGTs must get an opportunity to present and learn. I think what the zone should really focus on annually or half-yearly, do an international level CME and invite the others from the rest of the country. Then they'll know that this is a united bloc. They're doing good work. They're wanting to learn. They're wanting to teach. So learning and teaching is a very good way to unite. That's the way your ISRO will unite. I think that will be the glue. Yes.
Yeah.
Academics plus socially meeting is the glue. It's not enough to say that we'll go there, we'll bombard papers there. How many papers are you going to do?
No, Rajan, your point is well taken, but Rome was not built in a day. Single step you.
We got your point. We'll go in the merits also. Do something different from what the state association.
Yeah, gradually when one member will start working, then the rest will join.
Fine.
So that will
We don't have much time. Dr. Amresh Balgar Singh, you've been the APSI president. We invite you to talk about us, what we can do about it now. You heard so many things.
And you've been loyal to the state also. You got the conference to the state. My God. Not many people have done that. And you can talk as a sir.
I am to myself first. That's how. And how I want things to be done. So I can't stay in a cocoon, say that, everybody will be coming and wishing me and all You have to come out of, go meet people and do things. See, same thing for academics. Nobody asks me what I like to present or something like that. And many times I also request, see, to be very frank, many times I also request, another president, whoever is going to do that year's president or secretary or the scientific chairperson. See, I do these things. Do you think it will fit into your scientific job? scientific committee or program, do you think it will be useful? And many times also, see, I have gone through all the stages. Even I have asked to present in an audience where only I think the audiovisual guys are there. Still I have also presented. So I feel that auditorium is full and I am presenting. Who is not listening, they are missing something. Because the person who is on the podium, I think probably he is the most learned person because he must have done something and talking. That's how I put it. And second thing is, see how we interact with our own colleagues, how you put. So if we put interest on ourselves only, then I don't think it is a good idea. So naturally, if we think that for this zone, whatever is best, we should try for that. That feeling should come. Unless that feeling comes, then you are nowhere.
One strong suggestion from you.
What is?
One strong suggestion from you. One.
I think let's try something new, try something, good to continue to present. Because academically, if you are strong, definitely you will be appreciated. Because now, all these, people are from this zone more, that zone more, that is going to work to some extent. But majority are young people. They will appreciate if you are academically well, even if they say that. I think that is, one thing is, see, whether our colleagues are going to vote for us or not, that I don't know. But one thing is, I can be academically strong. I can interact with my colleagues to let my, feelings, whatever to let them know that this is what I want. And always be supportive to the association. If you are always supportive to the association, definitely you will be appreciated. That's how I put it. Because if I have to do something, I always think how it can take the association ahead. That I think the best way to get things done.
Thank you.
I think to enhance the unity, we should have one annual conference from East Zone Association. We are doing annual conference of all individual state associations. So we can decide to, it should be organized by one, just like Dr. Anjana Madam is now the patient. She will organize the next annual conference of East Zone. So there will be no individual state annual conference. There should be one conference so that we all be united.
No, I couldn't get you. What is it?
There should be one annual conference of association.
Separate one?
No, one, not separate. We will not conduct any body.
This is in association with Aprasocon. Last year it was West Bengal. You don't want that, you want that it has to be one annual according to president.
One thing. See, one thing is about many states. I think, especially you all mentioned about South Indian states also. I think for North zone also to some extent. And see, in South especially, many things they decide. Even politics are discussed in their general meetings.
Exactly, sir. That point I want to raise.
And they also support, this candidate is supported. That means majority will support. See, many seniors, they may like or not like, on principle basis they will support many times. So that should be done. And one more thing is, just one line I'll tell. If you conduct academic activities, that's the best way to break the ice and to make you interact with others, because you will be inviting people from other zones. So that will break the ice, so that mingling and interaction becomes much better, and they are your ambassadors actually. I must put it this way. They will talk to you about you. So in the conference, not only they will speak, we are also speaking. They will also come to know many things, what we are going to do, and that way it will be better. One simple rule, conduct academic activities as much as possible. So that I think will be going on.
Sir, sorry to interrupt. We have been doing those things like inviting guest faculty from out of state, and they are coming frequently to Odisha. Last 3 years we have been seeing that. And despite that also, the winning election is a number only, and there are a lot of politics going on, lot of politics going on. Sir, seriously we are making, not that we are doing workshop that Giri done three workshop in a year only.
No, that's okay, sir. No, we get your point, sir. That's the best way to establish yourself. You said that, even Rajan said the same thing, that we get some high-level workshop, maybe invite somebody from international faculty also, make it known that we are heavily into academics.
Sir.
Yes, Sunil.
Sir, my opinion is, for the time being, our East Zone Association, IJAPS, is not yet formed or at the premature stage. So let's segregate the politics from the academics. Let's not take any political decision at the IJAPS level. Okay, it's up to the consensus, like if I support, I thought that Honorable should go in front of me, I quit it. Or I thought somebody else should, he is a better candidate, I will. But let it be the personal decision. So let's not mix it with the academics. Let's focus only with the academics. I agree 100% with you. That we should focus purely on academics for the time being, till we at least mature. Okay?
Yeah.
Actually, what John said, question that I am not going to answer actually. Sir, as Sudi, actually we have debated. Actually,
Yeah. No, Ashish. He'll answer that. You were not there for the last two East Zone meetings, probably you're not heard. It was difficult to start one, but now we can start one. Anjana may probably start with the first one. We'll think about it.
I'll answer to
Because of all the consensus here, we will host an international level.
Bus first class.
Another last but not least, sir.
One point is, what is the aim, objective of an association? Is it only academic activities?
No. Both
that
are
is the
there.
biggest point I am to point it out. In Odisha, it is our responsibility as an association to make a rule and frame guidelines to secure our members in all time of problems. Suppose somebody is being caught, or the government is not properly, like I tell you in Odisha, for hair transplant, the government of Odisha has notified only plastic surgeon to do it. So in the central level as such, it can be reflected in that way. But I am seeing from the national level also, everybody is interested for a conference, then after everybody forgets, next conference, that president or vice president may not be there. So we do not want such type of associations where it is only based on one particular issue. There are so many other issues. I am talking as FC, do not have till today, have a permanent office where you can communicate legally or communicate otherwise also academically. I have talked with two secretary of FC, Dr. Parag and Dr. Arun Singh. There is no record at all of a FC till date, either in soft or in the hard copies. So what I mean to say, from that lesson I tell you the East Zone you are making, please make records of everything hard and soft copies. So do not just do mingle here and there. You will go away after one year. Some new secretary will now ponder what has happened. And every time we will go on repeating the same things. Please endorse everything officially so that it keeps on a record for future. Next generation will not blame you.
Okay,
Thank
sir.
you.
Okay. Concluding it, last but not least, that next East Zone Conference will be held with Bihar Association, Bihar Jharkhand Association in their annual conferences.
He is right, as per the rules are concerned, but we will change the rules as per Dr. Anjana's convenience. If you want to hold it to a big event, we will modify that.
That will be a separate event.
That
will
is
be a
separate. Okay, fine.
event.
The next Jharkhand meeting, all of you are called over for a good drink and good academics.
Okay. Okay, now we can wind up.
We will get back into the group, definitely. I'll talk to her, get back into the group. EC, okay, fine. So now in the nutshell, number one, that we got to work hard to bring more academics into it. Number two, we are planning to hold a separate East Zone conference. Dr. Anjana will take care, we'll be supporting her. Only, she won't work alone, we'll be supporting her. Number three, we cannot keep politics out of the group, that is for sure. We will discuss amongst ourselves in the group itself and come back to some conclusion for the next elections also. And since we already had 4 EC members for this year, can we have the nominations for those 4 EC members? And before we conclude.
No, the 3 will be continued, that
old
one, and 1 person will be a new one, that will be...
No, if we have 4 new. 4 new, let's have more people there.
4 news.
She'll be happier.
Okay.
From West Bengal, one Pathak from Jharkhand.
And from Odisha, you tell.
Odisha,
Giri.
1 person. Giri.
अरे तू है जा कौन है?
सोच के देखो. Okay, let be one more name from the, I'll get one name from the Northeast chapter. I'll ask those people. No, I'll get a name from
Northeast, I'll convince Kavita. So don't
get one name from there, that's about it.
Dr. Giri. We are doing it. Yes, sir, definitely.
Yes.
Sir, it will be shared in the group. So please group. Yeah. Yeah, I'll share it. Don't worry.
Fine. Thank you very much. My apologies for not being a very good president for the last 1 year. But believe me, I'll function better as a past president. And I help Dr. Anjana in a very, very big way. Thank you so much. Thank you all. And we must thank Dr. Sunil Raut and his team for a wonderful conference here. Please give them a big round of applause.
You want in the East Zone conference? Mane, whom do you want and what topics? And Calcutta, we are having the West Bengal chapter conference. You saw the flyer, and Dr. Venkat Ramakrishnan is going to march. So just the weekend after, no, not Surge, after Aprasocon.
Conference. Maybe within 5 minutes. Inaugural function is tomorrow. Okay. Will be done tomorrow. Tomorrow. Principal sir. No, please. Please everyone stay back. We'll have the formal inauguration of the conference.
ठीक अच्छे
Good evening, everyone. We welcome you all to the 10th Annual Conference of Association of Plastic, Reconstructive and Aesthetic Surgeons of Odisha. We shall now begin with the inaugural function. I request our Chief Guest, Professor Dr. CBK Mahanti, Pro Vice Chancellor KIMS and ex-DMET Odisha, to kindly come to the dais.
We now invite our guest of honor, Professor Brigadier Ambika Prasad Mohanty, VSM, Dean and Principal KIMS, to the dais.
With great pleasure, I now invite our President Apraso and Organizing Chairman, Aprasocon 2024, Dr. Sunil Kumar Raut, Senior Consultant Plastic Surgery, KIMS Hospital.
Now I request our Vice President Aprasocon 2024, Dr. Lakshmikanta Mishra, Senior Consultant and Plastic Surgeon, Apollo Hospital, to the dais.
I invite our Honorary Secretary, Apraso, Dr. Sanjay Kumar Giri, Additional Professor and HOD, AIMS, Bhubaneswar.
Now I invite our Organizing Secretary, Apraso, Dr. Bansidhar Mulia, Senior Consultant Plastic Surgery, KIMS.
And
I also invite our Co-Organizing Secretary, Dr. Chinmay Chiranjeevi Samal, Senior Consultant Plastic and Reconstructive Surgery, Health Village Hospital.
it's a great pleasure to welcome you all on this platform. I now request our distinguished dignitaries for the lamp lighting. I request our Organizing Chairman, Dr. Sunil Kumar Raut, for the welcome address.
Respected Chief Guest, Professor C.V.K. Mohanty sir, and our guest of honor, our Principal sir, Professor Brigadier Ambika Prasad Mohanty, and my colleague and dear friend, Dr. Lakshmikant Mishra, our Vice President of Association of Plastic Reconstructive and Aesthetic Surgeons Associations of ODISHA, and Secretary of our association, Dr. Sanjay Kumar Giri, and my Organizing Secretary, Dr. Chinmay Chiranjeevi. Good evening to everyone. It's my pleasure to express here that our we are completed 10th years of official registration of this August Association, for which we have been gathered here, and we are able to host a session of newly formed East Zone Association of Plastic Surgeons of India. So, first of all, I welcome all. We have three national faculties joined today with us. The senior most amongst them is our own family member, Professor Amresh Baliyar Singh sir, and he was the professor and head of KEM Hospital, KEM Medical College and Hospital, Mumbai, and previously in Sion Medical College also. And we have amongst us today Professor Dr. Rakesh Kane, who is Professor of Plastic Surgery in Safdarjung Medical College, and along with him, another senior faculty and a distinguished surgeon and academician, Professor Dr. Dinesh Kadam, who happens to be the chief editor of our Indian Journal of Plastic Surgery. So, there are senior members from West Bengal, Bihar, Jharkhand, and other part of East Zone also. I heartily welcome you all to this conference. From this conference, I have no doubt that we all will be immensely benefited in terms of technical skills, knowledge, and informations. I am very thankful to our Pro-BC CVK sir and our principal sir that for this organizing this conference, whatever help we have asked them, we just maybe just sent a mail and it is done. Rather, we got a call from the service people that for your conference this is ready, we have got this order, so just tell us what to do. So, thank you sir to both of you for your immense help and support to organize this conference. And their doors of the offices are always open for us, for me and my colleagues, Dr. Bansidhar and Dr. Nilamani. We all of them all have unitedly taken the effort to make it a success. So also from the association side, our honorary secretary Dr. Giri and Dr. Lakshmi, all the times they are with us. I will mention here specifically the name of Professor Dr. Sushant Mishra. I think he is here or not. So he shared the major burden from my shoulder. So see, he organized all the entire academic event he has organized, including making the scientific program, making the souvenir, everything. And today also he was busy here conducting the meeting. So without him, I think organizing this conference would have been a Herculean task. So it's already late evening, so I don't want to speak a lot, just a few things that I would like to mention about our department here in this institute. My colleagues, I just joined less than a year back, and myself and two of my colleagues, now we are 3 consultants here in the department, and in our department we are doing almost, we are covering almost entire spectrum of plastic surgery. We are doing trauma, we are doing hand surgery, we are doing a bit of cleft lip palate, we are going to about to sign the MOU with Smile Train to start the cleft program here also. And we are also treating whatever burn patients comes here, microvascular, onco reconstruction, everything we are doing here. So I hope with the blessings of our founder sir, Professor Dr. Achyuta Samanta, and he's a visionary leader. He leads from the front, and we all follow his advice and footsteps. Along with him, my respected principal sir and our Pro-Vice Chancellor sir. With all their blessings, I hope me, along with my colleagues, can take the department to a newer height. So, thank you again, all of you.
Now I invite Dr. Lakshmikanta Mishra, Vice President to say a few words.
Respected CBK Mahanti sir, I know CBK Mahanti sir since last 1989 when I joined in medical college. My father was admitted in medical college, means MKCG Medical College with pyrexia of unknown origin. And during that time, the PG students who were attending to my father, they told that the only doctor who can cure your father is the Dr. CBK Mahanti sir. And I know he is the encyclopedia of medicine. Sir, it's very nice that I am with you in this podium chairs. Second, respected Mahanti sir, Epi Mahanti sir, Sunil, Dr. Sunil is my colleague since last, we both are in the MKCG Medical College since 1989. Though he was in the SCP Medical College, I was from MKCG Medical College. But since post-graduation times, I know Sunil very well. And also during the period of MCS curriculum, both of us were studying for this MCS curriculum. And he selected in the PGI is Chandigarh, I selected in Safdarjung Hospital. And Dr. Sanjay Giri, he is the professor in AIMS Medical College, Bhubaneswar. Dr. Chinmay, director of Health Village Hospital. And my respected teachers. Today evening, actually I have seen since morning, today morning I have seen this presentation was excellent. And Sunil has done whatever the best possible till now. I have seen this, all these aspects of this conference was covered. The hospitality, this food, this academic, I think it is marvelous. And it is very difficult for me. He has covered all these things and I have to do excel in my next year program. And in 2025, I have to organize this in. And I will take definitely his guidance to cover all these aspects. And tomorrow morning, we have also very good programs on the PG programs and also the best papers. Hope we will enjoy. And mostly this East Zone teachers, means these respected delegates, the dignitaries are there. And I think we will enjoy this program tomorrow morning also. Tomorrow the final day. And I think this is already too late. And I conclude my speech. Thank you.
Thank you, sir. I now Secretary Apraso Dr. Sanjay Kumar Giri for the Secretary report.
Good evening, respected seniors. On the dais, CBK Mahanti sir, chief guest. He is our teacher, as already Lakshmi sir has told. He is an encyclopedia of medicine. I know when he was taking the classes, you go to that page number, this is there. At that time in Harrison, we have remembered in our class. Sir will finish the class in 15 minutes, but will tell you go to that page, and that type of teacher, sir, is there. So I think he is really encyclopedia. So Ambika sir, our guest of honor, and honorary president Sunil sir, under his guidance, we have done a lot of work in this year, which I am going to read out. And Chinmay, beloved organizing secretary, and Bansidhar, I think he is there for organizing the dinner. They both have fight for last, I think in a short time, one month, they have arranged a lot to organize this. And esteemed seniors from the East Zone, Anjana Madam, Anand Sir, Gautam Sir, Prasant Bhattacharya Sir, they are from there from morning. and all the delegates, esteemed delegates from the East Zone, and Amresh Baliyar Singh has also joined, sir has joined. So all my delegates and respected juniors, I'm just going to I welcoming you, all of you, for this Aprasocon 2024. I am very shortly, I will read out whatever the annual report, this is the customary to read out. We started initially from the month of January, the inauguration of our Bond Center in AIMS Bhubaneswar by our Honorable Minister of Health, Ashwini Mandavia, Dharmendra Pradhan. Then in the February month, we have taken from IMA House one permanent office of Apraso. So thanks to our Sunil sir, and there was a committee of by Arun Chaudhary sir who was decided, and we have taken one office from the IMA, newly building IMA House, one house for the IMA, for our Apraso. So this is in February. In the month of March, we have usually do bi-monthly meeting every 2 months, and it is done in the Bhubaneswar and Cuttack. So bi-monthly meeting was very successfully conducted by, in the month of March, by, in between March we have this annual conference is very successfully completed by Puthira sir and Rajendra sir in MKCG Medical College for the first time, and it has been done very successfully. In the month of May, Sushant has done the bi-monthly meeting. I think the MKCG it was a very fabulous conference, and it was first time done outside Cuttack Bhubaneswar, and 70 people have joined, and a lot of things has been done there. Then in the month of May, Sushant has done the bi-monthly meeting where Dr. Milind was in the Zoom meeting, and he has given a very good topic in the aesthetic surgery. In the month of July, we have a very good academic meeting done by Dr. Jayant Das and 5 of the faculty from the aesthetic parts, from the President Aditya Agrawal sir, and President, Secretary, Treasurer Rajat Gupta, Treasurer, everybody was 5 national faculty has come who have in one day have shown the A to Z video workshop of the aesthetic. It was an excellent workshop, and everybody has enjoyed that one in the month of July. And in the month of September, we have done, in the month of October, and we have done, Dr. Sujata Saravai has come, and she has given a good lecture in our bi-monthly meeting, and also the next day we have a very good awareness program in AIMS Bhubaneswar in the undergraduate people, where they do not know what is plastic surgery. To be frankly, I have seen they do not know what is plastic surgery, and it was excellent. Nearly over 150 people are there, and we have shown the grafting and to do it in the mannequins, how to do all those dressings and everything. Madam was there for one day. That is in the month of October. And in the December, we concluded it by doing the live brachial plexus workshop, where our present President Hari Venkatramani sir and Piyush Doshi has come, and we have done 6 cases of brachial plexus, which have been also done in the hybrid mode. So this is our whole year's activity. And in the last, if you will see, you must be knowing Professor Vibhuti Bhushan Nayak has got the Citizen Award, Odisha Citizen Award, the plastic surgeons, so which is the very good achievement for our association, because he is the first plastic surgeon to get this in health award. Then we have some good achievements by our residents, young residents. They have achieved very much good thing in this year. In ISHCon, from Odisha, we have 11 papers, and all are in podium papers. In APSICON, in Navicon, we have 7 papers. In APSICON, we have 30 papers this time. 30 papers, including posters. And out of this, 2 junior best papers have been selected first time from Odisha. Out of 9, 2 papers are junior best papers. So this is a great achievement for our Apraso. Then we have also then we have decided some achievements, like decided first time the presidential oration we have started, and I think in the morning Rajendra sir was the first person to give the presidential oration, which we have started from this year. We have also decided to appreciate those residents who are going abroad and giving the papers from our association. This should be given appreciation. This time we are starting it. And our vision for the next year is that to get the office full-fledged in IMA Cuttack by 2025. We have decided in the evening that by the end next January, where the next meeting is going to conducted by our President-elect Lakshmikant Mishra sir, we are going to make functional of this one. my functional of this Aprasocon office. This is our main achievement of this year to be done by 2025. These are the achievements which we have done. Besides this, about this conference, I just want to tell 2-3 words. We have seen the lecturers of Subodh sir in Zoom meeting, and Dinesh Kadam sir, who has come from a long distance, and also Rakesh Ken sir. That basic thing about the cleft lip palate and the craniofacial things which has been told, I think this will be very much beneficial to our residents. So that will make us a good thing to ask, to make a concept and do the things accordingly so that the young people can get benefited. So these are our achievements and which we have done. With this, I just want to conclude my secretary report and hope in the next year we would achieve some much more. And I hope all of you will enjoy tomorrow's program and also today's evening one. And at last, I also give thanks to Sunil sir and the organizing team who has given a lot of effort in a very short span of time to make it possible. Thank you.
Thank you, sir. Now I request guest of honor, Professor Brigadier Ambika Prasad Mahanti, to address the gathering.
Good evening, everybody. On behalf of me and all the faculties, staffs, and students of KIMS, welcome all of you to our institute. And also I like to thank to have invited me and my Pro-Vice Chancellor for this particular conference. Yes, what I have been thinking that why they have invited physicians is only because they hold some post. Otherwise, I think I am a misfit here. I am a physician, I am a professor of medicine. But I was surprised by a department of KIMS, that is the Department of Reconstructive Surgery and Plastic. Only 3 faculties to have organized this event which people are praising of. I was in the hospital at 8 o'clock today morning. I came this side. I saw Professor Sunil. He was going to details all alone. That shows his commitment to this particular organization event and his specialty. Respected Chief Guest, Professor Chinmay Vijay Kumar Mahanti. He is our Pro-Vice Chancellor, Professor of Medicine, former DMET, and all of you know him. The organizing chairman, Professor Sunil, I told. The organizing secretary, the Aprasocon Vice President, President-elect, Professor Lakshmikant, and the faculty from AIIMS Bhubaneswar, which I was a part of it sometime, is Dr. Sanjay. And the faculties who have come from outside, Dr. Dinesh Kadam, Dr. Rakesh Ken, Professor Padihari of the dais, his son Dr. Padihari, Professor Arun Chaudhary, he is a friend of mine. Then I just met Brigadier Sinha, who is associated with this institute. His son is sitting here. They may be the future in your footprints, and all the delegates. In fact, I was thinking most of these conferences are held in 5-star hotels nowadays, where you don't have to work hard. The companies will arrange everything. But usually in the auditorium, there will be hardly any audience, but evening will be full for several reasons. I remember in medical college of mine, that is SCB again, when a meeting was held in the college, the halls were full definitely throughout an evening, because it was full of students who wanted to see who have come from outside. Can I emulate them or can I be a part of them? This is changing. And I would have been very happy you could have asked me, not requested me to lend some energetic students to attend this also. It's not impossible. So I'll again thank you, but I'll also tell about this institute where I'm a part of it. I'm in so-called the School of Medicine for last 8 years, after serving in the Armed Forces 35 years and AIIMS Bhubaneswar for 2.5 years. KIMS is one of the 30 schools of the university called the KIT University. The KIT University is a dream of one gentleman called Professor Dr. Achyuta Samanta. You must have come to know him by now. He dreamt of two things in his life. One was the education to the underprivileged and the health care also simultaneously. So these two dreams he has fulfilled, he is going further. So-called the KISS is the only tribal university of the country and the world where students are given free lodging, fooding, education and subsequent employment. It was discussed in the parliament the other day, where government is planning to have a tribal university, but this gentleman has made it all alone. Coming to so-called the KIT University, the ranking is the highest in the NAC, that is A++, so the KIMS. KIT University has got a ranking of NRF of 16 in the country among all the universities, and KIMS is the 26th best medical college, including the government, AIMS and all that in the country. Besides that point, you must have realized private colleges can deliver. So that's why some change has happened, that people are coming to private colleges, even the patients now with different type of insurance schemes. My experience of so-called the plastic reconstructive surgery in SCB, when I was a student, there were only 2 faculties. But they used to work very hard because a lot of cases of burns used to come. Other things were not that a majority. Then I had gone to Delhi to work in AIMS sometime. The department of Professor Dinesh, that was actually headed by one Professor Gupta those days. One of the best institutes of the country. My roommate, he used to go there as a JR, he used to go in the morning, come next day afternoon and tired and sleeping. The quality of care was superb. People from all over the country used to go there. Even the armed forces also, reconstructive surgery is quite good. We used to have a skin bank in one of the command hospitals where I was heading that hospital. But over a period of time, this department, so-called the plastic surgeon, reconstructive surgeon, so-called the aesthetic surgeon, cosmetic surgeons, I think this is a requirement. Management of burns is a quite sort of difficult, long-time affair. But now people are looking to this group of specialists who can deliver the best, who have got their own training, own interest, and that is why this particular society is the sort of the requirement of the hour. And again also I like to thank Professor Sunil, Professor Mulia and Professor Nilmani Mohanty. They are also part of us. They are going to start the MCH program, which was overdue actually, and I think that will come in maybe few months or 1 year. And with this, I like to end my talk. Again, thanking you to invite me, and being a part of this university or the college where I have been here. The last request maybe, in case you have got time, those who have come from outside Odisha or something, they can go around the complex. If you go, then you realize what can be done by a single person, all that what I have described. Just in case you don't have time, spare 2 minutes, just across this road, there is a 7th floor building, one of the central library of the university. Once you go, you will realize one of the best in the world. You will realize when you go across. That is my request. Spend some time besides your all activities, all that thing. And wish you all the best. We have been halfway. Tomorrow is another day. Please enjoy and be a part of it. And thank you so much for taking sort of our institute as a place of your conference. Thank you.
I now request Dr. Anant Kumar Sinha, President, East Zone Association of Plastic Surgeons, to kindly speak a few words.
Thank you, sir. Members on the dais, off the dais, I'll just take 2 minutes. Sunil has been very nicely saying that because of your blessings, he's been doing all these things. Let me tell you one thing. You are sitting in a meeting where most vibrant society of plastic people are there in the Eastern Zone, the Odisha chapter. Dr. Arun Kumar Chaudhary, sir, he deserves all praise for that. He has raised a bunch of very committed individuals here. So from entire East Zone, let's give them a big clap to the entire chapter of Odisha. He wouldn't talk about himself, so we have to talk about him, sir. Thank you very much for calling us here, sir. We have really enjoyed, sir. Thank you.
With great pleasure, I invite our chief guest, Professor Dr. CBK Mahanti, sir, to speak a few words.
Respected guest of honor, Professor Ambika Prasad Mahanti, my senior and dean and principal of these institutions, KIMS, on the dais. Respected President of the Aprasocon, Dr. Sunil, Secretary, Dr. Giri, Dr. Vansidhar and Chinmoy, and of dais. The President of the Association, National Association, Professor Sinha, other national faculties, Professor Boliyat Singh, and my teacher, Dr. Ramesh Chandra Das, a versatile surgeon. By qualification, he was a plastic surgeon, but practically his ability to do all sorts of surgery. He is not restricted to his plastic surgery practice. And Professor Chaudhary, my friend, delegates. To start, I'll say that I am the odd man out. Because I am a physician, as my principal told, or dean and principal told, he is also physician. We opted for this subject because we are afraid of holding a knife during our early age. Yes. Before me, you all giant personalities in the field of plastic surgery are there. Just imagine, the plastic surgery is one of the oldest branches in the surgery. That is described much before the birth of the Jesus Christ. But what is the present status? By this time, the science has advanced, many techniques or skills that have been advanced. But how many plastic surgeons are in practice in India? It is because this branch is lucrative, is a paying branch, but is a risky branch. Accountability is very high. Just imagine, many things that can be dealt with plastics by the plastic surgeon, they are not even covered by the insurance policy. Just like aesthetic surgery or cosmetic surgery, so to say, they are not covered. The premium for professional indemnity, you just imagine, that is probably the highest. That speaks about the risks. And for everything you are accountable, because that involves the cosmetic appearance, which in turn is involved with emotions. Emotions. For that reason, I must appreciate, or I must thank all of you that you have opted for this risky branch, which can bring smiles to in the face of the patients as well as the face of the relatives. But still it is risky. Just imagine, suppose a cosmetic surgery will fail, what will happen to you? But still you do pursue this practice. So about plastic surgery, this is my knowledge, that it can be reconstructive So another important field in your domain is the management of the burns. India, having a population of 1.5 billion, how many burn centers are there in India? How many plastic surgeons they are fully dedicated for the burn cares? The incidence or prevalence is not less. At least 6 to 7 million persons they do suffer from burn injuries. 50% will require hospitalizations. So at least to some extent they can be managed. They will attend hospitals and 10% will have severe burns, out of which at least 50% will die. That is the statistics. And to manage such a large number of cases where hospital stay is expected to be very long, bed occupancy is expected to be very long. How many beds, dedicated beds are there in India? It is again not more than 1100. In 2020, it has been estimated to be 1031 dedicated ICU beds. That is just pitiable conditions. The national program has been launched since 2013. But what is the result? The main objective or goal was to increase the awareness, to develop infrastructures, and for better treatments or managements. Similarly, for burn injuries, skin bank is one of the essential components. But how many skin banks are there in India? In Odisha, at least one official skin bank is there in some hospital. So another private hospital. In government sector, that is not a single. Although Professor Chaudhary had tried a lot to have a skin bank at SCB, the oldest and most premier medical college of the state. That speaks about the apathy. This management protocol or this program is in the files, so to say. So practically in India, how many burn centers are known, widely known, where facilities are available? Probably, to my knowledge, 2. Which is fully developed burn center. One is at Safdarjung Hospital, another is National Burn Centers at Mumbai, where in recent past, one of my patients was referred and finally, unfortunately, she died. But at least the relatives were satisfied because there was a facility for comprehensive care. So this association that has been formed only 10 years back, young, but there are so many stalwarts like you in the field of plastic surgery. Can you take a mission? Because that is the call of the day, that we have to develop large number of burn centers, and as per the plans and programs, the burn service should be extended down to the peripheral hospital, let it be secondary hospitals or tertiary care hospitals or referral hospital like CSC, etc. And patients must be managed by trained personnel. Trained means not necessarily they will be plastic surgeons. Surgeons can manage if they will be trained in a better way. It is because we cannot create so many of plastic surgeons overnight, over years or 2 years, whatever it may be. And this is the requirements. Next, cosmetic surgery. So nowadays the patients, they are opting for cosmetic surgery, etc. So that must be complied. Next, life-saving emergency like facial-maxillary injuries or craniofacial injury, they must be managed effectively. Otherwise, time is most precious. Interventions must be done in time and rightly. And that is the job of the plastic surgeons. Again, limb transplantations. When I was a student, undergraduate student, about plastic surgery, I had an idea that they do only surgery like cleft lips or cleft palate. Subsequently, Dr. Vibhuti Naik, who now heads the department of plastic surgery at SCB, joined, and they started doing limb transplantations following injuries. And successfully they transplanted. So at that time, my idea about the plastic surgery changed, that they can do many things. Many things. So this is all my ideas or knowledge about your subjects. And I request that please get involved in injuries cases, particularly craniofacial injury or other injuries. Timely attendance is important when question of salvage following injury will be there. So attend times, be sincere, and attend to the call. And take it as a mission to develop burn care facilities across the country, at your level, at your association level, and see that national program will get through and that will reach all citizens of the countries. So lastly, I'll thank all organizers, because although I am a physician, they have invited me to be the chief guest. And I will also again thank all the delegates, faculties, national faculties, my teachers, my friends, and all dignitaries on the dais, that their presence has made this function successful and memorable. Thank you.
Thank you, sir, for your encouraging words. I invite Professor Dr. Sushant Mishra, Editor Apraso, for release of the conference souvenir. I invite our immediate past President, Professor Dr. R.P. Das, to come to the dais.
Sir has already given the oration he has to be given.
I request our chief guest, sir, to felicitate Professor Dr. R.P. Das. I now invite Professor Dr. Ramesh Chandra Das, Senior Plastic Surgeon of our state and past President of APRASO, to kindly come to the dais. I request our Chief Guest of Honor, Professor Brigadier Dr. Mahanti Sir, to felicitate Dr. Das.
This time we are giving to Ramesh Das sir the felicitation. Sir was born on 15/2/1951, son of the late of Mr. Narendranath Das and Srimati Devi in the village Dhandi, PS, Rajnagar district, Kendrapada, Odisha. Passed the matriculation with scholarship from MN High School, Potamundai in the year 1968. Passed first year science from the Ravenshaw College in the year 1970. Joined MBBS course. Passed in the year 1975 from MKCC Medical College, Barampur. Then did his MS General Surgery from SC Medical College, Cuttack in the year 1980. After 10 years, completed the MCH Plastic Surgery from BHU in the year 1990. Service period, sir has joined in the state government health service in the year 1979, worked in the different peripheral hospitals of the state of Odisha, then joined in the Department of Plastic Surgery, SC Medical College, Cuttack, Odisha, left government service in the year 1996 in order to work as a freelancer, since then working non-stop without looking back till date. Memberships in different association, life member APSI, ASI, IMA, Indian Society for the Surgery of Hand, Breast Surgeons of India, Hernia Society of India, Asia Pacific Hernia Society, Cleft Lip and Palate Society, Reconstructive Microsurgery Society, Gastrointestinal Endosurgery, Telemedicine Society of India, also AMASI, and also the National Academy Burns of India. Presentations, different papers for the years together in various national and state level meetings. Past positions, executive member of Hand Society of India, President ASI Odisha State Chapter Odisha. Then present positions held President of Vidya Vikas Samiti with more than 120 affiliated schools in the state of Odisha, empowering children with the Bharatiya ethos. President of Charak Swasthya Seva Prakalp, Odisha, with an aim to serve every village with trained boys and girls in primary health care. Executive member of Utkolika Bharatiya Kuntala Kumar Savak Foundation, executive member of Nari Suraksha Parishad. Voluntary services, cleft lip and palate surgery in Smile Train program for 3 consecutive years in Chhattisgarh and Odisha, doing free consultation and surgery for years. Free recanalization in cases of parents lost a child. Achievements, fast free tissue transfer of radial artery forearm free flap for lip reconstruction in 1995 with Dr. Subrat Jena sir. Fast monoblock advancement in craniostosis teamed up with Professor Vibhuti Bhushan Naik and Professor Sudhanshu Mishra in 1997. Fast double hand transplant teamed up with Vibhuti Naik sir and Professor Anudha Patnaik. So oration sir has already got Professor G.S. Das Mahapatra oration in ECON State Chapter at Puri. Sir, the executive committee and members of APRASO consider it a great opportunity to felicitate you on this auspicious occasion of 10th Annual Conference of APRASO 2024. We wish to see you every day as cheerful, joyful, and have healthy long life. Thank you.
Faculty Dr. Dinesh Kadam sir to kindly come to the stage. I request our chief guest to honor him. I now request Dr. Rakesh again sir to kindly come to the stage. I request our guest of honor to felicitate him. I invite Professor Dr. Amrish Baliyar Singh sir to kindly come to the dais. I request our guest of honor to felicitate him. I now request our President Dr. Sunil Raut sir to felicitate our chief guest, Professor Dr. CBK Mahanti sir. I request our Vice President sir to kindly honor our guest of honor. Thank you, sir. I now invite Dr. Debesh Rao, Joint Secretary, Apraso, to the dais to read out the names to be appreciated by Apraso.
Singh and MKCG team in recognition of the organization of March Aprasocon. So please come to the dais. Dr. Sushant Mishra and SOM team in recognition of May bi-monthly meet. Dr. Joyan Das and team for organization of IAP's video workshop in July. Dr. Sanjay Kumar Giri and AIMS team in recognition of October and December bi-monthly meet and brachial plexus workshop. Now the residents, Dr. Ishan Agnihotri, for presenting best paper in Aprasocon 2023. Then Dr. Deepak Kumar Sahu for e-paper in Aprasocon 23-9. Dr. Surya Malik for presenting paper in Aprasocon. Dr. Vishnu Swarup Reddy for ISKCON 2023. Dr. Priyanka Pant is there. Dr. Vishnu Swarup Reddy for presenting paper in ISKCON 2023. Dr. Priyanka Pant for presenting paper in Aprasocon. Dr. Akanksha Rajput for presenting paper in Aprasocon and Navicon. Dr. Gopika Jit for presenting paper in Aprasocon, ISKCON and Navicon. Dr. Ahana Bandopadhyay for presenting paper in ISKCON. Is it the hands?
Organizing Secretary Dr. Chinmay Chiranjeevi for the vote of thanks.
Thank you, Dr. M. Lopamudra. Good evening, respected Professor Dr. CBK Mohanty sir, our chief guest tonight, Pro Vice Chancellor KIMS, and our guest of honor, Brigadier Professor Ambika Prasad Mohanty sir, BSM Principal KIMS, Organizing Chairman Dr. Sunil Kumar Raut, Secretary Apraso Dr. Sanjay Giri, Vice President Dr. L.K. Misra sir, Apraso and my respected seniors and colleagues. First of all, I'll thank to Dr. Professor CBK Mohanty sir, Pro VC sir, and Brigadier Ambika Mohanty sir to grace this occasion out of their busy schedule. Thank you again, sir. I'll thank the senior members of Apraso, Dr. Ramesh Das sir, Dr. Baliyar Singh sir, Dr. Raju Das sir, and to bless us. Thank you all the invited speakers, Dr. Dinesh Kadam sir, Dr. Rakesh Ken sir, to join here adding value to this academic fiesta. I thank to all the members and the speakers from East Zone to join and adding value to this event. I will thank all the members of Apraso to present over here making this event successful. I will thank the organizing team, Dr. Sunil Kumar Raut, the organizing chairman and team leader, Dr. Susan Misra, Dr. Bansidhar Mulia, Dr. Sanjay Giri, Dr. Sudha, Dr. Lopamudra, and all the organizing team members for their tireless effort to make this event a great success. I'll extend my special thanks to KIMS and KIT management, the maintenance department, Mr. Dilip Jena and team, hospitality department, Mr. Anil Panda and team, IT department, the media cell for their timely support to make this event successful. Nonetheless, and in fact very important, the support from all the sponsors and timely support from the for this successful completion of this event. Lastly, I'll thank all support staff for their help, without which it could not have been a success. I know I have missed many names, and so sorry for that, and kindly bearing me for the speech. I will request you to join us for the gala dinner tonight at the Rose Garden KIT campus.
भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Everybody present in the audience.
रिफ्लेक्टिंग सरफेस है